had completed basic nursing and post-graduation from CMC Ludhiana and PGI Chandigarh, and also have won gold medals in both and obtained her PhD nursing by a comparative study on women's health, and also has done postdoctoral study on perceptions and experience of motherhood after 30s in collaboration with Karolinska Institute, Sweden. Ma'am has more than 50 years of professional experience on nursing or midwifery practice, academics, research, and administration. Ma'am is a recipient of various awards and honors. I would like to list few of them. Hall of Fame by Nursing Honor Society of India and the Award of Global Excellence in Natural Birthing by Institute of Holistic Medicine, Indore. Ma'am had been resource person for UNICEF OS8 projects. Has also launched an Indian Journal of Nursing Studies in 2010. Through her long association with SOMI, that is the Society of Midwives in India, since its early days, ma'am has conceptualized the midwifery model of care and set up a midwife-led alongside Natural Birthing Center at the Choitram Hospital Indore to demonstrate ideal midwifery services. And ma'am is also a prolific writer and has presented more than 100 research papers in national as well as international conferences, and also have published various research papers in the journals. Ma'am has launched her own publication house named Mullik Publications, where the Indian Journal of Nursing Studies is published regularly twice an year, and also ma'am's book named Nursing Epiphanies was brought out in 2021. Ma'am is author for one more book on mothers and midwives named Miracles of Motherhood, The Way to Natural Birthing in the year 2022. We are privileged to have you, ma'am, as a moderator for this session. I would also like to introduce our distinguished speakers for today for our first session, who will be enlightening us on the evolving frontiers of nursing research. We are very privileged to have Dr. Asuma Bivi ma'am to conduct the first talk on multidisciplinary research. Ma'am is having over 40 years of experience in teaching and research administration as well as clinical nursing in India as well as in abroad. Many publications and patents have been listed in ma'am's career. Ma'am has authored around 8 books, 5 copyrights, and ma'am has been reviewer as well as ma'am is an editorial board member in reputed journals. And ma'am has achieved Best Principal Award in the year 2022, Asian Education Award in the year 2020, Best Teacher Award, Mother Teresa Sadbhavana Award, and Best Citizen Award as well. Ma'am has guided around 203 MSc students and 8 PhD scholars as well. Ma'am has served on curriculum and academic boards of multiple universities and is recognized nationally and internationally for contributions in nursing research and education. Ma'am is presently the president of NRSI as well as the director of Aster MEMS Academy, Kerala. We are privileged to have you, ma'am, as a resource person for this session. Followed by ma'am's session, we'll be having the second session on implementation research by Dr. Anil Sharma, sir. Sir is having over 16 years of experience in academics, clinical practice, and health research. Sir is having more than 50 research papers published and guided over 10 PhD scholars. Sir is leading 2 ICMR-funded public health projects on cancer screening and WHO ANC model. Sir has authored textbook chapters in medical surgical nursing. Sir is Vice President of Nursing Research Society of India and has designed critical care nurse SOPs for Indian hospitals as well. Sir has contributed to national nursing curriculum for BSc as well as MSc courses, and has been a speaker and resource person in more than 65 national and international events. So we are happy to have you here as a resource person. We now have our deliberated session on Delphi technique that will be presented by Dr. Priyanka Bansal ma'am. Ma'am is having more than 16 years of experience in nursing education, research, and clinical practice. Ma'am has over 27 research papers published in national as well as international journals. Ma'am is the editorial board member of International Journal of Community Health Nursing and Practice, and also International Journal of Nursing Science Practice and Research. Ma'am has won awards for scientific papers, as well as ma'am is a certified diabetic educator and A-grade mountaineer also. Former convener of Red Ribbon Club in the Delhi State AIDS Control Society. So ma'am is presently the Chief Academic Officer in New Delhi. Ma'am, we are happy to have you here as a resource person. Over to Dr. Usha Okhande, ma'am, for the moderation session.
Good morning, and this is our first session of NRSI 29th Conference of Nursing Research Society of India. Now the name is slightly changed, but NRSI stands NRSI. I welcome you all on behalf of NRSI as a senior person and advisor at the moment for NRSI. And it's a privilege that first session is mainly conducted by the senior most people from NRSI on a very on the theme that we have, that is latest trends. I'm sure you all will appreciate the effort they have put to prepare their presentation, and there can be questions later on. So I welcome all the speakers, three speakers sitting here, Asuma Madam, Anuj Sir, and Priyanka Ji, and all of you who are sitting over there. Let's start it. I request the speakers to, two speakers to please go down. Asuma Madam can stay back, who is going to start the first session. These people have already introduced the speakers to you. So over to you, Asuma Madam.
Jai Hind. A warm good morning to one and all here. Uh, the theme of 29th National Conference is Emerging Trends in Nursing Research. The first one, we are starting with a panel for these emerging trends. We talk about collaborative research is one of the emerging trends in nursing research. And I will be talking to you on multidisciplinary research in nursing. Okay, I'm coming from this place. Everybody was telling me, introducing me as director of Astromims Academy. I'm not the director now. I was the director. I'm Dean Astromims Academy now, and I'm coming from this place. And I will be talking to you, as I said, about multidisciplinary research. This will help in advancing healthcare through collaborative science and integrated experiences. When we talk about this multidisciplinary research, the major portion which is given there, this advances healthcare and also through collaboration and also integrated science, because In multidisciplinary research, we include many professionals, healthcare professionals from various fields like, for example, medicine, surgery, or community health, or epidemiology. Like that, so many things will be combined to make better results or better patient outcome. That is why now the emergent trend is talking about collaborative research. And multidisciplinary research is one part of collaborative research. See, evolution of nursing research, when we think nursing research is expanding beyond traditional, sorry, something happened with this thing. Okay. Expanding beyond traditional discipline boundaries, embracing collaborations with diverse health sciences to address complex healthcare challenges. The shift reflects growing recognition that today's healthcare is or today's complex healthcare problems requires an integrated science or collaboration between different professionals or between different professions. That is why we will be using the multiple disciplinary expertise in this. So the four important areas when we think about evolution of nursing research, we were compartmentalized earlier. Nursing means nursing only. We will not be sharing our knowledge to somebody. Though we came from medical model to a different model later, where we went for a amalgamation of different models together, and our curriculum has been developed in that way. First, nursing started with medical models. Now we can see that we have gone to collaboration that has given us shared goals. That again helped us to utilize different expertise from different types of professions or different health professionals. And finally, we have got an integrated perspective that result in better patient outcomes. So when a little bit about collaborative research approaches, we can see that collaborative research includes these three important areas. One is multidisciplinary, second is interdisciplinary, third is transdisciplinary. When we talk about, I will be dealing only multidisciplinary, but to tell you when it comes to interdisciplinary, in the nursing itself we have different specialities. We can have these together, conduct a research, then it is interdisciplinary, or again medicine and nursing, interdisciplinary research can be possible. Then we have transdisciplinary. A nurse do a research along with a sociologist. A nurse do research along with a psychologist. Then it is transdisciplinary. I hope you understood. So collaborative research has three wings, that is multidisciplinary area, interdisciplinary area, and transdisciplinary areas. So multidisciplinary research matters in nursing. Why it is important for us? The complete health problems demand holistic and multifaceted studies. So that will help us to find out different perspectives of a problem that will result in a better patient outcome. Then it expands the scope and real world impact of nursing practice, then bridges the gap between clinical care, research, and policy, enhances nursing's voice in shaping healthcare system. This is very important because if you stay compartmentalized in nursing itself, people will not know about you. Nurse is nurse. Like that it will go. But the voice of nurses can be taken up when we have interprofessional collaboration or interdisciplinary research or multidisciplinary research, and we will be talking or we will be contributing in a research in that area. People will come to know about nurses caliber, capacity, and they will take up our voices. That is how we have grown. to this extent in nursing now in India. Because when when it was compartmentalized and the nurses were, oh, nursing care is this much only, giving for that patient-centered care, like, or you may be remembering, I don't know, the younger ones in the artificial intelligence era, they may not be knowing about how nursing has developed in India. Because when I was a student, I remember we used to learn needs or problems. A patient may present with a need or a problem. A nurse may identify a care plan with these needs or problems, how to resolve this need and problem through nursing care. That is all what we were doing as a framework of practice. Then came the Ura and Walsh writing on nursing processes, and we have that 4-step nursing process, 5-step nursing process. Now we have lot of other uh, a lot of other areas have come with each one. We know that now intervention science has come. In nursing intervention, ideas have come with so many independent nursing interventions. So the change has come to make nursing as a scientific profession. It has grown so big now. And this collaborative research and that will again take you to heights of nursing science, and the profession will grow very rapidly. That is what we need. That is why we talk thus emerging trend, multidisciplinary research. Then key drives for multidisciplinary research. This is for the younger ones to find out areas for practice or areas to do research in. Which area you can go for a multidisciplinary research? You can talk about. You can go for an aging population. Take up demographic shifts require integrated geriatric care models, combining nursing, pharmacy, physical therapy, and social worker expertise. So you can have all these professionals to do a research for how to care for aging population, and there is a shift in aging population. We know if you take the smallest state of one of the small states of India, Kerala, you will see most of the houses there are no people, and all younger ones have been migrated to some other countries, Europe or US, like other continents, Canada, Australia. And what happens is the homes are left with only old people. Most of the houses are with geriatric population. Who will be taking care of them? They need a very good model for identifying how to care for these people. They have contributed their life for us. So we have to take care of them in a better way. So we can have a research, multidisciplinary research in this area with this. This may happen to other states also very soon. When it comes to people, younger ones with lot of opportunities outside, their lifestyle has changed. They may be going also Kerala, because their education status was very high from the very beginning. Younger population started migrating to other states of India as well as to other countries of the world. So this happens everywhere, and we have to have better care facilities for these geriatric people. So multidisciplinary research may help us to find out better models of care for this geriatric population. Then again, you can think about younger ones also. We know that 40% of India, young India, we should say. So this younger population also require care models, and you know the Gen Z children, their attitude is entirely different from what we. I'm a senior citizen. You people may be below that and that. So you may be identifying the transitions of life changes happening. So in that area also you can do multidisciplinary research where you can have pediatricians, pediatric nurses, community health nurses, then psychologists, educationalists, how to train them, how to give them good skills and make them better citizens, and the influence of social media. All these need to be taken care and look into it. So these type of studies require multidisciplinary research to find better models. So we can go for uh, multidisciplinary research in this. And then technology integration, I need not tell you, because you are younger ones, you are always in uh, mobiles and social media with YouTube. you know how many types of things you uses, how many apps are there. All these will help you to find out all these things. Then emerging infections and re-emerging infections. Emerging infections, we have seen in COVID what happened to us, and how many important people uh, given their life because of COVID. We know so many important people of India have lost their lives during COVID. So this is emerging infections. How to combat these emerging infections? We need to have multidisciplinary research in these areas, because now there will be microbiologists, there will be nurses, there will be physicians, surgeons, psychologists, all people together. If each one has to set their own goal, that is only, and each one has to decide what design and what strategy they will use for the research. Then core nursing functions in these areas in multidisciplinary healthcare. We know that we provide direct patient care, then care coordination, health education, and patient advocacy. All these roles we have to define when we are doing a multidisciplinary research with somebody, some other professionals. What are your role? And what strategy you will use, or what design you will use, what type of research you will use, or methodology you will use in collecting data for your goals. That has to be decided. Then you can have the advantages of multidisciplinary research. It improves research quality, broader perspective, enriched studies design, stronger evidence base from diverse methods, and greater innovation through cross uh, pollination of ideas. This is very important. Cross pollination of ideas, when we say, we have learned cross pollination in plants. Uh, Here also, cross pollination of ideas. When we share ideas and network with other people, we get better ideas. And we may be able to polish our ideas for putting up for the research. Then health system, definitely multidisciplinary research will improve health system, because so many professionals come together, they keep up their perspectives, and finally they make a model that will help you to cater the patient needs of diverse populations. Then evidence of impact, we can see multidisciplinary research gives better evidence. And you can see this collaborative terms of nurses, teams of nurses, oncologists and psychologists have developed integrated care models that addresses physical symptoms, treatment side effects, psychosocial needs, improving both survival rates and quality of life of cancer patients. Then global recognition has come. WHO endorses multidisciplinary care models as best practice. Then research demonstrates improved outcome for chronic diseases, and international collaborations advancing health equity. Then pediatric chronic illness management, there's partnership with nurses, dietitians, and physiotherapists, create comprehensive care plans for children with conditions like cystic fibrosis, diabetes, resulting in better adherence and developmental outcomes. I have seen children with cystic fibrosis from different regions of the world, how this multidisciplinary team is providing care to them, and their survival rate has increased, and they live uh, like they lead a normal life. I've seen cystic fibrosis children for continuously for about 12 years, a child, and now the child is about 22 years, doing well, and usually this is the most lethal disease in pediatrics when we talk, because of the lung problem they develop with cystic fibrosis. But now with this multidisciplinary research, people have come with the good food, what food can be given, which food will reduces mucus, which will food will give expansion of alveoli. All this has come with the research, and now the cystic fibrosis children's lifespan has increased. So that type of studies can be done. And again, A lot of endocrinology diseases like type 1 diabetes, diabetes insipidus, all these we can see that multidisciplinary research has helped to improve the life expectancy of children as well as their uh, quality of life. Then, then again, summary of effectiveness, just these terms which are bold in the PowerPoint is very important. The multidisciplinary research consistently improves outcomes at 3 clinical levels. These 3 clinical levels you must remember, that is one, the first one is patient care, because the major responsibility of nurse is direct patient care. So here the first one is patient care, second one is research quality, and the third one health system performance. Then pathways to participation for nurses. Nurses can be a primary researcher in multidisciplinary research where she proposes the first ideas and come up with other team, and she proposes her first objective and first modality or methodology for designing this study, and others may collaborate with you or coordinate. Then nurse as a coordinator for a research also can be done. These are the two pathways for participation or in multidisciplinary research. Then essential skills for research collaboration. Students who are here, please remember these skills must be developed for a multidisciplinary research as a team member or as a coordinator or as a primary researcher. You should have critical thinking, you should have communication and teamwork skills, and you should have research literacy. That is a very, very, very important area, how to do a research. Anybody can do a research because a thing is there in the world. We are researching, just researching. It is there somewhere. We have to identify where it is with facts and figures. That is so anybody can do research. It is not a big thing. You should not think that how can I do a research? I'm a nurse practicing in clinical area. I did my BSc only. Oh, I did my diploma only. No, everybody can do research. We had a teacher. He is no more. Dr. Soman was there. He was a biochemistry professor in one of the medical colleges in Kerala. He was my teacher for biochemistry. So he made an association that action research for people's health. So he used to make even the people who are auto rickshaw drivers, like those ladies sitting in the market, were caught hold and taught what is research and made them to do research. And people's action for research has come up as a big turnover, like in developing research knowledge among public. So anybody can do research. That is what I want to tell you. Only thing that you should have research literacy. Then leadership. These 4 qualities or skills are essential for multidisciplinary research too. These competencies are not innate. They can be developed through continuing education, mentorship, and practical experience. That is why, as Florence Nightingale said once, nurses have to have compassion. This compassion is a tutored compassion. What is tutored compassion? We say nurses should be compassionate. Everybody will not be compassionate, no? When we are born, everybody will not be compassionate. Some people at family, they develop certain skills of compassion. But when they come to nursing, we teach them compassion. That is called tutored compassion. The same way, in research also, research must be tutored. The teamwork should be tutored. Leadership should be tutored. So you have to have these skills through tutoring or through learning. Then many healthcare institutions now offer research capacity building programs, specially designed for nurses interested in collaborative scholarship. So getting started, how can we go ahead? So identify a problem, then develop a research team. Once you identify the problem, you know that who all are needed in this research. Then you develop the team with all these people, and then each one have to define their objective. Each team member have to define their objective in their area, and then these may be amalgamated to make shared objectives. And later select appropriate design and go ahead with the research. Then your next one is multidisciplinary research is not just for academic institution. It begins with curiosity, collaboration and commitment. Every nurse can contribute to advancing healthcare through research partnership. So I request all of you to think about multidisciplinary research as one of the best emerging trends in nursing research. And I conclude, thank you for listening and hope people will come up with a multidisciplinary research team in each institution. Thank you.
Thank you. Thank you, Dr. Asuma. Um, every slide had some message. Every slide had a message for youngsters, especially how to take a topic, how to go about collaborating with other disciplines. So well explained, so simply explained. Thank you indeed. And I'm sure we are going to take many messages from your talk. Thank you. May I now invite Dr. Anil Sharma, and I welcome Chandigarh team and Gopi ji. So nice to see you all. Please go ahead.
Yeah, ma'am. May I? Yes. Good morning, everyone. May I get a little response from the audience? Okay. Okay. Jai Hind, all of you. Thank you. Can you please switch off the lights? Okay. See, the topic which has been given to me is an implementation research. Now, this implementation is a really a very common word for all of us, right? We write nursing process where one of the important step is an implementation. So how this implementation research is really working? So my job is to make you aware about the implementation research and what are the possibilities we have to do the implementation research. May I get the slider, please? Okay. So this 20 or 25 minute of presentation will have only three messages, or the flow will write this, that let me first tell you what is implementation research. Then we will answer only three questions. That's first, what it is. Then why do we need it? And the third one is important, how do we do it? And then one slide of take home message to make you very easy that what it is, the implementation research. Any research, when we talk about, few things always comes to our mind, but let me brush something to you, a recap for the researchers. This slide is very common. I hope all of you are aware about it. This is the research designs. Yes or no? How many of you have seen these kind of slides earlier, where we have quantitative, qualitative and mixed method we used to say. In quantitative, experimental, we say it's a gold standard. We invent something, right? In non-experimental, these are really important research for the public health. We do call as informative research, because these are the research designs which create the policies for the nation. Either you call as a descriptive, cross-sectional, case control, cohort. Every of these designs are so important. But our implementation research is not fitting to this. You are aware about the experimental and non-experimental, qualitative and mixed method. When we talk about the research, of course, these all will fall, but not as an implementation research. Then what it is? I'll give you an example. I hope that example will make it very clear to all of you. How many of you know about the tuberculosis program which India has? See, it started in 1962 when the name was National Tuberculosis Control Program, right? And then in 1992, there was a review by the government identified, and they reviewed and they find that it's not matching the objectives for which this program was implemented. So they revised the program, and then the new program came named as a revised National Tuberculosis Control Program. I hope all of you are aware about it. In 1997, and in that only they implemented DOT strategy. That's a direct observational treatment, right? And then it went like this. They wanted to reduce because India is heavily burdened with the TB. In 2020, again, there was one more revision in that program, and that program is National Tuberculosis Elimination Program. These three are same, but the intervention among these three programs, the methodology of all these three are different. Now, why this is required? Why don't we say that National Tuberculosis Control Program itself can modify it further and given like this only? Why the modifications are required? Then this comes to my mind how and why it's done, why these programs being changed frequently by taking the feedback from all the stakeholders. Answer is implementation research. So when I do talk about implementation research, implementation is what? When you have something in your hand. Let's say in research we say we are going to invent any intervention, we are going to test the intervention. That's what we say in the experimental research, that we wanted to test the hypothesis. Now testing hypothesis means what? You are actually looking for either creating an evidence or strengthening an evidence. But implementation research is furthermore. In implementation research, we have evidence in our hand and we wanted to see how it's working for a major area. That's how it's known as an implementation research. Let's understand the definition. First definition, I say it is Chatur's definition. Three Idiot. How many of you have seen that? All of you? It's a book language, so typical to understand. But when I say the second definition, it is Jhanjar's definition. Very simple to understand. So I'll come to that point only. It's an implementation research looks what? The barriers, the facilitators, and the strategies that make an intervention successful, feasible, sustainable, and the most important for the implementation research is scalable. Implementation research used to done to scale up the evidence which is already exist. Let me repeat. Implementation research we used to do to scale up the evidence which is already exist, and that's what known as an implementation research. Now next, in a very simple word, this will make you understand what is an implementation research. See, in clinical trials, what we do, we test whether a new intervention works, it's effective or not. Whereas in implementation research, what we need to do, we test how to make it work everywhere and for everyone. Simple example is noted down. A company built a car by a trial, but whether this car will work everywhere in the villages, cities, hilly area, that's an implementation research. So scale up is being done by the implementation research. Now how to do the next question comes to our mind. How many of you are involved in implementation research? Can I get the hands, please? Only one. I am also involved in an implementation research. I have, you might have seen that I have a WHO ANC model that's an ICMR funded. That was an implementation research. So in that already we were having, the WHO has given an ANC model, that this is the model every country has to identify and should implement that. But then India started doing that implementation research, whether this ANC model will work for the Indian states or not. That's known as an implementation model. So nothing going to be created, it's going to implement. When we implement, what happened? We have to take the many feedbacks. So in implementation research, Again, the most important part is try to involve all the stakeholders who are connected to this. Let's go in again for an example, one by one. First example, I already given this TB, but how can you formulate it in a better way so that you can put in very scheduled kind of an implementation research? TB control program, now it is TB elimination program. Problem is, many patients stop TB treatment halfway. You know that. MDR, again, that's the most important, and this is the major reason why the TB is not getting controlled, because many people, it's a long treatment, so people leave it in half of the way. Evidence-based intervention, what we have the dots in our hand, direct observation therapy. Implementation challenges, what's the challenge we have? It's a stigma or loss of wages for the travel, of course it's happening, and the forgetfulness. In overcrowded places, this is one of the major problem. IER approach means implementation research approach. What you need to do? The researcher should study the reasons and introduce the SMS reminders, family dots, and the digital adherence monitoring devices. How many of you know about the tuberculosis program? Your students might be going in community postings. You might have seen that. The TB centers have the electronic devices, the digital monitoring system now, and that digital monitoring system is a part of implementation research which has been done by many countries all together. But in India, because the scale of TB was too high, the prevalence of TB was too high, many deaths were happening. Even it has come that 3 lakh deaths happened in 2026. I'll tell you an interesting survey which held after when we were having the revised National Tuberculosis Program. It was in 2014, a study held at Mumbai. 2014 at Mumbai, and they find that for the TB, the survey received more than 900 plus different prescriptions. TB program is very set. They have the line of treatment. First line, second line treatment is there. Everything is so scheduled, but still, the implementation problem is every physician has taken it in a different way, and for single TB, one disease, they find more than 900 plus prescriptions. Then again, the problem started how to stop the TB. What are the problems we are facing? In that case, many stakeholders has given their feedbacks, and finally we have come up with the 2020, the National Tuberculosis Elimination Program. So that's a part of implementation research. If you not have that, then you will not able to do it, the modifications or further scale up of the evidence. So what's the lesson we have? IR adapts a program to realities of the people's life. I'll give you another example. I know many of you may not be knowing about the TB, but Lakshya program in government setups, it's very common program, Lakshya program, which is for maternal health. Now, if you see this Lakshya program, again, we will have the similar kind of a strategy, because we wanted to know how the implementation research is going to work for us. So, problem is high maternal and newborn deaths during the delivery. So, how this is going to be targeted by the Lakshya? Very simple. Evidence-based intervention, what we have in our hand, we have the safe delivery practice, which is well known. It's a well known, but it's not getting implemented. The problem, challenges, what we were having, poor staff training, that's a one challenge. Then lack of supervision. I just started. You're showing me 5 more minutes. I just started. Give me 10 minutes. I'll finish it early. Okay, lack of supervision and overcrowded labor rooms was the challenge. So what is the approach we must have for the implementation research is this. The researcher should use the quality improvement models like, team-based monitoring, feedback system, and the periodic audits. That's our approach. Now, what result we will get out of that? The result is improved respectful maternity care, then reduce the maternal complications, and enhance the patient satisfaction. What is our lesson? IR made a quality care practical and sustainable. That's more important again. Sustainability and scale up is an outcome of implementation research. The third, which is example of same, UIP, it's a universal immunization program. Problem we have, vaccine hesitancy and poor tracking. Evidence, what we have, that vaccines saves the lives. That's a proven from the decades. We know that. but still it is not taking up, then our IR approach will be introduction of electronic vaccine intelligence network that will help you, because digitalization involved everywhere, and digitalization will scale up the evidences intervention implementation. So that will track the stocks and the cold chain performance. Finally, what result? Reduce the vaccine wastage and improve the immunization coverage. What is the lesson we have? That IR uses the digital innovation to improve the program delivery efficiency. So that's how we use the implementation research. Now the next question comes, how are we supposed to do that? Very simple. Let's go ahead with this. So why we need the implementation research? See, this in many of the times it so happens that we have a lot of health policies in our hand, but not all policies work so well. Some of the policies may get fail in between. So in that case, our implementation research falls in business. And why? Because it helps us to understand how, why, and under what conditions interventions succeed or fail. So implementation research ke liye we have one tagline, that is, it converts policy on paper into practice on ground. That how it is happening at the ground level, at the reality level. So that's what known as an implementation research. So first we have an evidence, we identify the barriers, we implement the implementation research, we adopt, and finally impact have to be seen by scaling up. So let's have a quickly about the stages of implementation research. We have 6 stages. Number 1 is identify the problems, that what you wanted to, where you wanted to go for the implementation gap. Example, despite national guidelines for hand hygiene, compliances among nurses is still very low. Why IR focus on why that gaps exist? Because maybe the lack of supplies, or you say the time motivation. What is output? We can have a clear statement for the implementation research here, that the question can be, what are the barriers and facilitators to hand hygiene compliances among nursing staffs in district hospitals? You can have that, and then the outcome can be shared with the policymakers. That's the first step, to identify the implementation gap. Second step is understand the context, that what context you are going to work on. So first, you have to understand the environmental context. Environment, because this is what the India is facing. A study, for example, Lux has been, piloted at Tamil Nadu. At cervical cancer vaccine was first in 2009. It was piloted at Gujarat. But Gujarat culture or the Tamil Nadu culture is not same everywhere in the India. So in that case, the implementation research plays an important role, where how can you scale up, and everyone in all the states of the India, it can be beneficial. So you have to understand the context in terms of physical, cultural, organizational, or the political way. So in rural, for example, in rural area, the implementation research for maternal nutrition found that the women avoided supplementary due to a lot of myths are there. There are a lot of traditional practices of poor family support. So what you can do in the implementation research, guide the you can redesign the messages for the family members, especially the husband, who can take this lead and can help the improve the maternal nutrition. The third step after understanding the context is engage the stakeholders. This is the most important, because if you're not able to understand who all are the stakeholders are involved, it's not only about the beneficiaries. Understand it. It's not only about the beneficiaries, even those who are involved, providing, and the periphery. All stakeholders has to be touched and they have to be engaged. So that involve everyone who's affected, health workers, community members, program managers, and the other policymakers importantly, because they are going to change it. This ensures the ownership and sustainability. For example, National Health Mission, the involvement of ASHA is a purely part of the implementation research which the government of India has done. The fourth, after that, after engaging the stakeholder, design and select the implementation strategies that choose how you are going to test the improvement. So for that, training and mentoring programs can be there, job trainings can be there, or the supervisions can be there. Mobile or digital solution is a demand of current era. Then task shifting or the policy modifications. For example, simple in the tuberculosis program, you can see digital adherence tool help it to improve the statistic of the tuberculosis in India. The fifth is implement and monitor. Now everything has been done. You have engaged with the stakeholders. The thing has been in your hand. You understand what kind of a feedback you have. Now it's a time to implement and continuous monitoring is required there. So roll out that, choose a strategy at the pilot phase and then put it for the scaling up. Simple example, you have monitoring number of mothers practicing skin-to-skin contact after introducing KMC, the kangaroo mother care, and at the PSC's level. The sixth is the final one. Now you are going to scale up, evaluating and scale up. This is what you wanted to do. So in that, four things has to be measured: acceptability, how the population is accepting that change; then feasibility, whether it's going to feasible to implement or not. Third is fidelity. That's what how closely the intervention followed the plan which you have prepared. And the fourth one is sustainability, whether this program is going to sustain for a longer time or not. So that's how, if it is successful, share with the findings with the policymakers, because they are going to change it, and then only it's going to be scale up. Example, as I said, that Tamil Nadu Health System projected implementation research to improve the hospital quality standards by finding Kaya Kalp and Lakshya. And now you know that these programs are working everywhere. Okay, so these are the 6 steps. Clear? Okay. So finally, this is second last slide, madam. Okay. This is what I wanted to say, that implementation research, if you wanted to do, identify the key principles of the implementation research, that you need only these things, understand these things, then only you are going to do the implementation research. Practicability, whether it's going to be focused on the real world setting or not. It's not going to be done in the laboratories or the limited setup. No, it's going to be in the real world. So implementation research majorly used in the public health setups for creating the health policies and impacting the health policies understanding as a whole. Adaptability, how well it's adapted by the stakeholders or the local units. Collaborations, of course, require that involve the researchers, implementers, or all concerned stakeholders who are involved. This, of course, the community people is one of them. Sustainability, as I said already, how well you are going to sustain it, that's more important, and implementation research are meant for that only, to understand whether it's going to sustain or not. And scalability, it has to go for for everyone. That's what is important. So takeaway, very simple, is what? Implementation research is the science of turning evidences into impact. You have already evidence in your hand, only the thing which you wanted to see, that how it's going to impact everyone. It helps bridge the gap between research and the real life outcome. And what I wanted to say for India, because there is a huge demand of it, that in India, with the diversity, resource constraint, and the health challenges, implementation research is not just a method, it is a necessity, because so many things has to be done for everyone and for achieving the universal health coverage. And those who are really interested for the implementation research, for them, the courses are available at ICMR and NIHFW, and also ICMR have a lot of fund for the implementation research. Do visit their sites, so that you will come to know that almost every year, ICMR come out with an implementation research, because there are a lot of health policies which are supposed to be implemented entire nation. So they give the collaborative research, or they prepare a team from various states, and then they find that yes, these projects are good to implement. So that's all from my side. Thank you. Wanted to thank you for this, that all of you have listened to me patiently.
Thank you, Dr. Anil. It was wonderful. He gave us examples from the national programs. To start with the tuberculosis program, how it was every step they did something and implemented it, saw the results, made the changes. Similarly, Lakshya, then Kaya Kalp, and your universal immunization program. Everywhere, government has done it. I mean, we people, we do research only for the sake of research. We do not find much ways to implement them. But this lecture this session is giving us feedback on even everybody, if you want the results, you need to implement the research and do the research in the area where there is a possibility of implementation. Otherwise, it just becomes a, your academic exercise. So it should not be an academic exercise only. It should be worth implementable. Thank you so much.
Can I add one more word?
Yes.
See, implementation research is not a kind of a design which is supposed to follow. Majorly, or I say 99.99% implementation research we'll go with the mixed method. You need quantitative and qualitative parameters to scale up and to sustain the evidence which you have. So use the mixed method designs, go for the implementation.
Yeah, very true. I'm very fond of. I was doing the quantitative. Later on, did some qualitative research with Karolinska University. Understood what it is. Then found it is the mixed method that really works.
Yes.
Thank you. Yeah.
Thank you.
Good. Organizers, do we have to continue or you need to? Any questions?
Thank you so much, Anil. I just have a very small question that the time period for the implementation research has to be specified or it can be,
See, it
like
depends.
especially in academics.
It depends on what kind of a project it is. For example, I'll give you an example of it. I was doing this WHO ANC model implementation research. There, the ICMR have found more than 200 plus proposals from entire country. So they identify 5 projects, and all of them are from different states. From Gujarat, my proposal was got selected. So then we were having a team at Gujarat, then at CMC, Ludhiana, then one team at Ramaya, Karnataka, one team at Mumbai itself, ICMR Institute, and one team was at Bhubaneswar. So they made these 5 teams and working for one vision that how can we do this WHO ANC model can be implemented in India. So that project meant for 5 years, because we have to see in every state that how it's going to work. As I said, you have to understand the context, and these all are the programs which is very well connected with the cultural setup of our states. So that depends at which policy you are going to do. For example, if you do a Google even, you will find a lot of implementation research in related to the tuberculosis program, because a lot of studies has been done. There is a set protocol in a tuberculosis program, but still physicians, nurses are not aware about it, and that's the reason we find that a lot of prescriptions are there, a lot of care modules are there for the tuberculosis program. So when we do such, we'll come to it.
Vice Chancellor, is the time or Priyanka Madam will start it? Start Priyanka.
I guess the merit of your proposal and how they find it, it's how close of their demand. Yes, we have to give them. See, if they have given, let's say they wanted to revise even this elimination program, tuberculosis elimination program. So they will give a call for proposals that for this we want an implementation research. Now interested researchers can send their proposals to them.
Is coming.
Okay.
We need to break here for, we will continue this after the inauguration because the chief guest is arriving. So the organizers can tell you what to further. Thank you. Thank you, Anil.
Thank you.
Hello, check, 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 hello. स्पीड कितना चाहिए? हेलो 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 थोड़ा कम करो, थोड़ा कम करो। हेलो 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 कम, इको कम करो ना, कम करो इसे, इको को। हेलो 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 इको मत डालो, इको मत डालो। हेलो 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 तेज कर दो। हेलो 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 ठीक है। हेलो सही है। हेलो आप अपने हिसाब से भी डालो। हेलो 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 हेलो
Hello, hello, hello,
चेक कैसे?
hello, 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 hello.
हेलो 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 हेलो
हेलो हेलो सर चेक हेलो हेलो इसका शार्पनेस कम कर दो इसको। हेलो 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 हेलो
It is indeed our privilege to welcome among us our chief guest, Dr. P.K. Sharma, Sir, Honorable Vice Chancellor, Swami Vivekanand, Subharti University, whose esteemed presence add grace to this occasion, accomplished by Dr. Lubhan Singh, Sir, Additional Director Research, Swami Vivekanand, Subharti University, as our special guest for today. Light symbolizes knowledge, and knowledge dispels the darkness of ignorance. Let us now invoke the blessing of Goddess Saraswati, the divine wisdom, as we proceed for the lamp lighting accomplished by Saraswati Vanna. I request the gathering to kindly raise as the lamp is lit.
शुभं करोति कल्याणम् आरोग्यं सम्पदा शुभं करोति कल्याणम् आरोग्यं सम्पदा शत्रुबुद्धिविनाशाय दीपं ज्योतिर्नमोऽस्तुते दीपं ज्योतिर्नमोऽस्तुते दीपं ज्योतिर्नमोऽस्तुते दीपं ज्योतिर्नमोऽस्तुते दीपं ज्योतिर्नमोऽस्तुते जयति जय जय मा सरस्वती जयति जय जय मा सरस्वती जयति वीणा वादिनी जयति जय जय मा सरस्वती जयति वीणा वादिनी जयति जय जय मा सरस्वती जयति पद्मासना माता जयति पद्मासना माता माता जयति शुभ वरदायिनी जयति शुभ वरदायिनी जगत का कल्याण करे जगत का कल्याण करे हो विघ्न विनाशिनी जयति जय जय मां सरस्वती जयति वीणा वादिनी जयति जय जय मां सरस्वती जयल आसन छोड़ दे माँ कमल आसन छोड़ दे माँ देख मेरी दुर्दशा देख मेरी दुर्दशा ज्ञान का सरिता बहा ज्ञान की सरिता बहा हे सकल जग तारिणी जयति जय जय मां सरस्वती जयति वीणा वादिनी जयति जय जय जयति जय जय जयति जय जय मां सरस्वती
Thank you all. May the divine light guide our mind and inspire us towards greater understanding and compassion. We now invite Honorable Vice Chancellor Sir, Dr. Luban Sir, Dr. Asuma Bibi Ma'am, Dr. Usha Ogande Ma'am, Dr. Anil Sharma, Dr. Lata Mandal Ma'am, and Dr. Geeta Parvanda Ma'am to kindly take their seats on the dais as we begin the inaugural session of the National Conference on Emerging Trends in Nursing Research. Every gathering becomes meaningful when it begins with a word of welcome. We now invite Dr. Geeta Parvanda Ma'am, Principal and Dean, Pandanhaima Subharti Nursing College, to deliver welcome address and extend her warm greetings to all.
Jai Hind and warm greetings and my humble welcome greetings to all the executive members who are there on the dais, off the dais, and all delegates and participants who have come across India to attend and participate in this 2 days national conference, 29th annual national conference of NRSI on 13th to 15th November 25. I, Dean, Faculty of Nursing, Dr. Geeta Parwanda, is truly humbled and welcome Honorable Vice Chancellor, Sir Professor Dr. Pramod Kumar Sharma as Chief Guest. Guest of honor, Dr. Lubhan, Additional Director, Research, Subharti University, and Dr. Asuma Devi, who is President NRSI, Dr. Usha Ukande, ma'am, who is Advisor NRSI, Dr. Lata Mandal as Organizing and Secretary of NRSI, and Dr. Anil Kumar from Charusat University, who is a Vice President of NRSI. I welcome you all, sir, and we are so thankful for your gracious presence. A special welcome and heartfelt gratitude to the NRSI other executive member who have come from PGI Chandigarh. They have come even, we have here Dr. Gopi Chandran from NIMHANS. My special welcome to you. My special welcome to Professor Shashi Kumar, because I want to individual welcome you because you all have given your consent with one call that you will be there. Thank you so much, sir. First of all, I am so thankful to NRSI executive, all official for choosing Swami Vivekanand Subharati University, Uttar Pradesh as a event, what to say, host event. And madam, I would just like to bring two important facts about that. First of all, Meerut is a historical city because 1857 right started from here by Mr. Mangal Pandey. So the Vidro and the for some outcome was started from here. So I think it has got some relevancy. And secondly, the Swami Vivekanand Subharati University is laid down by our founder, Dr. Atul Krishna, surgeon by profession, and late Sangmata, Dr. Mukti Bhatnagar, a medical physician who were having the four more pillars of Subharati University, that is Seva, Shiksha, Sanskriti, and Rashtriyata. I may say that service, cultural, and nationality are the main thing, and we focus on mainly based on our Swami Vivekanand philosophy, arise, awaken, and reach to your goal. So here we use the term to greet each other is Jai Hind. So these are the some important facts, some small things. So we are again thankful that you have taken, you have said without any further clarification, you go on, and for that my special thanks to the president and all the officials. Now, Dr. P.K. Sharma, sir, I'm honored by your presence, and today I'm deeply thankful, and I find that this is a right platform to mention about your extensive research contribution. Sir has written uh, 650 scientific paper in Scopus and SCI's Index Journal, and I think this need a very big applause that today Sir has supervised 17 PhD and more than 270 M-Pharma scholars, and he has, if you search in all the research platform database, you will be finding the name of Professor Dr. Pramod Kumar Sharma. Sir has 127 patents, including 17 awarded ones. His citation metrics over 19,326 citation on Google Scholar and H index of 64 and I-10 index of 344 at least of his intellectual reputation across the pharmaceutical science. I think this is a vast and a very appropriate platform where that sir has given his consent to be a chief guest. Thank you so much, sir, for your gracious presence. We are honored by Dr. Asuma Devi, who is Dean, Astor MIMS College of Nursing, Kerala. Ma'am has, along with her PhD, ma'am has a additional diploma in medical education from UK, BHM, and at present holding a post of President NRSI. Ma'am, we are delighted to have you here. I extend my warm welcome to Additional Director Research, Professor Lubhan Singh sir, who is there, and sir has a renowned uh, uh, name in the research with the Scopus platform. So here the three terms are mainly for us in this university, and we usually get a message, I don't mind, regarding Scopus, Web of Science, and PubMed. Thank you, sir, for you are here. I extend my warm welcome to Dr. Usha Upande, ma'am, who is advisor NRSI, Dr. Anil Kumar, Vice President NRSI and Principal of Charusat University, Gujarat. Again, I'm thankful to Dr. Lata Mandal, Secretary NRSI, who has traveled all the way from West Bengal with the great enthusiasm for the research work. We hope that today deliberation of hands-on workshop and being scientific outcome for this great value. I welcome all the head of the institution, senior faculty members from various college for their benign presence. This 2 days conference will aim to bring knowledge related to evidence-based practice and the quality patient care. Sir, I will just like to ensure that we have a PhD scholar who have come all the way from West Bengal. We have some of the senior faculty who have come from the Yenopoya University. And sir, you will be really delighted to know the way they are working the bedside patient care, and from there, because we as a nurses, they don't say that we are up to only to the basic nursing care, but how the case studies and how the improvement in the vital parameter comes out, that is a true figure. And I said, I just request to all of them from West Bengal, kindly we should give applause to them, and so they are the people who have come from there. Yes, we have senior nursing officers from Military Hospital, Meerut. Yes, sir. Thank you so much, ma'am, that you have chosen Uttar Pradesh, Meerut, and Swami Vivekananda Nursing University for attending this prestigious esteemed conference. Thank you. From Military Hospital, Meerut, and from Army Hospital, Delhi, we had a senior nursing officer. We welcome you, ma'am. Thank you so much. Finally, I extend my heartfelt thanks to all delegates. Today we have a cultural event also in Satyajit Ray Auditorium, and I hope that these 2 days you have a beautiful and the comfort stay in this campus. To conclude, if you have an apple and I have an apple, when we exchange this apple, then you and I will still have one apple. And if you have an idea, I have an idea, and we exchange this idea, I think each of us will have two ideas by George Bernard Shaw. I think today the outcome from this conference, we may have the exchange of idea. And one my small request from my heart, ma'am, to the NRSI official, ma'am, can you declare one day for nursing research day? That day we can, if you declare it, come out to in white paper, and in a year when we have a WHO day, now why not we have a nursing research day? The house is open since we have the all intellectual from across India, and if it does, then this can be there through your society. This was just my small point. Okay, ma'am, that's the thing. And happy Children's Day to all today being 14 November. Thank you, Jai Hind and Namaskar.
Thank you so much, ma'am, for your warm and inspiring words of welcome. As a mark of our commitment to sustainability and our gratitude to our esteemed guests, we now proceed with a green gesture of welcome. May these plants symbolize growth, life, and the enduring bond of respect and gratitude. I now take this privilege in inviting Dr. Geeta Parvanda ma'am to kindly present a plant sapling as a token of love to our Honorable Vice Chancellor, sir. I invite Professor Ambli ma'am to kindly present a plant sapling as a token of love to Dr. Loban, sir. I invite Professor Sriram to kindly present a plant sapling as a token of love to Dr. Asuma Bibi ma'am. I invite Professor Manu to kindly present a plant sapling as a token of love to Dr. Usha Okhande ma'am. I invite Associate Professor Madhuri ma'am to kindly present a plant sapling as a token of love to Dr. Anil Sharma sir. I invite Associate Professor Khushbu ma'am to kindly present a plant sapling as a token of love to Dr. Lata Mandal ma'am. I request Professor Sriram sir to kindly present a plant sapling as a token of love to Dr. Priyanka Bansal ma'am. I invite Professor Ambli to kindly present a plant sapling as a token of love to Dr. Prema Janardhan ma'am. Uh-huh. I invite Professor Manu to kindly present plant sapling to Dr. Gopi Chandran L. Sir as a token of love from our side. I invite Miss Associate Professor Jasbir Kaur ma'am to kindly present a plant sapling to Dr. Shweta Patnaik ma'am as a token of love. I invite Associate Professor Madhuri ma'am to kindly present a plant sapling to Dr. Raman Ghalia ma'am as a token of love. I invite Associate Professor Saroj ma'am to kindly present a plant sapling as a token of love to Dr. Sushma Saini ma'am. I also request ma'am to kindly present a memento to Professor Shashi Kumar sir. Saroj, we have among us from CBS Publishers Miss Natasha also. I request ma'am to please come forward so that you can receive the plant sapling as a token of love. I request Associate Professor Khushbu ma'am to kindly present plant sapling. Okay.
Thank you, everyone. Research becomes meaningful when shared, recorded, and remembered. To commemorate the academic spirit of this conference, we now proceed with the release of the conference proceeding. May I request our chief guest, Dr. P.K. Sharma sir, Honorable Vice Chancellor, along with the dignitaries on the dais to kindly do the honors. May this publication serve as lasting record for today's collective learning and inspire future endeavors in nursing research. Thank you, respected dignitaries, for gracing this significant moment. The release of this conference proceeding marked not only the record of academic excellence but also reflection of our shared commitment to advancing nursing research.
I am honored to invite Dr. Asuma Bibi ma'am to say few words to the gathering on this inaugural.
Jai Hind, a warm good morning once again. Jai Hind. Respected dignitaries on and off the dais, distinguished guests, learned faculty members, dear students, ladies and gentlemen. It is with immense pride and heartfelt joy that I stand before you today to deliver this small address on 29th Annual National Conference of Nurse uh, Researchers Society for Innovations, formerly known as Nursing Research Society of India, which stays with the same abbreviation NRSI. At the outset, let me extend a warm welcome to all the participants who have joined us from across the nation to celebrate the spirit of research, innovation, and nursing excellence. This congregation reflects the growing strength of our profession and our collective commitment to advancing nursing science in India and beyond. We are truly privileged uh, to host this conference in the vibrant campus of Swami Vivekanand Subharti University, one of the premier universities in India, accredited with NAC A grade, and recipient of several national and international awards. Our society, the Nurse Researchers Society for Innovations, holds a historic position as the first professional body in the country dedicated to advancing nursing research, founded in the year 1986 by pioneering leaders of our profession like Indrajit Walia and her uh, team. Over the decades, NRSA has become a model organization promoting research, innovation, and evidence-based practice in nursing. Through conferences, workshops, its interactive platforms, and the Journal of Nurse Researchers Society, for Innovations, the society has successfully mentored generations of nurse researchers, influenced nursing policy, and enriched patient care. Today, NRSI continues its mission of mobilizing resources, interdisciplinary collaborations, and shaping a future where nursing research drives education, clinical practice, and policy transformation. Sorry. I take this opportunity to acknowledge the pivotal role of Pannadai Ma Subharti Nursing College, our gracious host. Established in January 2000, yeah, the college has emerged as a pioneer in nursing education in Western UP with advanced infrastructure, expert faculty, and an active focus on clinical, academic, community, and research. The institution has been nurturing competent nurses who contribute to healthcare at multiple levels. We extend our heartfelt appreciation to Dr. Captain Geeta and her dedicated team for their exceptional efforts in organizing this conference within such a short span of time. I have to place on record NRSI's appreciation towards this contribution by Dr. Captain Geeta and her team. Your commitment, meticulous planning, and tireless work ensured a smooth execution of and success of this event. Your teamwork and professionalism are truly commendable and have set a benchmark for excellence. Thank you, Dr. Geeta and team. You are really an asset to the university when our Honorable Vice Chancellor, Prof. Subharti University is here. I want to tell him also that Dr. Geeta and her team, the entire team of Nursing College is an asset to them in the campus. Uh, the theme of this year conference resonates deeply with our professional aspirations of Nurse Researchers Society for Innovations, that is fostering research-driven academic discussions, knowledge exchange, and professional development. This platform is organized to encourage educators, researchers, practitioners, and students to engage in a rich academic research, dialogue, explore emerging trends, and collaborate for the advancement of nursing and healthcare in our country. It is a moment where we collectively pause, reflect, and envision how research can continuously transform our profession and our patient outcomes. The conference has been meticulously planned with clear objectives to provide vibrant platform for knowledge sharing and professional networking. As Dr. Geeta was addressing the crowd, she said about ideas and how ideas will be shared and all those things. I don't need to repeat it anyway. So this is again to discuss emerging trends, challenges, and best practices in nursing research and foster interdisciplinary collaborations and open new research opportunities for nurses in the country. Though these objectives, through these objectives, we aim to empower our fraternity, that means our nursing fraternity, with knowledge and skills that are globally relevant and locally applicable. This is our dictum of Indian government, globally relevant and locally applicable. And that is why we talk about implementation research also in this conference. As we embark on this academic journey over the coming days, let us remember that nursing research is not merely about generating data, it is about transforming lives of people who are under our care. It is about bridging the gap between science and service, between evidence and empathy. Together, let us reaffirm our commitment to innovation, excellence, and the highest standards of professional practice. I once again extend my heartfelt gratitude to Swami Vivekanand Subharti University, Pannadai Ma Subharti Nursing College, our distinguished speakers, participants, and organizing team for their tireless efforts in making this conference possible. And one more thing, when I was reading the history of Pannadai Ma nursing college. Ipana means emerald. I was so shocked and so astonished. The name has come. Pana means emerald. So nursing college is an emerald. That is something great to know. And also the history of starting and naming the college is also fantastic. This shows our culture and our samskriti, I should say. That is what I felt. Anyway, may this conference inspire new collaborations, ignite fresh ideas, and strengthen our foundation of nursing science in our country. Jai Hind. Thank you.
Thank you so much, ma'am, for your words of inspiration. A true leader not only builds institutions but also nurtures mind. We are privileged to have Professor Dr. P.K. Sharma sir, Honorable Vice Chancellor of Swami Vivekanand Subharti University, as our chief guest for today, whose leadership and vision have been instrumental in advancing academic excellence. So we request you to kindly bless the gathering and inspire us with your enlightening thoughts.
Jai Hind. I don't think there's a noise or voice of Subhartians. Jai Hind. Still, it is not coming to my ear. Jai Hind. Yeah, now it is there. Friends, prior to starting this, I got two experiences. One at AIMS. I'm a very young person, but I'm interested in the research. That is my passion for excellence in research. Long back, while I was sitting over here, I remember that nearly, please close this door now, please bolt it. I don't want anybody should be inside or outside. Friends, that time it was again the nurses were there. They called me for the conference, and my question was this only: why nurses are stopping their career at bachelor's or diploma? Right? Today, when I had seen Asuma ma'am or the efforts by our honorable principal Geeta Parvanda ma'am, I was really heart touched. I'm not getting the words that am I sitting before the nurses who are now also coming for the research, and they had the forum for the research. Asuma ma'am, I salute you and your whole team, and I salute. You know, when people like Asuma ma'am, that our principal had desired, there should be a day for the nursing research. And I was sitting to adjacent to Professor Asuma, and I was shocked. Even Vice Chancellor can't do this. She told that tomorrow we will holding the GP and we'll put up this. The persons of that dearness are available at this level. Certainly they will make history. Second thing, I was just given to understand that this conference was going to somewhere else, but fortunately we got it. I remember, I think yesterday I called Dr. Parvanda for some work, or day before yesterday, and she was not well. And I asked that I hope you are not well. But she told, no sir, in half an hour I'll be in the campus. And just now the Vice President NSUI has updated me that she is suffering from dengue. Now, when you had the team leader with such dedication, don't we deserve at least one standing ovation for this gentle lady with the clapping? Madam, That is always there. Please, thank you for giving me this. I'm really honored by giving this. I always say that nursing college is good. Their team is doing excellent. I don't have to say anything. And to all the dignitaries, I just become so emotional. I really apologize that I had not even welcomed the dignitaries on the dais, off the dais. This you can see the emotion of a researcher. I just forget everything and I was so immersed in that that I should welcome that. So these are the humbleness, ma'am. These are the humanity. That is what I always tell to everyone. These all are the budding nurses. That there should be a different history. While I was going through the details of this, I prepared this, but I am not able to speak as per the written. I don't think anything's to be required. What Asuma ma'am has already told, what Dr. Geeta Parvanda ma'am has told. My only request is this, ma'am, to all the dais. Subharti University has been listed 1100 by QS World Ranking. 1100 in the world. The more better achievement is this, that the teacher-student ratio in that category, Subharti University has been ranked 5th in the world. For the academic work, Subharti University by QS ranking has worked 56th rank. Now you think about, we are not talking about the accreditation of this. The QS ranking system takes everything from the third party. They verify from there only. We are not there. We are not going to say anything. So I can assure you, all the persons who are here, they have came to attend. I'm thankful for them who are also people. You have trusted us, and we are not talking about the nation. Now we are talking of the global position. I assure you that these students will be recognized globally. The only thing which I need, what Geeta Pravanda ma'am has told, one apple is in your hand, one apple is in my hand. Let us share. The apple remains here only. It is not going anywhere. And the item remains there only. But we need the ideas. Friends, it is never and not possible that everybody is not getting the ideas. The only unfortunate part is there, we never document it. We never document it. Start making this a habit. It is not there that you should get the idea of nursing only. You may get an idea while you are working in the kitchen, while you are roaming on the road, while you are sitting in the hotel, while you are taking the dinner at that place. You may have this idea, oh, this glass is doing slightly disturbance to me. Why not I can change the design to like this only? Because you are working with the person, I will not say the person, the diseased person. And you say that the mental stage, the physical stage of a diseased person is better known to you than to us. And you handle them very carefully, very politely, emotionally. You are playing the role. So please make this habit of writing your idea. Please make this habit that I'm sorry to say, when such a good platform is there and still we don't get the research proposals, the patent ideas from that. Friends, do remember, people will always criticize. They had a reason to criticize because they don't have any work. But the persons who are working, tell me any person who is criticizing. Tell me any person on that because they are working. So you are in such a noble profession, you are saving the life. Really, you are saving the life. Kindly enlighten us. Kindly write your ideas that during this patient handling, we got this particular situation and we got this particular treatment or process which has saved the life. Because laboratory of the nurse is either a clinic or a hospital. This is the laboratory of that, what the trials are there. So start documenting. The university is with you. I'm again repeating, we have appointed the Attorney General who will be helping for writing for the idea which you are getting, and we are ready to pay any amount to get your idea patented. Second thing is that when you will start writing, you will get a access to be known in the world. That person is different because what you are doing in your room is not available to others. Everybody needs how best skilled you are. With these words, I'll stop my language. I'll just request every one of you, the person who are sitting here, Subharti is open for any type of collaboration. Subharti is open for any type of idea. To the all the dignitaries here also, you can also collaborate. Madam, we have just now going to start next month computer lab, that is a idea lab that has been invested with 1 crores of rupees. That is only the idea lab. We are coming up with the Subharti Research and Incubation Center. There also we'll incubate your ideas. We may take up if you had some startup ideas also. I'm sorry, someday will come, I'm sure I may not be there, but nurses will also come with the ideas of startup. So we are waiting for why not the Subhartian nurse student should become the first to be the person who brought the first person to brought idea of startup in the nursing also. With these words, thank you. Thanks a lot for patience listening.
Thank you so much, sir, for your blessings and encouragement. I take this moment as a privilege for me in thanking our chief guest and all our respected dignitaries on the dais for their presence in the inaugural session. We'll be moving on with our, resuming with our sessions. And I request Professor Sriram sir to kindly present a plant sapling to Dr. Sanchita ma'am, as ma'am has received an invitation and come here for as a resource person. Ma'am is faculty professor cum principal in Himalayan College of Nursing, Dehradun. We are very much privileged to have you here, ma'am, as a resource person.
All the dignitaries are requested to come forward for a photo. Military hospital staff are requested to come for a photo.
I invite Dr. Asuma Bibi ma'am to kindly present a memento as a token of honor to our Honorable Vice Chancellor, sir, for sir's presence to grace this inaugural session of our conference. Thank you so much, sir. From your busy schedule, you were here among us for the inaugural. Thank you so much, ma'am. Thank you, sir. Sorry for the inconvenience. We'll have a tea break of 15 minutes now as we are running short of time. So I request the gathering to kindly assemble for the tea near to the college entrance. I request you all uh, to kindly hurry up for after the tea so that we can resume with our sessions.
Posters, please submit to us. Give announcement. Posters and paper presentation, people will be shifted to their hall as they will be there and they should contact Madhuri.
Any posters and paper presentation is there, it can be submitted, and the presenters will be contacting Associate Professor Madhuri for the further proceeding of their presentations. Thank you so much.
Good afternoon, all. We will now be starting with the panel discussion on the theme AI in Nursing Research. For that, we have esteemed panelists Dr. Usha Gandhi, ma'am, Dr. Prema Janardhan, ma'am, Dr. Gopi Chandran, sir. The session will be moderated by Dr. Sanchita, ma'am, Professor, Principal, Himalayan College of Nursing, Swami Rama, Himalayan University, Dehradun. Presently, ma'am is working in Himalayan College of Nursing, Swami Rama Himalayan University. Ma'am is having 35 years of experience in nursing discipline. She has worked in various universities, and I would like to invite ma'am for the moderation.
Good afternoon, one and all present here. Though the gathering is very less, but I find the interested people are here. Because of the time constraint, uh, we'll cut short the introduction. We can know each other in various academic forums that is available. In this, all of us know that artificial intelligence is, helping as well as taking over various fields, and invariably health is health also. And without any doubt, nursing research is inevitably involved and getting immersed in artificial intelligence. So I thank the organizer for having selected this timely topic, AI in nursing research. In this panel, uh, mm, extreme right, we have Dr. Gopi Chandran. He is the quality manager and nursing consultant in Enhance, Bangalore. His introduction also I have to cut short with his permission. He is the coordinator of Pan India Heart Failure Stroke Program. He is the member of TNAI, NRSI, ISPN, and various other organizations. He is the PhD guide in Niemans. He is very actively involved in international, national, institutional, various academic programs. He has more than numerous publications in index journals. He's an international speaker. Most importantly, I have attended his session number of times, and I know him as a very good speaker, and he connects with the students. I'm very sorry that students are not here. You would like his presentation. He has also developed an app he would tell in his speech. I request Dr. Gopi to tell us about his experience. He is a very good nurse researcher. I would request his experience in application of AI in nursing research. Over to you, Dr. Gopi.
Thank you, madam. Also, I'd like to thank that organizing team, especially NRSI, because I'm very happy all the time I'm able to, attend this NRSI conference. That really made it, because I was, yesterday I had one session there in Bangalore. I met very young nurses. They told me, how do you feel nursing now? Because we are in the middle age now, already seniors. That person told me, sir, I have seen your presentation and I attended other presentation. After seeing this research only, we feel that nursing is growing very well. You see that even though we are dedicated professionals to so many tremendous services, even the COVID, that still nurses are, young people still going to medicine or engineering, then nursing only come for job, but only they're triggered, or I can say inspired with our research work to want to become, because today everyone or whoever they have taken the career to be the scientific professionals instead of that whatever they do them. That's why nurses become scientifically good. So one of the major contribution from NRSA where they are empowering. That's why I'm very part of, as a member and part of this conference, proud to say that it's become innovation. I feel so good because earlier it was a kind of India, now become innovation. That's our road to, our destiny to reach what we today we are talking about. So my, where is my slide mover? You are moving. So we, I have very quick presentation for 15 minutes because I know this was already, I also had to leave. And another thing, it already delayed in the sessions. So AI in nursing research, I think we are living in AI era. We were very proud to say, because today everyone investing in AI, because we know that we are definitely India like country, we have a lot of manpower, but we amplify our work. We wanted to do better and the time. and so many others, the gap or maybe we can say lacunae which can be overcome through AI, where the machines which help us. That's what it's not only in all the area, including healthcare, the AI is doing major work. But how we nurses understand AI, that's very important. Basically, what is AI? What is understanding itself? It's a AI itself complexity, but how we understand AI, what is exactly helping us, how we can work in that our workflow, and other than that, also in our nursing practices, and also in the research, how we can integrate. That's what the biggest, there is whichever the gap we found so far, we're helping. Overall, all healthcare team discipline, all healthcare team. Earlier we thought only doctors, only they're responsible for mortality, or we can say contributing for reducing mortality. Now this is well understood that multidisciplinary is the one make the differences. Everybody contributing, that way they make the difference. But how AI again integrating helping? I think you have attended the implementation research. He was mentioning the word how the digital technology is helping for to implement the national program. That was the finally the gap. Finally, there is a gap. In the gap you identify, you do research. Still, implementation of research also you need technology to implement, because India, like a diverse country, it's not like other countries. India is diverse nature of the landscape, people, context, everything. So you need some, and especially the ratio, doctor-nurse ratio, medical, nurses patient ratio. It's completely health professional between the population ratio is still need to be not achieved, even whatever we are working out. But we required something, that technology or structure to do to make that outcome to reach. That way we require technology. That's what even I done some many works with the heart failure patient, cancer patient. Even now I'm doing CVT. I understood that patient come to hospital, take the treatment, go back to the home. There is no connections, especially in the government sector. In private, still there is a lot of structure, but that's why we require technology. So this is what the ICU, before you are seeing that traditionally nurses working in this so much machines, but today you see how transformed. I'm the NABH assessor auditor. I went to hospitals, which is we don't want to tell the name as a confidential purpose. There the ICU, the AI ICU, that means everything is enabled. They all captured the vital parameters in the nurses in the hand tap, that able to do everything. This is what today the AI era, technology era, the technology, even though we know the parameters, how nurses still find a lot of difficult to manage with the machines, capturing the data, informing, reporting to the doctor, take the decision making. We need today the technology. It's not only that technology cannot replace the nurses. We already stated by even the president of the US, every professional can replace AI, nurses cannot replace. That's a well true, because we work with the soul. The soul to soul we connect. Nobody can connect to the other professionals. That's why it's very difficult. But still, how technology to facilitate nurses, amplify the nurse work, and when there is a workload is more, or nurses still in the demand, we are not, workforce is not there. How the technology helping us to, our improve our work or regulate our work. That what we wanted, that to the gap to identify the innovator, the nurses to become innovator. What we can able to say that today, whatever we see all the research today, we start with the resistance, we start with that, we initiate through the gap, we identify. Finally, we wanted to address to the gap only we are doing research. That way, whatever nurses felt in the need, it's not only the patient need, nurses find all the resistance to our documentation, structured documentation. There's a difference between unstructured, structured, where nurses to think about. And every notes, even I'm very happy when the Vice Chancellor talk about it, every nurse's expression is become its pattern, definitely. Every patient experiences with the nurses make the note that really it's like book. That much they can able to be, especially with the chronic patient who's suffering with the fighting for the diseases. They are with the different in terms of individualities there in terms of the treatment, for respond to the treatment, complexity in terms of the disease, respond to the symptoms. These all you captured, it's become different for you. It's a book that for the nurse, for you, to the future generation, how to take care of the particular patient or populations. In that way, we have a lot of challenges traditionally, but that way we are, whatever we do as a nurses, from admission to discharge, manually, whatever we do, all the complexity, but still how we can overcome, do the studies like small level, how scale up and do real time do that. This is what overall about overview about the AI, that another speaker will going to discuss more about it. But we were understood about machine learning, deep learning, and predictive analytics. This is a trend today. The patient come, we can able to predict it with the data, what the complication can develop, what type of risk the patient, what about the prognosis of the patient today with that AI we can able to do that way. Nurses need to understand this. It's very, very important is we work in the healthcare sector. Every professional, what they have the knowledge, same similar knowledge. That's why Madam was talking about, Madam, as in, we start with the medical model. Why? Because nurses to understand that medical concept very clearly, then only they can provide nursing care, what the patient required. That way that AI should understand by everybody. That way we can able to do. And computer vision is very common today. Even AIM started to use it, radiological finding through the using the AI for, especially in the COVID, they were started to use it. And also we talk about, today we talk about generative AI. That's a very, very common. Generative means which generate by own. Even you give the input. That is even we doesn't know that human doesn't know that AI will be, but even human is the one which create the model or provide the input. But the AI itself generate that. That's why we are getting so many slides, PowerPoint, everything you are making by own, by AI because of generative AI. And we talk about the research. It's I already telling all the clinical nurses, even I found so many MSc, BSc nurses, even they are, earlier they find difficult in the writing, do the reviews because of good AI tools. I can say that not like many AI tools are there, which will be very relevant or which is good one. We have seen, I listed because of time limit, they can also share this to you. And we can, especially consensus, prophylaxis, so many other good AI tools which can able to use it for review and analysis and report writing. And also that we are already good nurses today. I found they are doing systematic review and meta-analysis. That there is a software available for Rayon and Covidence. It also help you, guide you, because earlier, now the how YouTubes are, helping you for empowering you. Even you are not able to attend any conference, you can able to understand the quickly to get to know the information. Same way, these softwares are very friendly, guided friendly for you to know how to do it, and still you can get some mentor to help you to further to do it. So that way, there is another way analysis. Another one big challenge for nurses, the analyze data analysis. It's become more simplified because of AI tools. There is the SPS modular and many other, good qualitative also. There is analysis also can be do with, chat GPT based coding. That should be very useful nowadays, but you have to use it very defined manner, and you should not be and ethical manner. That's a very mandatory. Otherwise, the AI tools are existing today for helping you for your research where earlier they found difficulty in terms of analysis, literature review, or maybe to write the report, especially for publication. Now, this kind of very good direction for you, or the tools are helping you and explore further on that. So, talking about the clinical research in AI, how helping clinical research, it's a vast area. Now, already we are almost, I can see that, started in 2006, I started to explore working in AI or other, technical integrations, technology integration in my all kind of the research. Now it's very much expanded, and even I got opportunity to the other country to, collaborate and also start learn from them. In that way, we can say that patient care optimization, it's our objective, where we can able to predict, and especially our area like a fault risk, pressure ulcers, medication adherence, and personalized care plan. These are all major area from nursing domains where we can able to utilize the AI to, to improve the optimizations. And this is what the overall, the concept of this AI-based clinical decision. I think everyone know that still in the many of the good hospital, reputed hospitals, they keep all data-driven data stores wherever the patients come, any patient come, they take the history because of EHR, electronic health record, well-structured health record. They can able to, match out with this database, same similarity patient, all kind of, the problem, they can immediately match out and go for the treatment as per the standard guideline treatment. All are now linked. EHR, your information input, clinical decision support, follow the evidence-based practice, including nursing guideline in other country. I had opportunity to collaborate. I found that there is many universities, they are in US, they started to use that evidence-based nursing practice. So along with the model, same model. Here also you can see that how the model is working with the same kind of information assessment, you're collecting history, their symptoms, their complications, whatever, including other contributing factors. They used to match it or unmatch it. Match it means they say the same similarity of that, guideline they follow. Unmatched means they are engaged to what is the problem, is something different. During COVID, you understand everything. Every variant of COVID made the differences to take the decisions, whether it is COVID or non-COVID. That way, there's a lot of helping with this previous data that help us to help the physician and you also for any kind of, even with the bed sore, you cannot predict this patient will get bed sore. You cannot predict this patient get fall risk. That's why so many medication errors, adverse drug reactions, all the area today required to nurses to put their mind to think and take the decision, especially in our workflow. For that, you require definitely some technology to facilitate you, help your finally you have to oversee that, because we cannot so much depend on technology, how you can able to help. Same way, these all outcomes, definitely we all work for healthcare outcome, we work on patient care outcome. Outcomes are very much substantial. Like example, I told earlier we talk about mortality, morbidity, today talk about ADL, talk about quality of life, talk about medication adherence, we talk about the readmission. So many outcomes today we think about, even all are substantial outcome. Overall, we see quality of life is our clinical outcome. We say patient is quality of life is good, means we achieved everything. But still, we look into all micro outcomes, we look into the overall outcome, and we say that way we nurses today work on the outcome based. Earlier work on the doctor's orders. Now we work on outcome. That's what the research taught us, what you want to achieve, whatever you are doing you correct? Are you doing standard? That way we are able to achieve that. Again, somebody to help you, facilitate you. That way we are able to, so many models through AA help us. And the most important is patient safety. We understand patient is the biggest area. You give medication error, you do false risk problem, or maybe you have that, even infection, patient suffering with infection or sepsis, something happened because of we ignored. That also can be taken care by AA. That's called safety. And also we are using the current technologies, natural language, processing. It can say MP and NLP. That's NLP is a recent trend, especially for clinical notes. What nurses they are working. This is my work done by my student. She did it MSc in Ames, and she did now PhD completed US, and she is the innovator, first innovator in nurse-led NLP. She made very good. Last month I called her for talk with the whole nurses across our nations through CBS support. So she was expressed about this NLP innovations. She talked about so many words, stigmatized words we used during the time of care. Our communication with the patients, which is really more important, that made the patient to increase the length of the stay of the hospital. You see that she proven that from study, because of the communication, what you talk with the patient, especially with the comatose patient who are with the ventilator, we thought that we speak something, how many days the patient will be there, same time, and whatever you frustrate, you burn out, you express, this made the patient to stay for a long time. That was his proven. See that how much the important we understand our care and communications, what type of the word we are using, this all captured. That also they made like kind of innovation she made, that what kind of structured EHR, that means what type of notes we have to write. We have to write everything to that, what empathy we are showing, what tone we are using in the word, that all can be helped. So overall we understand today we are in the digital era. We are coming out from, from the paper, we are from paper to the digital, but definitely when you make to that something changes, transformation, we need structure. That structure will not, that's why we talk about mixed method. Why? Qualitative will help us exactly what we ignored, then we make into the different. So we already proven many of the studies or the work, the sepsis prediction. I think everyone knows that majorly the critical care patient die because of sepsis. It's unexpected if you are ignored, because nurses do 4 to 6 hour assessment, but still machine will do continuously real-time assessment that help us to do that. My work majorly on this remote monitoring, that was I think everyone know that I presented in NRSI also last time, so many work what I done it, but because of time limit, I just show that one of the recent work which is be awarded by the PhD student at AIM Delhi, that AI-based education, patient education, that was really made the patient to improve the adherence and also help them to, overall we understand even last implementation research. Why I'm bringing that research, because it was well structured, how that, adherence is the major problem. You see that whatever the doctor prescribe, whatever we instruct, the patient follow means patient will not back. The patient outcome is depending upon patient understand, we reinforce. There is a problem is we are not able to connect. That's why we are helping the technology, how we did. This is ICMR funded, almost 20 lakh they were funded for this with the, helping the patient, especially with the suffering with the cancer patient, the palliative management. We have e-prescription, we were started with this, and analgesic adjuvant, even the patient suffering with cancer, the pain management help the patient to improve the quality of life. And definitely they also report the symptoms which you wanted. We developed the website, web page link, so much, future will be there. Most important feature is alarm. We'll give you alarm every day, what time they're supposed to take the medications. And they also can report also when they come to the, to the doctors, they have that kind of, the app, which doctor can open the page. You can see last, for 3 months, 1 month, what was the patient status? Are they taken medicine properly? Are they taken any vomiting or constipation? Any report is given or not? That way, this really, during COVID time, this was very, almost 200 patients was benefited. We didn't get even one patient was not, I can report to the hospitals or not suffered anything. And there is no mortality also. That's why we received the national award for this, the best work. So we are very happy that we developed this with the AI mode, continue with this with the PhD, with the same project. We were able to develop that, Upchar app, that we can, one of the very difference is this app will give, automatically trigger the informations. Patient is having vomiting means the vomiting related information patient will get, not like customized information or personalized information. It will not give all the informations because every time we will feel boring, especially cancer patient, depression, you may stuck. Constipation means constipation only it will come. It's called machine learning method. It's a very simple automations where we triggered the patient to know, do, and also it gives same kind of other, automation like, alarms. And also we have that the patient remembrance for follow-up, everything will be there. That's why this work was well, accepted, and we are able to scale up more. So overall, that, advantage of this AI is good enough. And only thing is we have to consider the ethical aspect is crucial. Central ethical is very central for us. Privacy, confidentiality. That's why most of all my AI developed, and app and all, I developed with the institution like IIT or ICMR. Why? Because the software we are used server, physical server or maybe cloud server, which will be well protected and well aligned with the, because that's the biggest challenge. Even ethical committee will not permit you unless until you have developed such an app which a lot of privacy and confidence. You are ensured that you are able to do that. So a lot of challenges for nurses. And I get called from that. How do you develop an app? I am not even too easy to develop an app. When you go for research, you have to be very carefully how you can help you and capture your real time. That's why these nurses today, we really in the trend, we can say that we are, one time we are not able to fund from the good agencies. Today I can see so many people, today last speaker also has told many, fund he is getting. Everybody today able to get fund. And even when it was TNA also, we initiated that for funding for nurses. There is a fund available, your idea is available, but you can use this technology, the real time you can do many research that make the differences. So with that, I always, this is my own word which I written. That's my thought. So whatever we are dedicated professional, we do so many things as a different position we have, whether maybe educator, administrator, or maybe director, principal, whatever. But this all role, we learn the skills. Every role, even I was the TNA president of Delhi. I learned the leadership skills. All are skills you develop. This all skill help you to reach the pathway that to become the innovator and also the policy maker and entrepreneur. This is what our pathway to reach. This is our destiny. So all the nurses, clinical nurses, I have seen some of the one BSc nurse who worked in Raipur AIMS, he innovated one new, for ventilator. This is what today the trend is happening in nursing in India. Nurses are really highly inspired with other people and same time sharing that also knowledge to other like forum. And most important is your pathway, your destination, you should be sensitized. This is a destiny. You are becoming, you are researcher when you become innovator. You innovator, you are be part of the policy maker. Or again, your policy maker, your product, you are what you have patented, you sell out to them as an entrepreneur, not with the money, with your idea, your skill, what you are investing, that become entrepreneur. This is your way you have to reach. With that, I thank you very much for the, for the opportunity to share. It's a very short presentation. Still, I hope that something I sensitize. Any questions can arise. And also, CBS want to do something to, CBS from, yeah, they can also. Thank you very much. Anything from my, thank you. Very short.
Thank you so much, sir, for a very wonderful session. We have among us Dr. Anju Dheer, ma'am, Senior Product Manager, Commissioning Editor of CBS Publishers and Distributors. Ma'am over to you for the.
Thank you, Lindsay. Uh, Friends, we are here today to launch the book by Dr. Gopi Chandran, and I take the privilege to talk a little about Dr. Gopi Chandran and the book. This book, The Essentials of Educational Technology and Nursing Education for BSc Nursing students, is as per INC syllabus, which is revised one, and all the chapters are thoroughly revised and new topics have been added into it, as well as new chapter is added into this book. Now, Dr. Gopi Chandran is well known. He is PhD and MSN specialty with more than 23 years of teaching experience. He is working as assistant professor cum consultant in neuro nursing department of NIMHANS, Bengaluru. And co-author Kanyan Mal is also a doctorate and is a former professor cum dean of SRM College of Nursing, Chennai. Ma'am has got 40 years of experience and she is still working as a guide to the nursing PhD scholars. Now, I will call upon the stage Dr. Gopi Chandran, Dr. Usha Ukande, Dr. Raman Kalia, Dr. Urmila Bhardwaj, Dr. Geeta Parvanda, Dr. Asuma Devi, and CBS face, that is Miss Natasha Arora.
As it was a great presentation, sir. So, as sir is leaving, sir has to catch a flight. So, now I request Dr. Sanchita ma'am to present Memento and Patka as an honor to Dr. Gopi Chandran, sir. I would like to request sir and ma'am. So I invite Dr. Sanchita ma'am to continue the session.
Heartfelt thanks to Dr. Gopi Chandran. Very proud of you and all the best for your future endeavor. Dr. Gopi has covered almost all the aspects of AI in nursing research. Most convincingly, he very quickly covered upon his work through his students pertaining to AI. Please log on to his page in LinkedIn and you can read much more. Our next speaker, Dr. Prema Janardhan, Professor cum Vice Principal, VHS MA Chidambaram College of Nursing, Chennai. She has over 21 years of teaching, clinical and administrative experience. She held leadership role as Vice Principal cum Professor, Reader, Lecturer and various capacities in military and academic institutions. She has numerous publications. Very interested to know that she has worked on victimization on pregnant women and domestic violence. She completed a funded research project, Tamil Nadu NMC, on quality of lesson plans by nurse educator. Very much convincing. I would like to read up that. Her achievements and awards. She received numerous awards. To name a few, she was the Best Nursing Officer from Army Medical Corps School, Lucknow, Academic Excellence Award, and she's certified faculty from International fame, Johns Hopkins Nursing Center, USA. She has been PhD guide and advisor. She is contributing as executive editor in TNNMC journal, and obviously she is the inspector under the regulatory body TN Nurses and Midwifery Council. With this background, I call upon Dr. Prema Janardhan. She would cover, not to repeat the portion that Dr. Gopi has covered, she would take her portion very briefly, take you through, and I request her to cover the regulatory system in India related to AI. I think the seniors will be interested to know. I also request Dr. Prema to cover strategies for patient privacy and confidentiality. And lastly, the role of nursing education in preparing future researchers for AI integration. Over to you, Dr. Prema.
A very, a very good afternoon to everybody, and I thank the organizers for giving me this platform to share some knowledge regarding the AI in nursing research. As the previous speaker has spoken, he has given a wide briefing about how they actually find the problem and how they sorted out the issues and how we can apply the AI in the practical setting. Now I'll just touch upon like what is the various components of AI which is there, which we can use for research, and how we can maintain our standard of the research, like keeping the ethicalities and all that. So this is what sir has already mentioned, that it refers to machines or software. So there is no human touch in the AI. So we nurses have to play a vital role. So that's what we are going to look into today's session. So how AI is transforming nursing researches? It does its data analysis and pattern recognitions. That's what sir has also said, how we find out and predict things. And predictive analysis, we can use it. We can use it for evidence synthesis. We can use it for improving accuracy and efficiency. And personalized nursing research can be done in this. That is where individuals can be given, like individual like when we talk about research, we talk about samples in the population, but here it can be each and every individual can be a participant of the research, and also ethical and methodological inputs. So how AI is used in nursing research? Mainly we use it on various areas like literature review and writing, data analysis, efficiency and workflow is achieved when we use AI, and also predictive analysis and evidence-based practice can be there. Sorry for the thing. So the current trends which we have is we have the predictive analysis, chatbots and visual assistants, and we also have the predictive analysis can be done, and also the group that is we have that like the vision which we use in the analysis. So the emerging technologies which are in healthcare today, which we use is natural language, that is natural language processing. Here, whatever the nurses' notes are there, that can be utilized for doing a research through AI. And computer vision, that is analyzing wound images, which can tell us what is going to be the prognosis. And also we can use generative AI for creating clinical documents and patient education materials. And also the federated learning, collaborative research without compromising patient privacy, we can use this application. So when we talk about the patient education materials, we generally have a common material for all the patients, but when we use this AI, we can make a personalized education material. So what is the role of AI in the evidence-based practice? Because that is the current trend of practice for nursing, where we use a lot of evidence, and it supports by accelerating the literature synthesis, and also it is used for providing real-time clinical decision support can be obtained, and predictive evidence for real-world data, and also enhancing accuracy in the data. So by this we can improve the quality, safety and personalization of the patient care. So AI data management, mostly we use one is the big data. So a lot of information from investigation, science and symptoms, so much is available, and this can be analyzed for individual patients using this big data. And we have machine learning, which identifies patterns and trends, like how the progression will be there in the patient and what will be the outcome expected, and natural language processing and predictive analysis and data mining can be there. So when we use in nursing research, we can use it for identifying the risk factors, evaluating the interventions, resource allocations can be regularized, and also personalized care research can be done when we use this AI in nursing research. So the benefits, so we can handle volumes and densities, like large volume of data can be handled, and accuracy and reliability will be there in the analysis, and also it saves time and evidence base is available. So when we use predictive modeling, that is the real-time data, with the available real-time data, we can forecast what will be the future events and help nurses and researchers to anticipate patient needs. Because we today, we see the need of the patient on that day and we provide care. But here we can predict what is going to be the need of the patient in the future. And also it supports what we can use is machine learning algorithms can be used to predict the patient risks, and also electronic health records can be analyzed using this, and simulation of nursing interventions can be there. So what are the benefits of AI predictive modeling? When we use the predictive modeling, it enables us to proactively get the information than being very reactive. Not that when problem arises, we take care, we can presume it earlier. and quality and safety of care is achieved, and also data-driven decision making can be possible. And qualitative data, when we do a lot of research with qualitative data, we generally restrict the samples because it is very difficult to do the analysis. But here AI makes it very simpler. It can the time consuming analysis can be reduced by using this AI. And that is natural language processing is a concept which we can use, and qualitative data can be analyzed very easily. So AI helps us by text mining, then it gives sentiment analysis, that is emotion also can be analyzed using AI, and also pattern recognition on automated coding can be done. Because this is all I think is covered by the previous person, so I just skip them. So ethical challenges, ma'am is there, she's going to cover after this, so I'm skipping this part of it. Okay. So what are the skill development and nurses preparation? So today it's not that to say what AI is there and what we can use, but how to prepare the nurses. Are we really prepared to take up this AI into nursing profession? So for that, preparation of nurses is very important. In that, developing digital literacy and technical skills is very important. That is basics of computers and understanding the AI system, how it functions, because it's a vast area. It is not, it doesn't have much boundaries for us to say only this is AI. So we need to have a lot of understanding about it, and also using AI tools for decision support software systems. And all, by understanding all this, it will help the nurse to put, get proper AI tools to take up the research. And also strengthening critical thinking and analytical skills. So this is something which the nurses are very it's a real talent of a nurse. She has a lot of critical thinking and the analytical skills. But what happens when we use AI? This tends to get lost. We depend on the technology, but we should use our critical thinking skills to get assistance from AI than depending on the AI systems. And also promoting ethical and legal awareness, which ma'am will be addressing in detail, and continuous education and professional development. So for this, you should have enrolling into various courses on AI, and we can also have them participate in seminars and webinars. I think this is one of the good trigger for that. And also engaging in interprofessional collaboration. So because if we use any research, when we do, we always like to do a collaborative research. So in like when we use collaboration, we are able to give a holistic approach to the research. So another important thing is institutional and organizational support, which is very important. That is providing access to AI technologies, because when a researcher, when a person wants to dwell into the research, the access to technology should be available. And also establishing policies and guidelines, because when ma'am will be discussing about ethical aspects of this use of AI, you will understand how much of problems do come up. So how to also maintain the privacy. So that has to be there. Every institution should give them, whoever is going to use AI in their research, to give them guidelines as to how to use and what are the boundaries for it. And encourage the culture of innovation, transparency, and also accountability. So what is the role of nursing education in preparing future researchers in AI integration? So first is integrating AI into the curriculum. So curriculum should be having a detailed learning about how AI can be applied in nursing and nursing research. And second will be the developing of digital competency of the nurses. So the basic education itself should be focusing towards developing the competency of the student nurses and emphasizing on the ethical and responsible AI use, because lot of ethical problems do crop up, and promoting critical thinking and human judgment, because what happens when we use AI, the innovate, because even today if you want for a research, if you need a problem statement also, you ask the AI will give you a problem statement, but whether that is required or not and all that can be decided by the nurses. So ethical aspects has to be taught to them, and also encouraging research innovations. So continuous professional development for opportunities has to be opened up for people all throughout the profession. Like you can have workshops and training, online and offline courses, and also peer learning and mentoring sessions. So in collaboration, I was telling about that collaborative approach should be there when we use it in research. So in collaborative, how what will be the major role of people can be as a nurse. We can define research questions, ensure clinical relevance, interpret patient-centered outcomes which we expect. And what support you can get from the data scientist will be like developing the AI algorithms, and from the other technologists and engineers can be like building the AI platform to go about doing the research. So the best strategies for getting effective collaboration will be good communication among the team members, shared learning, mutual respect, and joint publications will help to travel smoothly in a collaborative aspect. So what are the ways to mitigate the problems which we face with AI is use AI as a supportive tool. Do not depend on them for our total research, and encourage critical evaluation and validation, and training and reasoning, ethical thinking and evidence appraisal has to be there, and promote reflective practice. So what are the challenges we face when we use this AI in nursing is that ethical concerns and academic integrity is one issue. Then we have data privacy and confidentiality, lack of accuracy and reliability, because when we do not if we are not using the AI properly, then this problem can crop up. Technical and knowledge barriers can be there. Bias and inequity in algorithms, and lack of clear guidelines and regulation, and financial and infrastructure barriers will be we do encounter when we use AI. Because these are all already discussed. So what are the AI tools we use in writing is, so we use Grammarly, ChatGPT, Quillbot, Scriber AI, proofreaders. So many we use, but how much? Like when we use all this, we should not rely on them totally, but we have to use our judgment to check for the accuracy. So for analysis, we use IBS, PSS Modeler, Rapid Miner, NYO, and Tableau with AI Analytics and MATLAB. And we have AI tools for reference management are EndNote, Zotero, and Mendeley. These all help us to do the referencing. And we have for clinical decision support, we have various AIs, IBM Watson Health, Google DeepMind Health, and Epic Systems, Microsoft Azure Machine Learning, and Biosymmetrics Augusta. These are all other support systems which you can use in the clinical research. And to to check for plagiarism, we have Turnitin, then Authenticate and Grammarly Premium, and certain regulatory frameworks are there. That is patient safety risk management, then data privacy, security, transparency and explainability, and bias and fairness. So, what will be happening in nursing when we bring AI in will be like, first it will be for 1 year. It may be the basic education and training which will be required for the person. Then next short term will be like 1 to 3 years. That is to involve AI in the research and practice, and also 3 to 5 years we can deploy them as a continuous monitoring process. We can use the AI. So large scale studies are possible. Maybe if we start today training people and going ahead in the next 5 years, we can master ourselves in the using AI in the nursing research. So to conclude, I would like to just give a takeaway point. Nurses must embrace AI as a tool to enhance, not to replace, human judgment and compassion in care delivery. So there can be no AI without nursing touch. So we cannot go away to technology without the touch. Thank you.
Thank you, Dr. Prema. Very elaborately and not very fast, so people could understand all the points you described. It takes time to, internalize the components that you have said, but very nicely you have described the care plan part and all the technologies, and motivated the young students who are sitting behind that they can take part of this AI. It is not replacement, but it is the supplement, you can think. How many of you who are sitting behind have watched the movie where Kirti Sanan is playing the role of Sipra? How many of you have watched? No? Only two. The trailer. The last part, many, both the speakers have covered the, I think, does the algorithm part. If even for a computer, if you give wrong input, the output will be wrong. So the last part of it, the Shahid Kapoor is destroying her because she goes with a fire wood in her hand, Delhi ko jala denge. Because the algorithm was such that her battery goes low and she is following the instruction that the human gave her 3 days before. So you have to understand that the input instruction that you give, that's more important. Algorithm is more important where the human connectivity and is required and planning is required. So as she has rightly said that it is not replacing, but it is AI is to help us, not to replace us. It can be very fast. The huge data we have to cover within short time it can do, but based on the instruction that we have given or the input that you have given. So that is the take home message. And we all the technological part is discussed, but I am very much interested to know what are the ethical consideration that we should, our young ones should know, and the challenges that they should consider while applying AI in nursing research. For this, I call upon Dr. Usha Ukhande. I think Madam told me not to again elaborately tell about her. Madam is the president of SOMI and director Chottidam College of Nursing Indore. I think Madam has been already introduced. So with her permission, you are very senior to me. With your permission, I request you to kindly tell us how your next generation of nurses should use AI, keeping in mind the ethical consideration. Over to you, Madam.
I don't see it. Can't see it.
Can I have it? I don't know. You stand. गुड आफ्टरनून ना जय हिंद बोलना चाहिए जय हिंद जय हिंद गुड मुझे ऐसा लग रहा है जैसे ना टाइम ऐसा है कि लोग सो रहे हैं प्लीज सोना नहीं है ना थोड़ा सा I'll not spend much time because I am going to talk about legal and legal considerations in using AI in nursing practice and in nursing research, right? मेरी जो स्लाइड्स है ना उसमें बहुत सारा ऑलरेडी कवर हो गया है एवरीथिंग सिंस मॉर्निंग वी आर टॉकिंग अबाउट इट गोपी हैड डन वेरी वेल एआई नर्सिंग इन्वॉल्व्स बोल दिया चलिए कैन यू मूव इट गुड okay we realize that yes because nursing cannot stay separate nursing AI has become part of everyday's life not only in nursing not only in healthcare not only in industry everywhere in our personal life also chat gpt सब लोग यूज करते रहते हैं छोटे छोटे काम के लिए उसको ऑर्डर दे देते हैं ये बता दो and it tells you and if we have more of these luxuries we become dependent on them this is the thing this is what we are going to talk about ethical consideration so I'll quickly go through please next ये कौन था यहाँ भाई okay it's moving na move clinical nursing practice has a potential to revolutionize healthcare delivery, improve patient outcomes, and transform the role of nurses. This was said in 2020. Now it is 25. People have already started using in clinical, but I don't know how many clinical nurses are really using AI for improving their patient care. We have doubt. You can have you can do some research on it. It does improve our efficiency in practice, nursing practice, if we use it properly. Accuracy, it does give us accuracy because the data which is we are making use of the things, it is collected from all sources. Patient outcomes should improve. Again, it's a matter of concern, a matter of research that try to see if the nurses are using it and have the outcome improved or not. And time saving, of course, it is time saving. Yes, in nursing research, in nursing practice, everywhere. Okay, next. Whatever has been put in red is little more specific. That is, if we use AI in nursing practice, it helps us in using evidence-based. There are evidence-based recommendations. I was saying that many research topics are taken on implementational research also by scholars in colleges, but it is not, it doesn't go to the practice side. We do not collaborate adequately with the practice people and so we do not, most of the studies remain in their libraries, they are not implemented here because they can use it directly. It is available online, so they can use it. So evidence-based recommendations can be used by practicing nurses for improving the patient outcome by using AI. Then it makes us easy for the nurses working in the field, that is monitoring patients' vital signs, detect early warning signs, deterioration, receive real time. Those things have been said that AI does help us if we are consciously taking care of patients and we want improvement in patient care. So the practicing nurses can use it and can improve in these areas. And it streamlines care coordination and reduce nursing workload. Most of the time when you talk to nurses practicing, if we ask them, what are the problems? There's a shortage of nurses. So this is the thing for you. You can use it properly and help you to reduce your workload. Okay, next. The most important is because it has come and we should start preparing our students in the colleges itself. Good thing that book which is written by, just now we released that book, it's the 3rd edition of Gopi Chand. So it is there. But how much they are using it in teaching the nurses in the classrooms how to use it, I have doubts. We are not really very sincerely. It is again made into a theoretical part of education and not a practical part. Let's all of us look at this, that how do we make it, like if you teach it in the classroom, give them some project to do it, so that we are sure that yes, they have understood and they will use it. Okay, so this needs to be done. Okay, next. Same thing is repeated. I'm not going to repeat it. Come on, next. Please scroll. Yeah. All theoretical things, right? Chali, aage. Ethicals. Here comes the point. I have put it in ethical practice, use of AI ethics in practice as well as in research. Education part is separate. Education we will teach them, and there hardly any ethics are concerned about use of AI. Okay, so autonomy is one thing. Autonomy of the practitioners and of patients. Patient has a right to decide about his care. Now, if AI has come, the doctors will say, we are using this and this is the way. Patient is not familiar with that. And if we are considerate about involving the patient and their relatives into patient care, like I want to do this particular procedure for your surgery or avoiding surgery, I'm going to do this. This has to be made very, very clear to patient and take their consent. Okay, okay, I can go for it. But because it's a new thing, because people will have doubt, so are we compromising with the autonomy of the patient or not? That is the concern. Doctor may decide it, and nurse is standing, she is there all the time coordinating with the doctor and the patient. If it comes to her mind that this patient doesn't understand, he's from village, he doesn't understand this new technique that doctor is telling, and doctor has not explained properly, like we say written consent after explaining in their language, are we doing it? We are just signing it. So that is the concern for us, the nurses who are custodian of our patients. So we are a bridge between the patient and the doctor. So we need to understand it, make it clear to them, and see that patient's autonomy is not compromised. Okay, next. Privacy and confidentiality. You know, the data that we create now, anything, even your own personal data from your mobile phone is going where it is going, you know, all that AI is created from that. And here the patient's data is there. There used to be a lot of concern about privacy and confidentiality. Now, how much confidentiality and how much privacy is going to be compromised if we use AI? That concern the nurses need to feel and consider and discuss. Okay, next. Accountability and responsibility. If AI maker makes an error, who is responsible? The nurse, the hospital, or the AI developer? We take artificial intelligence, somebody has developed it, and we try to put it into practice in our work. And something happens to the patient. So who is responsible? Is it the nurse who has carried out the order? Is it the doctor who gave the order based on AI? Or is it the AI developer who gave us all that information? That also needs to be looked into. Nurses must still apply critical thinking rather than blindly following all AI recommendations. So critical thinking has to be used, maybe more than before. Maybe more than before. Okay, next. Human touch. Every speaker said this. AI cannot replace the nurse's specific, very basic compassion and human touch. You know, earlier also patient, once I was a nursing superintendent, I went for a go for a round. One gentleman came to me, do you see how many nurses are touching the patient? He was watching. Nurses are coming, giving goli, injection, doing things, not even touching the patient. He said, I was the nursing superintendent. I really felt it. Okay, yes, he's right. So I would see that most of our nurses should, that human touch should be there. अभी AI आ गया है तो अब क्या होगा? We will be going more further away from that. So please, that thing needs to be. Nobody can, no AI or no other technology or no machines can replace our touch. That is the basic for us. Ethical question is, can AI truly support emotional needs of the patient? These days, we were seeing the simulation. Earlier, simulation was very, in between, they put the, okay, patient can respond also. Heart problem. Emotion is coming there or not? How does the person? But they are progressing, but still, it is an artificial thing. It's not the human actual reaction of the person to what you do. So that thing, if there is a progress in this technique also, that these things can be incorporated, fine. But I heard somewhere that AI is going to go very, very fast. Top will come. And then along with that, SI is coming. Spiritual intelligence is coming up. There is a need. That's why we are talking about it. Like in this institution, in this university, you've heard every speaker, first speaker, uh, today's speaker, they are very spiritual. Although in technology also they are very fast, but they are spiritual. And I want to tell one more thing. That is, there is सोलन में एक यूनिवर्सिटी है बाबा इन लोगों को पता है सैनी मैडम एंड ऑल there is a Baba, that university, क्या यूनिवर्सिटी डिवाइन यूनिवर्सिटी सोलन में है बरू साहब university. Once we were there, Babaji, who runs that university, I mean, he's the top person, he came and said, it was nursing conference, he said nursing is a spiritual profession. I really loved that one sentence. Nursing is a spiritual profession. तो spirituality जो है वो आएगी ही, आने ही चाहिए. So I write a column in Beyond Nursing in my journal. In that I based on Babaji's word, nursing is a spiritual profession. So I wrote that column. I felt really, yeah, if the nurses are not spiritual, then they are not nurses. So while you are using AI, do use it because it needs to be used. Don't forget our basic. And we are spiritual. God has made us nurses so that we be with the patients. And this AI should not come and disturb us. We can make use of it. We can make it our servant and not our master. Okay, next. Yeah, those things have been said that it is good that we use it for our data management. See, I tell you from my own experience, when we did our master study, we were doing it manually, all data, the data was less. When I did my PhD, that time I used SPSS, Reader Progress. Now people are using this. Similarly, for qualitative research, we were using open code for transaction of that, making them into codes and memos, etc., whatever. Now this thing has come. So the information technology is progressing very fast, giving us new tools, good thing. We make use of them. We should make use of them, but don't let them become your masters. Keep on using your brain also along with. Otherwise, people will stop thinking, only depend. Like these days, if you ask somebody to calculate few things, इतना ऐड कर दो, माइनस कर दो, तो लोगों से होता नहीं है. झट से अपना मोबाइल निकालते हैं, उस पर करते हैं. मैनुअली नहीं करते, माइंड से भी नहीं करते हैं. I want to tell you, we have a sabzi wali. She's so good. She's not much educated. Maybe art class पढ़ी होगी. I take sabzi and fruits etc. for 500 rupees. She will keep on calculating. Mind. उसका बेटा जो है वो कंप्यूटर पे करता है, जबकि ये लेडी अपने माइंड से करती है. वो ज्यादा पढ़ी लिखी नहीं है. And it's always accurate because she's always using it. We have stopped using that. So same thing is here, that don't stop using your brains. Okay, next. Time efficiency, we mentioned it. Yes, it helps us in time. This thing. Okay, next. Qualitative, I told you that this new tool, NLP, is helping replacing the open code that I use for my qualitative research. I had to put it, that was a software, उसमें डाला, उसमें सब कुछ फिर भी manually करना पड़ता था. यहाँ पे they'll do it everything for you. It's a good thing, but then don't blindly follow it. Consider, is it okay what they are telling you? Okay, next. Predictive modeling, you people have already discussed in detail. Okay, next. Yeah, evidence synthesis. Yes, it helps a lot. Simple. Earlier we used to do a lot of systematic review and meta-analysis and then come to with some conclusion. Here you will have the conclusions fast. But then again, using those conclusions for as evidence for your patient care or in your research, then it needs to be thought about. Okay, next. Simulation. Yes. Virtual patients. Yeah, it is help that, okay, now they are showing that all those changes which occur on the simulation, because we do not have, nowadays we don't get patients. Our students do not get adequate number of patients, and patients are not supposed to be treated like earlier. So many students were there, we were learning in the clinical. Now it's difficult to learn in the clinical for the students. So simulation is also improving and helping us in making it more, that the students really can use it. Okay, next. Again, decision support means when you want to take, you are using AI, but use your own brains also. Okay, next. Data privacy, interpretability, training need. These are the three things which are important. That is, we must see that the privacy is maintained. Interpretable means ki what we are getting, can we put it into practice? That we need to look into. And of course, not only in the classrooms, but all the nurses working in the field, in the practice area, in clinical area, need to be made acquainted with this, and they can make best use of AI in their work field. Okay, next. In research, concern for plagiarism. Yes. What happened, sometime back in my journal, one girl, she had sent her data, and I told her to talk to you. In March, we were going through that. In June, we took out our journal, but before we took out the journal, I mean, with her data and with her topic, someone else has already published it somewhere. She found it online, but she could not get the full article. But she tells me, Madam, aisa ho gaya. I said, where was your data? She said it was with the statistician. I said, that statistical person must have leaked it or not. He didn't personally did it, but when it is in the system, from system, somebody has taken it. So these things can happen, and that is why somebody can take it or somebody can take your data. So these need to be considered. Yes, there can be. You can take somewhere from somewhere. You can steal the data, or your data can be stolen. So that will concern with the plagiarism, and similarly with publication. Nowadays, when they take your research topic for publication, you will make sure that it has not been published somewhere else, knowingly or unknowingly. So those are our concerns. Okay, next. Intellectual property, again, that's a big issue. So when you are doing research, you will have to see whose intellectual property it is. Are they taking it? I mean, you have worked, but somebody else has taken it. So those things also need to be looked into. I'm not an expert in that. Expert people are young people. You can look into this and consider. I think we need to have a one full day conference on all these issues. Okay. Same thing that we need to be, that girl, when she asked me if this is my work and somebody else has published it, so it becomes somebody else's intellectual property. If that person goes into internet earlier than what we published. So this is a concern we need to look. Okay, next. Legal issues, data protection laws. We should know, are there any new laws made for this kind of work. Compliance with local, national, international data protection regulations. Maybe since AI has come, there are some more regulations that we need to look into while we are taking help from AI for data management. Penalties for violence can also be severe. If they have given the regulations and if we have not followed them, then we may be penalized for that, so that we need to know. These are the legal issues. Okay. Liability, unclear legal framework about AI related errors in healthcare. So that also, whose liability, who is going to be punished for that? Are we allowed to use this? So you can have an in-house this thing that, okay, this much is allowed, this much is not, this is not allowed, using the AI so all, because if a doctor commits a mistake and it happens, it's a private institution, the management, top management will be caught. Why this patient suffered because of the decision that you people took using AI, whereas the other method was already there. Why didn't that use it? Okay. Possible need for shared liability models. Okay. So these are, there is still need to, we need to, institutions can work together to see that how far they can use the AI new technology, which is supported by AI and which is better than the traditional method that they were using. Okay, next. Regulatory approvals. Like you see here, MTP Act came. There are many regulations for MTP Act. In fact, when this came, um, sonography and all that, people misused it. We have that habit of misusing it. तो इसीलिए MTP Act बना था, because what they did, they started using it for sex determination and killing the, aborting the female sex. So that thing happened. That is why MTP Act came. So MTP Act is very strict about many things, many things. Again, so we need to see, is there any change in that? Is AI also being into it, and what are the changes that have happened? That's an example. Okay, nurses must ensure tools are certified, approved before use. Any tool that you use, it is certified at global level, at national level, at your institutional level, and then only you should use it. Even the clinician, they are the main persons for taking care of patients. I mean, treating the patients. We are the people who are taking care of the patients. So we need to know that regulatory body approval is there or not. Okay. Next. हो गया ये last है. Okay, I think there is one more. Now, how best we can address this ongoing training of nurses? And they must understand. Everybody mentioned, yes, training is needed. Okay, and ethical committee should be there to evaluate. Earlier, we always send our projects, research projects through ethical committee. So now they should also be more enlightened. How do we use ethical committee? What decision does it take in use of AI? Bias audits, regular check and discrimination of AI outputs. It needs to be done regularly, and patient-centered approach. Of course, my patient is a person. Long back when I was a student, I was given this thing. I had to write an essay on my patient is a person. That was 50 years back. I wrote based on that time, my observations. Now observations are different. I mean, AI has come in. We are talking about AI. So my patient is a person. Am I really serving him without doing any harm to my patient? Okay, next. These are the areas. Okay, next. People have told there are so many areas. Nursing skills, AI will never replace. Intuition, AI के पास intuition होगा कि मेरे patient को क्या होने जा रहा है? No. Nurses have, we have. Emotional intelligence, AI doesn't have. Ethical improvisation, ethically. Okay, trust and integrity. A human being, nurse has the, people trust us, nurses. Value judgment, mentorship, original thinking, inspiring others, true collaboration, personal courage, humor and connection, negotiation. These are the qualities that we have. Look for, if you think your AI has these qualities, compare it, make use of it. Otherwise, use your own brain and heart, both. Okay, next. छोड़ दो इसको. Next. Okay, so what we say is, what does wisdom say? Internet plus internet. Together they will work better. So don't depend totally on that. Use your own inner spiritual values and go about making best use of your AI as a servant. Okay, next step. Okay, let AI be your servant and not your master. Responsible integration is another thing. Yes, use it. It should be used, but responsibly. Responsibly. Okay, next. Thank you.
Thank you very much, Dr. Professor Usha Khande, ma'am. Ma'am has covered very elaborately, very patiently, shared her experience. She has covered all aspects of AI again, made you all understand. I'm very happy that ma'am covered the importance of simulation and how it is helping, which is currently we are using. I come from Himalayan College of Nursing, Saminama Himalayan University. We recently inaugurated AR and VR, augmented reality and virtual reality. I got an experience of demonstration, and I felt how happy the young ones will be by applying such modalities in the laboratory before you touch the actual patient. Because nowadays the student numbers have increased and there is no space in the laboratory. So it is nice that you use the normal demonstration, then you do AR, VR, and then you go to the actual setting. Madam has also very beautifully explained. I have heard Madam 2-3 times in my lifetime, and very nicely explain about the plagiarism, about her journals. She said this AI can also write the proposal for you, can create the not create, I would say AI cannot create. Currently the AI that we are having, it doesn't have creativity, but it can generate the research proposal for you. As ma'am already said, one of them said that they can develop the problem statement, but you have to use the human intelligence to understand whether that research topic is realistic, whether ethical concern is there. So I think there are many take-home messages. Most beautiful part is that people who are talking behind, I will ask one question because you are not asking any question. Can you name 2 E's? Can you name 2 E's which the current AI does not have? Students, can you name 2 E's, which the current AI does not have? Emotional intelligence and ethical consideration. It cannot do something which is novel. It will perform as per the instruction. However, as all the speakers have touched upon the uses of human intelligence, I conclude this session. It's already lunch hour. We have taken 15 minutes more. That we have to develop the AI very carefully and apply it very intelligently, and then regulate it also very thoughtfully. And as last 10 minutes ma'am spoke about the limitations of AI, we have to be very much aware about the limitations of AI. With these few words, I open this for discussion. I think we can take only 2 questions. If you have any questions, please raise your hand. Anyone from front rows or back rows? I think all are very hungry now, already 2 p.m. and we have a session After this, can we take one or two questions? If not, uh, please permit me to conclude this session with the summarizing points. Wish you all the best and thank the organizer for having included us in this scientific forum, beautiful forum where the president is sitting. At this stage, madam is from morning sitting over here, other senior people are here. Sushma Saini ma'am, thank you. Dr. Ashima ma'am, thank you so much. And have a good lunch. Thank you very much.
Thank you to all the eminent panelists and moderator for the thoughtful, provoking and forward-looking discussion. So I request Sanchita ma'am and Prema ma'am to kindly take their seats, and I would like to request uh, Dr. Priyanka Bansal ma'am to continue with the first plenary session, that is on Delphi technique, which will be moderated by Dr. Usha Ugande ma'am. The stage is yours, ma'am.
So, good afternoन. सॉरी, जय हिंद, जय हिंद, जय हिंद. सुबह का एक सेशन बचा हुआ है प्रियंका मैडम का. We were having the first emerging trends in nursing research. She is going to talk about Delphi technique in nursing research. So, over to you, Priyanka ji. जरा जल्दी कर दे.
Thank you so much, Usha ma'am. And I know this is your lunch break and I am taking time in that. Apology for that. But I assure you that it will be a short and sweet session. And I'll try that it is beneficial to you as much as possible. Okay? Okay. So, Delphi technique. I think anyone, students, I would like to know from you. Have you heard this term before? Delphi? What is Delphi technique? Anyone? Yes? Okay. Let me brief you. So it's an iterative process that refines and converges expert opinions over successive rounds, right? And Delphi technique is a research approach which is used to gain consensus through a series of rounds of questionnaire surveys where information and results are fed back to the panel members between each round, and it aims to achieve consensus or decisions on a specific topic or issues. Right. So here, the role of AI is not there as of now. And here we are more concerned about taking opinions from the experts. And as it states, it's an iterative process. That means it is a frequent or a repeated process till the time a particular decision is achieved, right? Or particular opinion, a collective opinion is achieved. And then It has various rounds, as it is said, at least minimal 2 rounds, right? And after achieving a particular, or a collective opinion, then we move forward with the decision-making policies in it. So how Delphi technique got its name? Very fancy name, right? And how did it came into the market? Let's see the brief history about it. So in Greece there was a Greek oracle which was called the Greek oracle of Delphi. So when there was any issues or any problems, there was one priestess, right? Her name was Pythia, and she had this panel of priests around her. So they used to give their opinions about that particular problem, and then a particular consensus was made that okay, for this particular problem this should be the solution. So maybe again if the that person was not satisfied with that particular decision, then again another round was done. So that's how this Delphi technique came into being, and it is not only in nursing research we see that, we see its presence in many other fields where a particular consensus of experts is required, right? So I have already discussed that, an overview of Delphi technique. So just a formal definition is that it's an iterative process that refines and converges expert opinions over successive rounds. So in the picturesque form, you can see there are issues, there are problems, right? Through which we formulate proper questionnaires, and these questionnaires they are circulated to the experts with the help of a facilitator, right? Feedback is achieved, and then there are consensus rounds, and finally we came on to a particular decision. Okay, so first we'll just discuss what are the 6 major steps of your Delphi technique, right? So here we can see first and foremost step is your panel discussion. I will be discussing all these steps in detail. So first I'll just enlist them. First is your panel selection. Second is your round 1. Okay. So in round 1 there is questionnaire development where you collect the data, and finally feedback and analysis of that data is there. In step 3, again it is a round 2. Here what you are doing is you are revising the questionnaire, and then you are collecting the data and analyzing it. Finally, in the 4th round, any other iterative round or a repeated or any other frequent round is required, then that is carried out. 5th is your termination. That means you have reached a particular consensus or a decision. And 6th one is your final report, which will lead to the implementation of the decision, right? So these are the 6 basic steps of a Delphi technique. So the first one, the foremost one, is your panel selection. The first and the most important. Okay, the first step defines your whole journey. So right from the very start, your panel selection should be adequate. So whatever field you are, dealing with. For example, you want some particular information about AI. So your selection of panelists who are experts in AI is one of the major element for a Delphi technique, right? So here you can see identify and select a panel of experts with knowledge and expertise in the subject area. So round 1, we develop an initial questionnaire that includes open-ended questions or statements related to the topic under consideration. Then these questionnaires are sent to the selected experts, asking them to provide their opinions, maybe predictions, or recommendations based upon their own expertise. Then data collection is done, collect the responses from the experts in the first round. This is followed by an analysis of the responses and creating a summary report without revealing individual experts' identity and responses. This is one of the major elements. Anonymity is maintained. The experts are not knowing about each other so that biases can be controlled. right? Because otherwise it will be very influential that, okay, that so-and-so person has said this, so we have to agree this. So the major element is anonymity is maintained in the Delphi technique. Round 2, it is kind of similar similar kind of a round, but here what you are doing, you are revising your questionnaire. So whatever feedback and whatever analysis you have gone through, now what you will do is accordingly you will be revising the questionnaire, you will be making it more refined, right? And then your fourth round, the iterative rounds, that is the process continues with additional rounds as needed until a predetermined level of consensus or stability is reached, or until no significant changes occur in the experts' responses between the rounds. That means when everybody is like, okay, now this is the thing which is required, and accordingly they take the decision. Finally, the termination round. Here you can see it's decide on the termination criteria for the Delphi process. This can be based on achieving a certain level of consensus. Thank you. Certain level of consensus or stability in responses or a predetermined number of rounds, right? And finally, the final report, the most important element, right? So here we prepare a final report summarizing the outcomes of the Delphi process, including any consensus, recommendations, or expert opinions which are reached. So this the final report is prepared accordingly. Now here's a quick example of Delphi technique which is used in the nursing field. So here, what's the scenario like? A research team wants to identify the most effective strategies for preventing hospital-acquired infections, right? So here the round one is experts, that is majorly your nurses, infection control specialists, physicians are asked to list key strategies they believe are most effective, right? Because the persons who are working there in the infection control, they were the experts of that area, right? So it is always wise to take opinions from that panel of experts. So here, after taking that, we do the analysis. The researchers compile the responses and identify common themes. Then, in round 2, experts review the summarized list and rate the effectiveness of each strategy. And finally, in the subsequent rounds, the process repeats with experts re-evaluating their ratings based on anonymous feedback until a consensus is reached on the top strategies. Of course, you cannot match all the strategies, but the base or the aim of that strategies, if it is reached, then we prepare a final report accordingly. Now let's see what are some of the advantages of Delphi technique. Why we are doing this in the nursing field. So first and foremost, anonymity, right? That means confidentiality of all the expert panel is maintained. Here, experts can provide opinions without fear of bias or peer pressure, promoting open and honest feedback, right? So this is one of the major reasons we are using it. Second, it is an iterative process. The method allows for multiple rounds, refining opinions and reaching consensus over time. Although it's a time-taking process, but yes, until and unless the panel is ensured about the decision, then only a particular report is generated. Third, expertise, right? We know here we are not taking data from any Dick and Harry, we are taking the data from your experts, right? So it involves subject matter experts ensuring high quality input and well-informed decisions. Fourth, it reduces groupthink. Groupthink means like it minimizes the impact of dominant personalities, right? And group dynamics leading to more unbiased results. Now, after seeing the advantages, there are certain disadvantages also, right? So, as I think it is quite clear, because it's a time-taking process, right? You need experts for it. So you can say, you can look at it like, half full or half empty kind of a thing. So the advantages are somehow the disadvantages of this method also. Like it is resource intensive, then there is lack of face-to-face interaction, although we are maintaining the anonymity. But that the real time feedback could lack. Because if you are telling me one opinion of yours, maybe you can influence me, or you can compel me to take on that particular decision. But if there is no face to face, so maybe after reviewing it from my own mind, I will come to a particular decision. So that means I cannot influence as an expert to another expert. Then subjectivity. Then results are based on expert opinions, which may not always be entirely objective or free from personal bias. Right? Then consensus may not be achieved. There is no guarantee that a final consensus will be reached, and the process can continue indefinitely. Right? So either if there is a predetermined rounds that okay, after 2 or 3 rounds we will come to a conclusion, one thing can be that. But if it is not predetermined, and somehow if one particular opinion is not being achieved, then this method can even fail. So that is one of the major drawback of this particular technique. So in nursing areas where we can see Delphi, in the major areas, first and foremost is you're developing clinical practice guidelines. So whenever, a guidelines is being prepared, so it cannot be made in one day. You have to go through a lot of inputs from various peoples who have been in that area. After taking their opinions only, you can form a particular guidelines. So to establish evidence-based protocols and standards of care in the hospital settings, I would say, right? It is very much needed. Then identifying research priorities, right? Like what is the need of the hour, right? If I say what is the need of the hour, in what particular field research studies are required. So I need, consensus from that, from a group of experts. Then creating nursing competency frameworks to define essential skills and competencies required for nursing professionals. Then designing educational curricula, okay, in nursing education field also. Like recently we, revised the BSc curriculum. We introduced forensics in it, right? So what was the need of it? Because when the need was seen from all the angles, it was, a particular decision was made that, okay, this particular curriculum should also be introduced in the nursing curriculum. Then assessing ethical issues to gain expert consensus on ethical dilemmas or decision making frameworks in nursing. So here you can see, like, these all listed areas are some of the examples where after doing the Delphi technique, after taking opinions from the experts, we have reached and formulated these guidelines. Then improving patient care strategies, right? In the hospital settings, the clinical nurses. You can ask your experts, you can take guidance from your, nursing superintendent, your ANS, your DNS, and then accordingly, you can formulate your patient care strategies also. Then evaluating healthcare policies, right? In the top level, the decision makers, I would say. Then developing measurement instruments to reach agreement on the content validity of service, questionnaires or assessment tools, right? In the research settings, we send our tool for validation. Yes, we all do that. That is one of the major steps of your research. So that can also be done through your Delphi. Then exploring future trends to forecast developments in nursing practice, technologies or healthcare delivery. So this is major thing which I have explained you, that how Delphi is being done. Now there are certain types also, right, which are a little modified in its own way. So like the first and the foremost, the classic or the traditional Delphi, which I just discussed, in which there are multiple rounds of questionnaires sent to the panel of experts. Anonymity is maintained, feedback provided after each round, allowing experts to revise their opinions, and it aims to reach a consensus or identify area of agreement or disagreement. Second one is your real-time Delphi. In real-time Delphi, what you can see, it uses electronic media or your electronic communication to facilitate faster feedback. So here, experts can see others' responses in real time. So anonymity is maintained. You cannot see who is giving the feedback, but you can see the feedback instantly, right? So it's like real time. It saves your time. So one of the disadvantages was time consuming. So here we can eliminate that. So it allows for continuous or rapid rounds, often reducing the overall duration. Third is your policy Delphi. It focuses on exploring and debating different viewpoints rather than reaching a particular consensus or a decision. It is used for complex policy issues with multiple conflicting opinions, facilitates in-depth discussions of various scenarios and strategies. So mainly for policy making, like in the government sector and all, this particular Delphi technique is being used. Then is your decision Delphi. It is aimed at supporting decision making rather than forecasting. Right here, you're not making the announcement priorly. Here, you are doing this technique to give a particular decision. Here, it gathers expert opinions on options and criteria to make informed decisions and emphasizing ranking or prioritizing the alternatives. So all the alternatives are actually ranked or prioritized. Okay, this will be the thing which will be prioritized first, or a particular thing, or how a ranking system can be made. So all those decisions are being made in this particular technique. Last is your modified Delphi. It starts with a pre-selected set of questions or information, and it may involve fewer rounds or different methods of collecting the responses. It may not always be a panel discussion. It can be, data collection can be in the form of workshops also, right? Or interviews also, one-to-one interviews also with the, I would not say panelist here because it's not, panel discussion here. It can be a workshop or a interview method also. So to summarize my topic, it's a structured consensus method, right? Then expert panel is always involved. It is an iterative process, that is, it is a repeated process. Anonymity is maintained, right? Goal is to achieve a particular consensus or a decision. Advantages, I have discussed in detail, and the limitations also I have told you. The limitations and your advantages are somehow same. It's the way you say it that defines it is a limitation or a advantage, right? And to conclude my topic, Delphi technique is a valuable tool in nursing for achieving expert consensus, guiding evidence-based practice, and informing healthcare decision making. Its structured approach enhances the accuracy and reliability of complex clinical judgments, ultimately contributing to improved patient outcomes and healthcare quality. So with this, I'm winding up my session. If any questions, most welcome.
Thank you, Priyanka. Anybody has any questions? Has anybody ever used Delphi technique in preparing their tool? Good. Asuma madam did it. We did it once for my PhD, one of the PhD person. So there are two people who have used it. There is Anil also has used it. Yeah, there is one. Yeah. Yes, it is a good thing. And then she told us about types and all those things. Very good. Thank you.
Thank you. Thank you so much, ma'am. Thank you for the opportunity.
Thank you so much, ma'am, for such an informative session. I thank the moderators. I thank the moderators as well as the resource persons of both the sessions for their time, and a thought-provoking session it was. We now will have the felicitation of our resource persons as well as the moderators for both the session. First plenary session, which was conducted in the morning, as well as the panel discussion, which was there today. I invite all, both the moderators as well as the speakers, resource persons, to kindly be on the stage. I first invite Dr. Usha Okhande, ma'am, moderator for our first plenary session, to present a memento as well as patka to our resource persons, Dr. Asuma BV ma'am, Dr. Anil Sharma sir, sir. Thank you, ma'am. Dr. Anil Sharma, sir. Thank you. Thank you, sir. Dr. Priyanka Bansal, ma'am. I now invite Dr. Sanchita, ma'am, the moderator for our panel discussion, to present memento and patka to our resource person, Dr. Prema Janardhan, ma'am. I request Usha, ma'am, to join to felicitate our speaker. Thank you so much. I now invite Dr. Lata ma'am along with Professor Sriram sir to present memento and patka to both our moderators for the session. It was great honor to have you both as our moderators for the session. Uh, Dr. Usha ma'am was the moderator as well as one of the panelists in our panel discussion. Thank you so much, ma'am, for such an informative session and your presence in this conference. Thank you so much to both our moderators and all our resource persons. So thank you so much everyone for your patience. I know it's already half an hour late, more than half I know. Thank you for your patience. We'll be moving on for the lunch now. And I request, since the time has already exceeded, we have only half an hour to have our lunch. So kindly be back. Yeah, at 3. At 3, you should be back in the auditorium. Please come back. We need not to call you again. So after your lunch, immediately assemble in this auditorium. Otherwise, we'll be delaying with the sessions further. So thank you so much. Have a great lunch. This session will help us explore how evidence can be converted into meaningful nursing practices. The session will be moderated by Dr. Asuma BV Ma'am, Dean, Aster Mims Academy, Kerala, and the President of NRSI. We invite you, ma'am, to kindly take a seat on the dais. For this session, we have two resource persons. Our first talk on understanding the basics of knowledge translation will be delivered by Professor Dr. Shweta Patnaik, ma'am, the Treasurer, NRSI, and Professor in Choitram College of Nursing, Indore. Ma'am is having over 17 years of experience in nursing education, clinical practice, research, and leadership. Ma'am has authored textbook of adult health nursing, co-authored module on preventive strategies, published and presented numerous papers at national and international forums, secured research grants from ICMR and CSIR. Ma'am has achieved Best Paper and Best Poster awards at national conferences. Ma'am is a state level trainer and mentor for CHO program. Ma'am is also coordinator for Project SPUN and CTP at Choidram Hospital and Research Center. Ma'am is the treasurer, as informed earlier, of NRSI and is also an editorial board member of the Indian Journal of Nursing Studies. We welcome you, ma'am, for your session. And following ma'am's session, we'll be having the session of Dr. Raman Kalai, ma'am, Principal Saraswati Nursing Institute, Chandigarh. Ma'am will be taking session on how to share research findings with nurses, patients, and policymakers in a very simplest language. Ma'am is having 32 years of experience in administrative as well as teaching. Ma'am has won gold medal in her Masters of Nursing and also have got Best Thesis Award. Ma'am is having a WHO fellowship in Thailand in children daycare. Ma'am is Secretary, North Zone Nursing Research Society of India, Founder President Nursing Research Forum 9 PGI, and ma'am is also Editor-in-Chief Nursing Research and Midwife Journal, Guide to PhD Students in Indian Nursing Council Consortium and Baba Farid University of Health Sciences, Faridkot. Ma'am has published various research papers in various nursing journals. Ma'am is also an ex-chairperson, Board of Nursing Studies in Baba Farid University of Health Sciences, Punjab. Ma'am is all 11-member research quality committee is also there, and ma'am is an author of books. Nearly 10 books have been authored by ma'am. We welcome you, ma'am, for this session, and we'll be moving on with the first session of Dr. Shweta, ma'am. I request the audience to kindly maintain silence. Even though we are having few audience, we'll be joining with the others also. And we welcome you, ma'am, for the session.
A very good afternoon to everyone present here. It's truly an honor to be a part of this conference, and at the outset I would like to thank the organizing committee for giving us this platform for this collaboration and representing our organization at this respected platform. I know this is the toughest time, that is the post-lunch session, where actually the brain wants the evidence, but the body wants a nap. But I assure that I'll try to keep you all very energetic with the presentation. So, starting with our topic, that is knowledge translation, understanding the basics. So, sometimes you might have come across a research article that you find very relevant in the clinical setting, and you would thought yes, this would have really been implemented in my hospital. But sometimes it has never been happened, right? And that's here is what the gap that is created between what we know exactly and what is done. So this gap is what we are going to discuss today, that is knowledge translation. So we'll be discussing about the some what is knowledge translation, components of knowledge translation, KT models and frameworks. KT is basically knowledge translation. Barriers to KT, strategies to enhance KT, and role of nurse researchers, and finally concluding the topic. So let me take you to a hospital in Canada where a research team led by Janet Squires noticed that although everyone knew about hand hygiene, that it is very vital, it is very mandatory and an important practice that needs to be done, but compliance among physicians remained very low. So instead of blaming or lecturing, they took a knowledge translation approach to solve this issue. So they applied the behavioral theories to understand why compliance was low, and they explored physicians' attitudes, perceived barriers, and even social influences. And based on those findings, they actually designed the interventions like peer role modeling, or you can say virtual cues and leadership in the environment. And this was published, this article was published as a study protocol, which actually evidenced that yes, knowledge translation helps to bridge the gap between what we know and what we do. So starting with knowledge translation, what do you think? Does it matter in nursing? Yes, definitely, it does. And it actually does it very deeply. So in nursing, it is not just a fashionable academic term, but yes, it is the bridge between the nursing research findings and also the patient care. That is the evidence-based care that we promote. So we already have a huge evidence on infection control policies, the wound care protocols, the bundles, infection care bundles, the safety checklist, and so on. But yet, still, so many hospitals do not practice it. We know that it is important, but then yes, the hospitals are not practicing it. The patients suffer not because the knowledge is lacking, but actually the application is lacking. We know that this is important, but certainly that knowing is not actually valid, but the application is valid, where actually the knowledge would be implemented. And that's why KT, that is knowledge translation, matters. So over 90 different terms have been used here to describe knowledge translation, from knowledge mobilization to research translation to transfer and exchange, and all of them point to only one idea, that is turning what we know into what we do. So this is also word cloud here. You can see the synonyms of the knowledge translation, knowledge mobilization, the transfer, the implementation, and so on. So what do we mean exactly when we say knowledge translation? By Kathleen Sibley, that was given by the Canadian Institute of Health Researcher. She defines KT as a dynamic, iterative process involving synthesis, exchange, application, dissemination of knowledge to improve the healthcare system, and the healthcare service delivery. So in simpler terms, we can say that KT is all about making sure that research doesn't just stay in the journals, but it reaches to the patients, to the communities, and to the policy tables. So KT exactly is moving beyond simple dissemination of knowledge into actual use of the knowledge. It includes, it starts with the knowledge creation. The knowledge creation basically includes the primary research studies, the qualitative, quantitative research studies, the systematic reviews. And then it has to be promoted, and then it ends up with the knowledge distillation and knowledge dissemination, and with the action that this knowledge is applied into real practice. However, just creating or disseminating information is not enough. KT demands engagement. Engagement, bringing the researchers, the clinicians, the policymakers all together at one platform, so that actually what the evidences are present can be implemented and bring into action. For example, imagine discovering that a new wound dressing has come and it reduces the infection by 50 percentage, and KT, that is knowledge translation, exactly ensures that it reaches to all the hospital settings so that the patient may be benefited by it. So if it remains just in the journal, or if it remains just in the shops, so it is not enough. So finally, a great definition or simpler definition of knowledge translation can be getting the right information, to the right people at the right time and in the right format so as to influence decision making. For nurses, knowledge translation is necessary, or why the nurses should care about so much. First, because we are the largest clinical workforce. Our decisions are directly influenced by our every single action that we do for the nursing care, for the patient care. Exactly. Second, failing to use proven practices means wasting our resources and, more importantly, potential harm to the patients. There's no use if we have done a study and we are not using it. And thirdly, KT reduces the unwarranted variation in care, meaning that no matter which nurse or to which hospital the patient goes to, but finally the care remains evidence based and it should be consistent. So KT is not just an academic concept, it is a patient safety and quality improvement tool that every nurse should use. When we engage in KT, we strengthen the credibility of nursing and also interventions and shorten the time between discovery and also the improved outcomes. When we say knowledge translation, the components are four in number. That is knowledge creation, knowledge synthesis, the dissemination, and application. So we'll see in detail knowledge creation, that is where the evidence is actually generated through studies, different studies, the cohort, the systematic reviews, the qualitative or the quantitative one. Then once the knowledge is created, we need to synthesize it. So synthesize, actually the evidence is combined, it is compared and then evaluated. For example, in systematic reviews or the clinical guidelines that we have. Then we have the knowledge dissemination. This means that sharing of evidence in a usable form through policies, the training sessions, the workshops, or maybe on the social media, how we are disseminating it. And finally, when it is disseminated, we are applying it. That is the knowledge application. That is adapting the knowledge to that particular local context according to the setting of that particular unit or the hospital setting. So for instance, after reviewing evidence about hand hygiene, you adapt it to your hospital environment. And what is the proof? You decide where the dispensers need to be placed. You monitor the compliance rate. You see that everyone is practicing it, and then a feedback is given. So this is how something, an evidence is actually generated, and then it is recorded. So you can see here that it actually takes 17 years to turn 14% of original research to reach to the patient care. So this is a huge gap that was given by Ballas and Boren long back in 2000. And why does this gap actually exist? So first, up to 95% of patients report dissatisfaction with the information they receive. Meaning, even when we know the right evidence, it isn't always that this is communicated effectively. And therefore, who is the sufferer? The patient, who is the sufferer. Second, there's limited use of research in policy making. Health research is rarely applied consistently across all stages of policy development. And as awareness of this problem grows, more KT initiatives are being launched. But then again, changing behavior is a complex one. It's not essential that all the organizations would accept it. So therefore, it requires tackling the organizational barriers as well. And like poor health information system or the communication gaps or the influential support is not present. And therefore, the evidence is not being implemented. So ultimately, our goal is very simple: to achieve a better health outcome through evidence-based care delivery, ensuring that what we know exactly is truly implemented. So this is again a very good picture. You can say that is a research article that shows the valid research and the actual clinical benefit. So how the research is conducted and how much it is being implemented actually into action. So every stage you can see here, from when the research is produced to when it is finally coming to the patient for its usage, we lose a little effectiveness. These small losses or leaks, you can say, accumulate and significantly reduce the overall clinical benefit that the patients receive. So each stage, from being aware or accepting it or applying it or being able to use it or agreeing upon it, adhering to it, experiences some small leaks or loses its effectiveness. Even if we lose just 20% of benefit at each step, only about 21% of research is full in its full potential actually reaches to the patient. That means nearly fourth-fifth of the valuable scientific knowledge never turns up into patient care. So this figure reminds us that why knowledge translation is very important. This is again one research article, research study that was conducted by the bioengineering and the biotechnology people, which actually is a clinical trial which shows the lost in translation, the gap in the scientific advancement and clinical application. So it begins in different stages. So here at T0, where basic and animal studies were identified. At T1 stage, it was translated to humans. That is, those discoveries are tested in humans through different phases and checking the safety and proof of the concept. Finally, in stage 2, that is T2 stage, that involves a larger clinical trial that confirms that effectiveness and guides the evidence-based care. At T3, it focused on how to apply these findings in daily practice, ensuring that right care reaches to the right patient at the right time. And finally, at T4 stage, it extended that knowledge should reach to the community and public health level where society experiences the true benefit. So where is our role in this? At the stage T3 and the T4, where the nurses, the clinicians, the healthcare personals are involved, and we have to experience it, and then we have to make them reach to the community people so that the patient gets the maximum out of it. So when we talk about the KT models and frameworks, there are many, and out of that I have chosen 3. That is the very important ones. That is knowledge to action framework. Then we have Paris framework, and then the ALVA model of evidence-based practice. The knowledge to action framework says that it was developed by Graham et al. In 2006. It connects basically the knowledge creation with an action cycle and showing KT as a continuous process that is in the cyclical form, showing, implementing, evaluating, and finally refining it. So this is the KTA cycle that is in cyclical manner where you can see the cycle, and at the center you can see the funnel. The funnel actually resembles the knowledge creation. Okay? So knowledge creation includes the knowledge inquiry. The knowledge inquiry, from where we can get the inquiry? From the primary research studies, from the systematic reviews, from the qualitative and the quantitative research studies. Then it comes to the synthesis, summarizing the evidence from the multiple studies. Finally, knowledge tools and products are created, that is the guidelines and the protocols. And then identifying the problem, that is determining the gap between the current policies and the practices. Adapting knowledge to the local context, that is modifying it, modifying the guidelines as per the clinical setting of the hospital. Assessing the barriers and facilitators to the knowledge use. That is, the barriers can be organizational, it can be personal, it can be sometimes related to our own barriers, that is the personal barriers itself. Select, tailor, and implement the interventions where we need to use the strategies like training, reminders, audits, and recording. And then after that, finally, we need to monitor the knowledge use. That is how the knowledge is being applied. Once it is monitored, the evaluation outcomes need to be done. That is measuring it, how, whether that particular evidence that we have implemented is for the betterment or not, whether it is useful or not. And finally, we need to sustain the knowledge use. That is ensuring that changes are made, not at the local level, but then it is, yes, embedded everywhere in the hospital. So this is about KT. Coming on to the next one, the KT, that is knowledge to action framework in short, is starting from the knowledge creation to the knowledge application, including the diffusion, research utilization, knowledge translation, and implementation. The second one focuses on Paris framework, that is promoting action on research implementation in health services. That IPARIS is the updated version that was given in the year 2016. That actually highlights that successful, there is an equation here, that successful implementation, SI, is equal to the function of the evidenced, the context, and the facilitation. Or in simpler words, we can say the strong evidence alone won't work unless the organization culture supports the changes and someone actually facilitates it. So here we can see this picture that highlights the success of putting evidence into practice depends on 3 things. The evidence that actually includes not only the research, but the clinical practice and the patient practice. Then the context, That actually refers to the environment, its culture, leadership, and evaluation process that supports and resists the changes. And lastly, the facilitation, that is the holistic purpose. That is the active process of helping people implement evidence through guidance, motivation, and its support. So even the best evidence will fail if the workplace culture is not supportive, right? The evidence will lie just in the journals, but it would not reach to the patient safety or the patient care. So when all these three components, that is the evidence, the context, and the facilitation is strong enough to implement, effective and sustainable care can be provided. And the last one is EVA model of evidence-based practice. The recent updated version was given in the year 2015. This one is very particularly a nurse-friendly application of knowledge translation. It helps to identify the triggers like recurring patient issue or the new evidence. Together, these models provide all the practical roadmap for making research usable. So when we talk about EVA model, this is the ray diagram, the algorithm, that is how it is being used. So actually, we need to see that what are the triggers. The triggers are basically divided into two things, that is the problem focused triggers and the knowledge focused triggers. We need to identify these triggers first. Thereafter, once the trigger is identified, we need to plan, we need to form a team, that is a multidisciplinary team, including the nurses, the physicians, and other stakeholders to analyze the issue collectively. Finally, the team then reviews, critiques the best practices and evidences, considering the patient preferences and so on. And if the evidence supports a change, then that particular thing is pilot tested. The pilot tested in a small area with a limited group of patients, monitoring the outcome and actually witnessing that whether this implementation is successful or not. Finally, if the results are positive, the change is implemented organization-wide. This is very important. It should not be limited, followed by the ongoing evaluation and dissemination. So what makes the EVA model effective is that it is a team-driven approach. It is not only one single person who is actually utilizing the findings or maybe developing it or considering it, but then yes, the organizational support is very important and therefore the best evidence can be generated. Finally, coming on to the barriers to knowledge translation. Here we can see the individual level, then the organizational barriers are there, and also the system level barriers are there. At individual level, the nurses may lack confidence in delivering and appraising the research or may prefer some familiar routines. They may not go for it or not take action for it. At the organizational level, there may be insufficient time, staffing, or access to the updated database. And at the system level, policies or administrative delays can also happen. For example, a new infection control guideline might exist, but without institutional support, one cannot go forward for it. So support for training or supplies is actually required. So recognizing these barriers is the first step towards acknowledging or overcoming them. So individual nurses hesitant to follow the new protocol due to familiarity with the old methods. At the organization level, there is no access to the latest database or the journals. And finally, at the system level, the policies are delayed. You know, the guidelines would be there at the journals or at the local level, but then it would not be implemented unless the system is actually applying it. So strategies, how to enhance the knowledge translation. These are the steps towards it. So to make KT work effectively, we need a multi-level approach. Capacity building, leadership and champions, then collaboration, technology, some implementation strategies, and monitoring and feedback is important. So in these particular steps, how the nurses can actually play an important role here. So when we talk about capacity building, we need to train our nurses in interpreting and applying the evidence. Leadership support is important. The nurse leaders must be a model and reward the evidence-based practices. And then collaboration, partnership between the clinicians, the researchers, the stakeholders, the policy makers are vital. Technology integration, the digital tools, apps, and dashboards are actually easily accessible, and that is very important. Then finally, once it is integrated, we need to monitor it. We need to see the outcome, whether the implemented strategy is beneficial or not. So regular audits and discussions ensures that yes, it is sustainable and improvements can be done. So when all these strategies work together, KT becomes a living part of the organizational culture, and it just not sits in as a research term or an academic term, but it is actually being used. So this is all in short about KT. So let's discuss with an example, that is an hand hygiene initiative, a stepwise application of KT. So hand hygiene initiative, first we need to assess the problem identification and a baseline compliance, and the infection rate has to be set. Next year, we need to review the literature on the effectiveness of the interventions. Then engage the key stakeholders who all are going to use it, the nurses, the housekeeping staff, the infection control nurses, and the patient. Implementing a short pilot, say a 4 to 6 week intervention with the reminders and the audits. And after that, we need to monitor the progress, that whatever we are implementing or executing is being done correctly or not, and therefore the monitoring is important. Finally, evaluating the outcome and scaling it up if successful. And this example finally captures the essence of KT, where research evidence is being co-designed, that is tested, and that is sustained by the nurses for the better patient outcome. So finally, summarizing the topic, it is the knowledge translation is equal to the actionable evidence. Whatever we have learned, whatever we are doing, whatever we know it should be done. It should not stay in the journals or in the tables just. It isn't enough to generate knowledge. We must ensure that it is actually applied in the real world. For that, we need a good evidence, supportive context, and skilled facilitation. Remember that just don't generate the knowledge, but we need to translate it, we need to apply it, and we need to measure its impact. Even small, consistent actions can bring large-scale improvement in the healthcare industry. Concluding the topic, knowledge translation truly brings evidence to life. It bridges the gap between research and practice and ensures that discoveries, it actually translates into healthier lives. And the nurses play a very important and crucial role in bringing the evidence into actual care for the patient benefit. So let's continue to strengthen the culture of evidence and evidence-based nursing, where every new idea is actually finding its way from the lab to the bedside, where the patient is actually benefited. These are some of the references. Thank you so much.
Thank you, Dr. Sweta, for giving such a enlightened information on knowledge translation. Do you have any questions to Dr. Sweta? Anybody? Okay, I hope you understood very clearly. She explained, but one thing I wanted to add to it, that is knowledge translation is now a science, a form of science. It is entirely different from knowledge utilization. Knowledge or research utilization, I should say. When we say research utilization, it may be with one study, somebody has found out something, and in the context of that area, they may be utilizing the findings to improve patient care. But in knowledge translation, she said, she has clearly explained the steps, synthesizing the knowledge from different parts, and then analyzing it, then disseminating it, and application of this knowledge comes as translation, where there are a lot of other things comes in, because if you are finding out something in the research study, for example, I remember how practice has been changed in Vellore Medical College in 1988. When I was a student there, the pulse oximeter was first introduced to India to Vellore. It was a clinical trial, and in pediatrics they wanted to test the oxygen saturation. It was a big machine, but now you see the handy pulse oximeter. First pulse oximeter was like something of this cushion size, more than that, and with lot of wires and inserting batteries, all those things were there. That was the first pulse oximeter, which was donated to CMC Vellore by John Hopkins University. They wanted to do clinical trial in India. And fortunately or unfortunately, I became the victim of that because I was doing masters in pediatric nursing. I was got hold by the department head and asked me, you do something with this, find out the oxygen saturation. Then I have proposed a study to find out the effectiveness of oxygen delivery, two methods of oxygen delivery. One is stent and one is the nasal catheter. And we found that 10 we use for 1 hour, 9 liters of oxygen. And for a nasal catheter or cannula, we use only half liter of oxygen. At that time, the 1 liter of oxygen costs about 19 rupees, 19. Now you know it is very costly oxygen. We in Delhi people buy oxygen to breathe. That is what I heard. I don't know. People say that they keep it in home also. So what happened is finally I was asked to prepare a tool to find out what is this oxygen saturation level and the child's symptoms. If it was 90% of oxygen saturation by the oximeter, what will be the symptom of the child with respiratory rate, pulse, and Ronge rails, all these things, physiological parameters. I compared and made a tool, and finally what happened is this findings came out that oxygen saturation improves with more with the nasal cannula than oxygen 10. Only thing that it is little bit uncomfortable if catheter is introduced because it goes to nasopharynx. If it is a cannula, bronch can be connected here. Still, that is better than a oxygen 10. And Vellore Hospital, once the result came, they found that their oxygen cost will cut because whenever the research comes or findings comes, people, the management people will think about the financial aspects of it. So what they said, we will try with this, and they have removed all the tents from the hospital pediatric department, and they started using nasal cannula, and still they are using nasal cannula, not the tent. That is utilization. I want to tell you that is research finding utilization. But translation is entirely little bit more. Now in the era of evidence-based practice, knowledge translation is more important because from different sources you collect data, knowledge has come. Then you synthesize as Shweta has said. Then she has given a lot of examples, lot of studies about it and how the protocol will be going on. And I bow my head to you. You did very well. Thank you.
Thank you, ma'am.
I now invite Dr. Raman ma'am to kindly proceed with ma'am's session.
Good afternoon, everyone. Half of the job is already done by Dr. Shweta, and still it is an important topic to discuss how we can deliberate, implement, disseminate the findings of our research, basically for use of nurses, to the patients and the policymakers. This is the topic outlined as by the organizers have been given to me, and I'm so very thankful to be part of this conference today. And I thank the organizers for giving us this opportunity to discuss together. When research comes for implementation, there are many methods, ways, and small things which make a difference towards uh, implementation of the results, implementation of the findings, their usage to the common people, to patients or nurses. So let's just discuss and revise many of the things we are all already familiar with, but still it's the need of the hour that we pay more attention to the implementation of our research and how we can put up our reports, findings, and all these things for the. Is it okay? So with these objectives, we'll try to understand why dissemination is required as a part of research, and we'll try to know how to tailor our message for nurses, patients, and policymakers, and what frameworks should be used for implementation, and whether our communication or putting up the reports and findings was able to make a difference in evaluation of implementation of the research. So just the outline would be importance of research dissemination, what are the principles of communication, what are the needs of stakeholders, and how we can communicate with nurses and peers, what are the barriers in communication, communicating with patients, caregivers, and policymakers, and what are the effective ways of communication. We all know that research contributes meaningfully to healthcare only when its findings are effectively disseminated, communicated, and implemented. And patients and policymakers are the ones who are using these findings. The nurses, because we are talking of nursing research, so we are more concerned about the improvement of nursing practices, and whatever research is being done, the ultimate aim is the improvement of practice. So from that angle, we always target our interventions or findings to reach for the benefit of the patients or the hospital policymakers or the administrators. Why communicating of research finding is crucial, and effectively we have to ensure that it has understood by the intended audience. Whosoever we are communicating, they are also understanding it in the same perspective with which the researcher has conducted the research. Now there is a gap in knowing and doing, or knowing and practicing, or knowing and implementation. So this gap is to be filled, and advanced professional practice and patient outcomes are targeted. So institutional policies, public health decisions are to be made, and the research has to be collaborative. In the morning also we discussed the multidisciplinary research or collaborative research. Again, all are targeted towards the benefit of the patients. Then why should we use simple language? Because in simple language, people understand the things in their own way. If you always present some graphs or figures which may not have a background context, people will not understand. So many times it is easier to communicate in patients' language, to people's language, and in the easy to understand language, because we have got diverse audience. And it encourages the application of evidence in the clinical practice. It builds the trust and engagement between the researcher and the community, and also reduces the gap between the real world translations or problems. The important key principles are, when we know to whom we are talking, we can talk in that language. Maybe if you're going to the community, you will talk in people's language. If you are talking to some policymaker, you may present your findings in the form of a report. And if you're talking to nurses, maybe you can talk in any form which they understand. We have to focus on what we have done instead of many times going into the details of methodology and other things while communicating the research findings. We use only simple language and visuals which can make the findings and the results easier for the persons to understand. So we define only one decision at a time. If you will bombard with the information, too many things altogether, people may not understand, and your message is not communicated and research is not implemented well. Always we have to find the barriers and motivators which will work. What are the obstructions in implementing or understanding the concepts? And we also use the channels which are already people familiar with these days, WhatsApp groups or the social media. Many people are using as channels for transmitting their research findings. But many times social media findings and all become very unprofessional. People these days are in a habit of putting their research papers on Facebook. I don't know, many people may be liking it, but I personally don't feel any liking towards it, where everyone who may not be a researcher, for example, I put up my research paper on Facebook. Half of my relatives, my family, my people who are not even knowing what is research will say congratulations. Will that congratulation matter to me? I don't think. So this is my personal opinion, but these days it's a fashion. Many people put up these papers on Facebook. It's everyone's individual decision. But basically the findings should be put wherever they are useful, how they are implemented, and whosoever will be benefiting. If we target even one person, we are probably achieving the result of these things. And we have to be very realistic. Rather than showing off the research has been done, realistically achieving the goals is more important rather than mere show off of doing the research. So basically, when we talk in the hospital or the patients or the nurses, they all have specific needs. And for the research implementation, also the stakeholders will target specific type of interventions and specific type of informations. And as researchers, we should be giving the result reports in that way only. For example, for talking to the nurses or peers, we should talk about the implications for practice. What will be the useful of this research in terms of improving the nursing practice? Probably the nurses will understand better. For the patients, we have to tell what is easy, what to do in their accessible language. And for the policymakers, they are more concerned about the cost, effectiveness, feasibility in the institute, practicability of the ideas. So we have to target our audience in that language and in that perspective wherever they can be useful. So let's discuss one by one how we can target our findings for nurses, for patients, and policymakers. If we start with nurses, nurses are all qualified professionals, we all know. And when we say research is not published, is not research done. So it is very, very important when we do even a smaller study, it's important to publish that study and make it available for reading to our own peer, our colleagues, and share the knowledge with them so that with whatever idea, aim any nurse has conducted, that results findings should be benefiting to the patients. And it is not complete, it is written up and the findings have been communicated. And so finally, they should be important part of the research process. While communicating to the nurses, we should emphasize about the clinical relevance, what difference this practice can make in the clinical use, and the key points, what was done, what was found. We should be discussing it in conferences, workshops, in-service programs, practically, in the newsletters of the institute or professional conferences. For example, if you are to say some nosocomial infections are inversely correlated and hand hygiene practices improve it. So instead of putting sentence like this, the simple thing can be that good hand washing habits will help reduce the infection. This is easier to understand. if it is a result of a study, when we put up in a simple language, our own colleagues will easily follow that. Also, we should lead with the problem and discuss what's new found in this particular context. Always we use IMRED format. We are all familiar with this. This makes the thing reporting very systematic. And also we can tell ideas about the recommendations about the future studies, how we can improve upon, how data can be shared, what all things can be contributed, and checklists, etc., can be shared with colleagues. If we are to submit some reports for nursing people, we should be just talking about the introduction, because all of us know that in introduction we are to give what was the current problem, what was the goal, and what we have achieved. In the methodology, we are to tell the details of methodology, what was the topic, sampling, methods, setting, etc. All that should be covered. In results also, a shorter description of what was found with the help of tables, graphs, because nurses are qualified people, so they can understand this, so you can structure your report in a great detail for submitting it to the nursing colleagues. Discussion of the topic and references should be included carefully, because if someone wants to replicate some study, the references should be written clearly so that people can make use of it. Also, you summarize the whole report, write with the objectives and the use. And if you are submitting this in writing, it should be interesting and people should be able to read this and should be able to capture all the key elements of the report. Also, there are other methods of sharing results with nursing colleagues only. You can have journal clubs, webinars in the department. You can write in the hospitals, conference presentations, research papers, publication in various journals and all. For example, if some nurse has conducted a study on urinary tract infections or catheter-associated infections, so this is an important study which can have implication on other care practices. So studies like this should be communicated in the right perspective to those particular departments where a lot of catheter-associated infections are occurring or where catheters are being used. So sometimes you can adopt this type of study and implementation in the specific type of departments for communication or improvement of research practices and show the results if it has been able to reduce the infections. There are many times barriers in communicating the research results. Most of the time nurses will complain of overload and many times they are actually having patient load. So they are not interested to do research. There is lack of support from colleagues. Not all people in the department, not all colleagues or all people will have same research orientation, research interest, and many will have not cooperation from higher authorities. People, sometimes the administrators discourage, they don't listen, and they don't promote adoption of new policies, new results. So that also is demotivating, and many times people don't feel like doing research because they are not heard. And sometimes there is lack of funding or communication things, and so there can be some barriers where nurses are not able to conduct research or not able to communicate the research findings. Then we have the other area where we have to convey our research findings to the patients. Along with patients, I have added caregivers, because many times the patients are not the ones. If the patient are not able to do anything at home, they are assisted by the caregivers. So whatever information you are giving to patient, it is always better to communicate along with to the family, to the caregiver, because they'll be helping the patient to use that practice. So we include the family or the caregiver as well. So the purpose of patient communication of research is we are giving education and it is behavior changes required. Suppose you are to teach blood pressure monitoring to a patient. You want the patient to be knowing about the importance of managing the blood pressure, and you want to have a record. So you have to teach correctly, then you want to see its implementation correctly. So it's important to involve the family or the caregiver as well with the patient. And these can be many times, the needs can be disease specific. For example, for an anemic patient, it can be diet related. For a hypertensive patient, it can be monitoring. For any other patient having chemotherapy and all, it could be prevention of infection. So sometimes you have got disease specific patients and you will give specific information or research related results to the patient for according to the disease. And many times these are general things, general health promoting behavior. For example, hand washing you can teach to all family. Use of sanitation, good hand hygiene practices, good cooking habits can be taught to all. So depending upon the needs or the topics, you can involve the family or the patient. Many times patients should be taught with in the plain language, easy to understand language, in their own language, keeping in mind their cultural beliefs and readability. If they are, sometimes we start giving lecture or we start teaching without knowing their social background, they are able to read or write. It's always good to ask, involve them in the discussion, and then convey your information. If you are using some posters, you should be giving some large fonts, culturally relevant examples, or always tell them the side effects, whatever are, if you are implementing some interventions, what can be the problems or side effects also can occur. If you are using some visual aids, your message should be clear, label it clearly, figures, numbers, test comprehension between the people that they are able to read, they are able to see from a distance the picture or the graph. Whatever you are using should be able to convey the meaning of what you intend to be as a researcher. Many times we tell the patients as a case study or findings of your research as a case study in a storytelling manner, in an applied manner, where you want to see the result of correlation with the cause, why this effect was occurring, what is the effect of this intervention to a set of patients. And you discuss that. You cannot say anything which will have miracle benefit. Always the research or the findings or the counseling, whatever is conveyed to the patients in simple words, patient will be retaining some information and then later applying it in his daily life. If you are giving some intervention, you have to make sure that patient is practicing also. For example, even simple hypertensive patient, if you are teaching BP monitoring at home, it is very important to make sure that patient is doing daily and someone is observing it. If the patient is recording it, so all those things have to be kept in mind and then you expect a result from the patient. So you have to connect your findings to the real world. Always should not assume that whatever you have said 100% is understood by the patient and 100% will be implemented. This may not be the case. We have to frame our research in a narrative that patient will remember. Many times patient will just remember the context in which the doctor or the researcher was telling that particular point and which point to be highlighted for the patient, keeping in mind the patient's particular problem. And if you are talking to a group, all patients may not have similar needs. So sometimes you can be very selective in knowing what information related to this particular topic they want. Somebody will be knowing half of the things and someone may not be knowing anything. So one size fitting all approach may not be possible every time. So whenever you're talking to a group, you should be keeping in mind the needs of the whole group, and even there is no problem repeating the topic, repeating the content, or even asking the patients about their needs and understood what they have understood, discussing them, asking questions, and keeping in their mind all the myths, beliefs. If they are knowing half of the things earlier, many times patients want to clarify the doubts. They want to sometimes compare the information given by a doctor, by another nurse, or you. So patient, we should be giving that atmosphere and interaction to the patient so that patient feels free to talk. It's very, very important to keep in mind the ethics. ethics of privacy of the patient, whatever information we are giving related to the results of a particular study of patients to the other set of patients or to the audience, we should keep in mind the confidentiality and privacy. We should always highlight the personal details of the subjects. These are standard things, copyrights, licensing, and if there are any conflict of interests or fundings, etc., that also should be highlighted. For example, in a patient, if you are teaching the patient self-management of hypertension, the problem is poor adherence because you're not going to the patient's home and you are not monitoring yourself. So you are relying upon the reply which the patient is giving you. And you can always emphasize with SMS reminders, with these days with video calls, with messages, whatever text messages. And you can disseminate this information by using a leaflet in plain language or WhatsApp, or in the hospital you can put up the posters how to monitor. And this you can see that the controlled BP patients would improve because the dissemination of the information or the research results was like that. The patients felt like keeping a record of BP, monitoring, dietary advice, or whatever was told to them. The improvements can be seen and highlighted. So the last part is when we have to communicate certain research findings to the policymakers. This is very essential and important in terms of improving the nursing practices. It starts from where this report is to be submitted. It is to be submitted to the ministry or to the funding agency or to the institute. If we are submitting it to the ministry or funding agency, maybe it is in reply to the standard format in which we got the grant or we got the permissions. If we are submitting to the institute, it is for the improvement of the practices. So you can always tailor your report or your write-up according to the needs of the policy and prioritize what is the agenda of this report and how should I write, which issues are urgent to be highlighted and in the way. And in this also, policymakers are always aware of many things, but what this particular report wants to be communicated. So what are the knowledge gaps for the policymakers after this study? For example, we always say shortage of nurses, but if we have to report shortage of nurses, there has to be certain measuring terms, there has to be certain reporting parameters from where we have come to this figure of shortage of nurses. So a broader idea reported in an accurate manner will be appreciated by the policymakers. The message should be very, very clear. Many times, if you give 50 pages report, nobody is interested to read this report. So they will just read the abstract or the summary. If it is the first two lines are catchy, one may feel like reading it. Always you should frame your message in terms of outcomes. For example, in the hospitals, the cost is one thing, always. Manpower requirement is one thing, patient safety, patient concerns, infection. There are certain terms which are very much liked in the reports, or many times the government programs needs to be highlighted in the reports. That may or may not be practically possible and good, but the administrators want to read the reports also in a particular format. If you are submitting the report to the policymakers, the title should be short, clear, background and problem statement should be appropriate. The findings should be in the current accessible knowledge, implication, recommendations only and references. The report should be very, very crisp, submitted to the policymakers. Again, use plain language, keep the report to a brief of 1 to 4 pages, but all the information results should be given very clearly. If attention is paid only to the diagram or to the table, it should be clearly highlighting what you have got after this research. The decision-making context. What action as a researcher is expected from the administration or the policy maker as a result of this research, what action should be taken, should be highlighted. It's not just handing over a document many times or posting the document or sending an email. Wherever possible, especially in your institute, it's very good if you can follow the submission of your report. You can personally deliver the report to a policymaker, to a senior administrator, and find a time where you can discuss your findings also. Because if you happen to talk, happen to meet or share your findings in a casual way, probably these are better understood or paid attention by the administrator rather than reading a 20 pages report or report given to a clerical person and put up to the administrator may not pay much attention. So one should be very, very careful when you are presenting your research findings to the policymakers. Keep these things in matter. For example, timing. Sometimes people are in a very hurry and we also don't have much time and we just go and meet, quickly come back. So always find a time to discuss, sort a meeting, sort a personal hearing, so that your research is given some importance. One should be using channels, but in-person briefing is very, very important. And stakeholder meetings, sometimes you are asked to present your research findings in a meeting. There also, it is very important to pay attention to who all will be present, who will be attending meeting, what will be their interest, how can your research be discussed in that particular meeting, and what emphasis you can make in that meeting presenting your findings. And in that also, it is very important to talk in terms of patient safety, patient benefits, because if it's a hospital, everyone is concerned with the patient care. Follow up and evaluate what your research can do in policy change or policy implementation or making some new rules or providing some new informations. And sometimes if someone asks how it happens or how it will be useful, again, you should have a very clear idea about the result. This is the result and this change it can bring towards the patient care. So you should be knowing what to talk. Many times, administrators are not in a habit of reading or listening long stories. So you can just keep in your mind just 2 sentences while talking to them. A crisp response will be always appreciated in terms of cost. It will reduce this, it will reduce infections. So you can tell how the implementation issues can be handled. It is very important to discuss and link directly to the nursing relevant policy areas. Then only someone will pay attention as, for example, quality of nursing care, nurse patient ratios, training, education of nurses. Use your data findings related to the improvement of patient care, challenges in the hospital care, rural care, or problems of nurses. So if you highlight your findings in this way, probably they are better understood. Suppose your researches are local, it is important to talk in context of people, their habits, their wayouts, their improvements, local examples, and highlight how your findings are helping in that setting, improvement of people there, nursing experiences, and one should be ready to discuss the feasibility, how these can be implemented, what can improve the practices, what can improve the uh, health of the people in the community. So we should be knowing that also, and we should be discussing that. A brief outline for a policymaker could be, for example, the title is Improving the Nurse Staff to Reduce the Patient Falls in a Hospital. So what one can have a message, the patient safety is a priority. So keeping in mind you have this study, that the policy option could be either you have maximum staff or you can invest in nurse-led fall prevention, education or training. So the management might think that instead of increasing the manpower, let us give some education to people, so, nursing people, how to prevent fall of the patient and how can we ensure the patient safety. So the idea can be put up to the policymakers that training or teaching a new idea or teaching a new technique can ensure patient safety. So this kind of studies can be put up. If you are talking about the staff policy or safe nurse patient ratios and overload of nursing works or overload of nurses is leading to the fall of the patients and readmissions, you can disseminate in 2-page policy brief and then discuss the ratio of the patients and the nurses and what improvements can be sought, and a longer period. In the morning also we were talking about the implementation research. Now also we were talking about the translational research. So this can depend upon various kind of topics. What topic can be talked in which way and can be made in brought into the notice of the policymakers for improvement of nursing practices. Of course, when you are communicating to the policymakers, we should focus on the key communication outcomes, align findings with the national health policies or the programs, avoid lengthy reports, use policy briefs, highlight the measurable terms, and for example, if we are training the nurses for early detection of complications, it will reduce maternal mortality. So this will help in achieving the SDG goals. So in those terms, the official terms or the specific terms, if you present your report, these are better understood for the policymakers. You can have press release, media partnerships, policy briefs as other way of communicating to the policymakers. And to summarize, the tools for effective communication could be the meetings, public channels, community outreach, and policy forums for the policymakers. If the reports are not to be submitted, then the reports can be highlighted in some of these ways. It is very important to see the evaluation that did your research for whom you have conducted and you have communicated has reached, message has reached, or it is not. So you have to have some audit and feedbacks to see the implementation of your research in way of checklists, records, interview focus groups, how people have understood. If the patients are there, as I said, you can take feedback from the patients, survey questionnaires, observations, knowledge implementation, what habits were corrected, what behaviors were changed. For example, hand hygiene, we all have taught a number of times, and we are seeing the improvement also in hand hygiene habits. So these kind of feedbacks are important for the evaluation. Just to summarize again, the nurses and peers for academics, we should focus on methodology, data, theory, and format our examples, giving in them in journals, articles, conference papers. And if you are conveying the research findings to the patients or general public, it is always to be focused on relevance and simplicity of language. You can disseminate them through the videos, pictures, posters in the hospitals or pamphlets for their homes. For the policymakers, you have to focus on the implication, recommendation, appendices of the reports for the institute, and you can put up them in the form of executive summaries, reports, presentations, etc. So just to conclude, that big problem in healthcare today is the research practice gap. And often this is caused because of failure of dissemination of the new knowledge, and either the research results are not disseminated, or even if they are disseminated, they are not able to produce the desired results because of lack of understanding or lack of communication, both. And shortage of manpower is often there and is always there. So everyday nurses face dilemma in clinical practice. Whatever practice they can do, they do. And research always is not appreciated by many, and many are not interested to do and conduct research. And the practice is different. The context practices are different. The research practices are very different. And an attitude to change, again, is a very big challenge. But exposing this gap is always important, because if we will expose, we will come to know our shortcomings and we will try to improve them. So it has to be emphasized for ensuring the improvement in the nursing practices. If we are to improve the nursing practices, it's important to discuss research, disseminate research, and make the research findings in front of everyone. With this, I finish. If you anything want to clarify, or if you want to add some other ways of communicating the research to patients, nurses, or policy briefs, it would be good to understand and interact. Madam can
Thank you,
contribute.
ma'am. It was a very wonderful presentation with your long and vast expertise and experience. You did it
Not
well.
longer than you, ma'am. My pleasure. Very humble and so
No,
frightened to speak in front of you.
no, because your experience, your learning from PGI and all those places, no, that contributed for this talk very well, and you talked in very simple language. I hope there may not be any questions to ask her because of that. Even if you have any questions, please come up and ask. Anybody? Any questions? No, that was Dr. Jyoti Sarin was supposed to talk because she was not here today because of her illness. Otherwise, we would have talked that also in this panel. Anyway, thank you very much for your talk. And I want to add upon something. I want to tell you a story where she was telling, no, communicating with people. In Tamil, there is a saying, "Sabai arinju peshi," means know your audience before you talk. That is very important. Because now when you talk to people, when you are communicating to somebody, you should go to the level of the people. Then you have to talk. You know about Abraham Maslow. You have learned about hierarchy of needs. See, when he stated he is known as a high, he let higher intellectual, like that. His name is like that. But when he wrote about the hierarchy of needs, anybody can read. Even a fifth standard student who knows English can read about it and understand hierarchy of needs. That type of presentation is important when we present something. People have a feeling that if you are using academic jargon only, the Scopus articles will come out or Web of Science will publish your articles. It is not like that. Go with simple past tense when you are writing articles for publications. That is very important. That you must know. Everybody must know. There people mix up tenses and all those things in writing. They forget about grammar. I know that English is not our language. It is an illogical language. But when you use that illogical language, the rules of that language has to be followed. That is the reason. Then anyway, again, she was talking about policy makers. I was feeling, I wanted to laugh at that time because I have a very interesting experience. When I was working in Government Medical College, Calicut, we were talking about to the policy makers, about ministers, MLAs, and all. We were called to find out what is necessary for the next budget, how much money has to be spent on each project and all. Then we were telling our MLA in that local area, we want ventilators. He was telling, ventilators? Why you want so many ventilators? Everywhere there is ventilators. I said, sir, this ventilator is not needed for us. This is the building ventilator. We want ventilator to ventilate patients who are sick, very sick. This is used in ICU. See, sub what I said, sabai arinju peshe. You know your audience. That is very important. This I just shared with you. I don't want to tell the name of the minister or MLA and all those things, but it happened. I was there. That is why I just shared this to you. So whenever you write something, whenever you talk to somebody, you should talk according to the level of the people. We may be academically in this audience. Now I can use academic jargons. I can use big words. But when I'm teaching in an undergraduate class, I won't use this language. I will be talking to them according to their level. We want them to understand when we talk. The same way, when we go to the clinical field also, our nurses, most of our nurses may be diploma holders or degree holders only. They may not even have post graduation. So their level we must know. And one more thing I want to tell you. Now only in BSc nursing we have included research. uh, by 15 years or so, like that only, not more than that, or 20 maybe. Before that, there was not much research or project, combined project was there. And it was in certain states, it was optional also. So what happened is they don't know the research language and all. And ma'am has clearly told you how to publish. IMRD format has been explained very well. Once again, thank you. And please see that when you are writing, you follow IMRD format. At the same time, use simple language. Scopus Index journals also will publish your article even if you use simple language. Only thing that the methodology and things what they expect must be written in the proper way. Uh, Once again, I thank Dr. Shweta and Dr. Raman Kalia for giving a very good presentation on these topics. Thank you.
Thank you so much, ma'am. I now invite Dr. Asuma Bibi ma'am to kindly felicitate our resource persons with a memento and patka. I invite Dr. Shweta ma'am also to the dais. Thank you so much to both of our resource persons for your time and also our moderator, ma'am. So moving on to So we will now be proceeding to the scientific paper and poster presentations. We have three moderators for this session. Dr. Ashok Kumar sir from National Institute of Nursing Education, Chandigarh. Dr. Shatrughan Parekh sir from IRSH Bikaner, Rajasthan. And we have Dr. Anirudh Srivastava sir, Associate Professor from R&D Cell, Swami Vivekanand Subharti University. I request all our three moderators to kindly take their seats on the dais. We had first round of abstract presentation in our college, and after the round, we have 6 abstracts selected for the final round today. I would like to announce the result of the first round of abstract presentation. We have 6 papers selected. We have abstract selection of Ms. Sapna Patel, Ms. Binsha Papachansi, Ms. Melita Shelin, Ms. Reshma Kotian, Ms. Janet, and Ms. Parveen. We'll be having the same sequence in the presentation also. We have our first presenter, Ms. Sapna Patel. The rules and regulations will be the same what has been told to you for the first round of presentation. So kindly follow that. And we are starting with the first presentation by Ms. Sapna Patel.
Shall I start? So good evening to everyone. Today I'm going to present a research project on development of mobile application-based postnatal education program for new parents, which is a multi-phase study. I'm feeling proud to share that this is a TNAI funded project. The team, a research team consisting of myself, Dr. Anil Sharma, Dr. Pragna Dapi, and Ms. Jalpa Prajapati. Looking to the background of this study, postnatal period is a trying period for new parents because they have to adapt the demands of the parenthood, and sometimes it can lead to the self-doubt, anxiety disorders, and postpartum depression. If these needs are not fulfilled, so this adversely affect. WHO has reported that most of the maternal and infant death occurs during the postnatal period. However, the quality services during this time is largely neglected. Utilization of postnatal services is very less in India. And if I talk about the Gujarat, so Surat reported 50% of utilization, whereas Anand district reported 85% of the utilization. Studies also reported that mothers express great dissatisfaction with the quality of postnatal care. Looking to the importance of this period, various interventions like home visits, clinical visits, and telephone follow-ups have developed. And among everything, this mobile health related interventions are reported very good. And mobile health applications may also assist in addressing the workforce related challenges. So this technology is novel, it is convenient, widely accessible, and cost effective method to address this problem. So that is why we have developed the proposal and submitted to TNAI, and we got a fund for that. So basically this research is achieved by two objectives. In the first objective, we have developed the postnatal education program, and in the second objective, we have converted this program into the mobile health app. Now, this is a research methodology for two objectives. For the first objective, we have this is in total 3 different phases, and we have adapted the various research designs for that. And the second objective about the mobile health app. Now, in the phase 1, this is for the first objective where we have developed the postnatal education program. This firstly, we have used the exploratory qualitative research design to explore the perceptions of women about the postnatal education program. Here, we have recruited total 25 women with a purposive sampling, and this was conducted into the government like CHC as well as one private hospital, that is CHRF. Now, first of all, we have taken all the administrative permission, including IC as well as government permission. And finally, we conducted total 3 focus group discussion. And this were conducted into the hospitals itself in the private room, and it was lasted for average 45 minutes and conducted in the Gujarati language. We recorded it, and finally we used the thematic analysis based on Brown and Clark's 6-step framework. Then we received total 7 theme, and we merged with the literature review, and finally 107 topics were identified for the postnatal education program. Afterwards, we went for the validation. For the validation of this program, we have used email-based online Delphi technique. And here total 13 experts with the pervasive sampling technique were selected. The experts were from obstetrics and gynecology field, and total experience was about 10 years. And afterwards, like firstly, we have contacted all the experts through the telephone, and then upon agreement, we have presented the first draft of Delphi technique, and the experts were asked to give their opinion in the 3-point rating scale. 3 means important, 2 means unsure, and 1 means unimportant. And total 3 rounds of Delphi technique was conducted to reach the consensus of 80%. This is about the result and discussion part. So for the result and discussion part, this is for the first phase, the socio-demographic data of the postnatal woman. So 72.1% woman belongs to the age group of 18 to 22 years. 58% women completed secondary education. 72.1 41%, that is the majority of them, they were unemployed. Majority of them were family income about 10,000 to 15,000, and majority of them were received the health education or from their family members. Here we received total 3 themes, which included information about the maternal health, nutrition knowledge, postnatal period related problems and management, newborn care, social support, and family planning method. These findings were These findings were very similar to the previous studies. And finally, with this theme and literature review, we have identified the first draft of postnatal education program, which were included total 117 topics. Then for the validation of this program, 13 experts were recruited, and 84% experts were female, 16% were male, and they were having average 21 years of experience, and we recruited them from the various parts of India. This is about the Delphi round. So round 1, round 2, and round 3. In round 1, 117 items were presented to them. 90 topics reached to the consensus of 80%. And then during this time, 9 few more topics were suggested by the experts. And at the end of round 3, we selected total 89 topics, which were reached to the consensus of 80% and more. Now, finally, based on this postnatal education program, we have developed a mobile health app called as Ma Swasthya. This application was designed by the faculty and students of Master of Computer Application of Charosset University. This application was designed in Flutter, and this is for both Android as well as iOS. And if you will see, this is our eye-catching, informative, and beautiful mobile health application, Ma Swasthya, which is about the mother wellness after the pregnancy. So when we log in, it is available on the Play Store. When we'll just go with this. So first they will ask you the email ID, contact number, and few more questions. This application is on English, Hindi, and Gujarati. And you can see that these all are few of the features about the application. When you will click it, so you will see so many images, posters, videos about these topics. And we have also given a support chat. They can ask us the questions and we reply them in 24 hours time. There is a MaGem also. This is about the AI-based information which they receive. And we have also given our hospital contact detail for emergency. In future, we are going to check the effectiveness of this mobile health application. And just to conclude this my research project, postnatal care has significant role in decreasing the maternal mortality and morbidity. Our Ma Swasthya application will enhance the physical as well as psychological well-being for the first-time parents at the doorsteps. Thank you.
So very good presentation.
Thank you, sir.
So I think you told that in like implications you will use in future. So there is any study for this? You have to do study or planned you study for this or something?
Actually, sir, this project is divided into the two phases.
Two
In the
phases.
first phases, we have already developed the application. Now, in future, we are going to check the effectiveness of this application on utilization of postnatal services, parent self-efficacy as well as satisfaction,
Okay.
and definitely the health of the woman as well as their infants.
So you have done parent satisfaction in this? You have checked
No,
satisfaction?
we have not checked yet. Actually,
Okay.
this is the second phase
Second
of this project.
phase.
We
Okay.
have just developed the mobile health application with a scientific method.
Okay.
Yeah.
So you have used Delphi technique.
Yes. We
Okay.
have
So
used
can
the
you tell me like a difference between modified Delphi technique and Delphi technique?
Sir, here we have used the email-based Delphi technique, like the
Okay.
traditional Delphi technique.
There is no. Yeah. Go on.
The traditional Delphi technique is we were looking to, like, we have listened in the mornings, afternoon's presentation.
Yeah.
That this is about the experts are coming together and in the like face-to-face or anonymous. I mean, sometimes even they don't know their names of each other,
Yeah.
and they will reach to the consensus towards the agreement. Whereas here we have used the email-based Delphi techniques.
So they don't know each other?
No.
So
They
it
do
is
not
a
know
modified
the-
something like
exactly.
that. Okay.
They don't know each other. We have sent the email. First, we have contacted them. We have sent
Okay.
the email. Everything was like completely confidential. They were not at all knowing each other, sir.
So when you perform this study year 2000?
Sorry, sir.
In 2000?
We got approval of this project in 2022.
22.
And,
Okay.
22. And this study was performed in 2024, sir.
24.
The Delphi technique,
Yes.
yeah. it
So in
was-
introduction background, you have mentioned, I think, one reference that
Yeah.
in Gujarat, only 60% of the users are
yeah,
using
that
a
was,
smartphone.
ha.
So it is 2016, and you did this study in 2024.
Yeah.
And I think in 2024, around 90 or 95% users were
Yeah,
using
definitely,
something
sir,
like that.
definitely. Yes,
Okay,
yes.
so very good.
I have some basic questions.
Yes, sir.
How would you confirm that this type of study already someone has already done? Have you confirmed that?
Yes, sir. There are so many such, like when we started this project and when we did the review of literature, there were some different types of such studies were there. We have seen that many applications were based on for pregnancy, and we have also seen that few studies completed in the like Africa and US, Australia as well. And when we look to in Gujarat, so we did not get such studies in Gujarat. So if you will see the application, so it has a Gujarati language, Hindi as well as English, sir.
I think suggestions better to comparative studies be added here because you have focus on the Gujarat.
So at the same time, we have some unique features in our application, and this type of features we did not see in other applications. So if you will see the MaGem, this is a platform based on AI. So if a woman is asking a question, like for example, if the woman is asking about the postnatal diet, so from all the Google Gemini, they will catch all the information and you will see that it will reflect in the application. So this is how it is a unique compared to the previous studies.
It's a nice study, and basically this is a need of her. I want to just ask that you had mentioned in the phase first you have conducted 3 FZD.
3 focus group discussions.
Yes.
Sir.
So what was the sample size for that?
25, sir.
25. And
Yeah.
how you deal with the researcher bias?
Sorry, sir.
How you deal with the researcher's bias?
For researcher bias, sir, like first of all, when we contacted the woman, like we have developed the semi-structured focus group guide, focus group discussion guide. And like when I conducted this focus group discussion, so like I already had only 4 questions, and based on the answers, I had like, it is a qualitative study, sir. So based on their answers, I asked the questions, I asked questions to them. And and there were no, like, we recorded everything and we translated, not any kind of like their language tone, nothing. It is just whatever answers they were giving, we recorded and we did the analysis of it.
So your responses were all in the Gujarati or in the mixed language?
It was in the Gujarati, sir.
So how you go for the translations of the Gujarati from English?
Sir, we did it like we did it from it was a team of 4 members. So first of all, I did, and it was again validated by the other team members. Then we went to the language translator, and he did, and again we revised. Like it was, we have HSS department in our university, so we took a help of them, and this is how they are the experts in English. So from Gujarati to English, we translated, and again from English to Gujarati, sir.
Basically, it is very hard to encourage the people to download the applications in their phone. So how you will encourage the mothers to download these applications and utilize these applications in their phone for their health purpose?
Sir, we have already like contacted so many hospitals because this study conducted to the CHCs as well as our own hospital. So we have already like informed many nurses. We talked to the medical officers as well, and we explained them about the importance of this particular mobile health app, and they are helping us to get download in various like in different participants. I mean different women. Thank you.
Thank you, Ms. Sapna. We have a second abstract presentation by Ms. Binsha Papachan.
A very good evening to all the moderators, dignitaries of the days, my fellow researchers and delegates of this national conference. A warm greetings from NRSI Nursing College, Mangalore, Karnataka. I am Dr. Binsha Papachan, Professor and Head of Department for Mental Health Nursing. I would like to present my study titled Beating the Clock, Exploring the Link Between Procrastination and Academic Success Among Nursing Undergraduates. Before starting my presentation, I would like you all to just reflect on a familiar scenario where we have postponed some of our tasks, not because we cannot do it, but because we thought we still had time. Even our students face the similar situations many times in their life. In the fast-paced world of nursing education, where deadlines are constant and expectations are very high, procrastination often becomes a silent academic enemy. A meta-analysis of 96 studies involving 55,477 participants revealed a modest negative correlation between procrastination and academic performance. When procrastination takes hold, it may hinder not only the academic progress, but also the development of professional accountability and time-sensitive clinical judgment skills that are vital in providing safe and effective patient care. Experiencing similar pattern of behavior in our own students motivated us to take this study. And today I will take you through the influence of academic procrastination on learning outcomes and how or why it is so important in academic success. Objectives of the study were to assess the level of procrastination among undergraduate nursing students, to evaluate the level of academic performance among undergraduate nursing students, to find the correlation between procrastination and academic performance among undergraduate nursing students, and to determine association between the level of procrastination and selected demographic variables, and to determine the association between academic performance and selected demographic variables. Methodology was a cross-sectional quantitative approach. The design was descriptive correlational research design. Research setting was NRSI Nursing College, Mangalore. Sample were undergraduate nursing students. Sample size was 104, and sampling technique was disproportionate stratified random sampling technique. Tools used were demographic performer, academic procrastination questionnaire, which was a standardized tool, and academic performance marks card, their marks card of the sessional exams. Inclusion criteria, undergraduate BSc nursing students from selected nursing college, students studying in the 3rd and 5th semesters of BSc nursing program, and both male and female students. Exclusion criteria, post-basic BSc nursing and GNM students. Results, out of 104, majority were female, that is almost 88.5% participants were females. Since it was a disproportionate stratified random sampling, we took 50% of participants from 3rd semester and the remaining 50% from 5th semester. Out of 104, majority, that is 95.2% were hostelites and 4.8 were day scholars. If you look at the academic procrastination score, the percentage distribution, we can see that 51.9% were having high levels of procrastination, whereas 37.5% were having moderate level of procrastination and 7.7% were having minimum levels of procrastination. And if you look at the mean range and standard deviation of procrastination score and academic performance, we can see that the range of procrastination score range between 37 to 138 with the mean score of 95.87 plus or minus 19.67. Academic performance range between 22 to 91% with a mean score of 54.60 plus or minus 15.05. The frequency and percentage distribution of academic performance shows 11.5% of the students got distinction, whereas 26% got first class, 37.5% got second class, and almost 25% of them failed in the first sessional examination. Relationship between procrastination score and academic performance, we can see that the correlation shows 0.04 p-value. So it was significantly negative correlation between procrastination and academic performance, which says when the procrastination scores goes high, the academic performance were going down. Association between procrastination and academic performance, we could not find any association with any of the selected demographic variables. To discuss the findings of the study revealed, more than half of them were having high percentage of procrastination, whereas 2.9% was having very high levels. Mean procrastination score was 95.87 plus or minus 19.67, representing 62.2% of the total possible score, indicating a moderate tendency towards procrastination among participants. And these findings are consistent with previous studies which reported moderate to high prevalence of academic procrastination among nursing and health science undergraduates. To conclude, the study found out a negative correlation between academic performance and the procrastination. So the results highlight the need for time management training, self-regulation, and motivational interventions to enhance academic performance among the students. Since procrastination can negatively influence academic success, clinical efficiency, and professional accountability, addressing it early in the nursing curriculum is very essential. Acknowledgement, my sincere gratitude to principal and management of NRSI Nursing College for allowing us to do the study. And my heartfelt thanks to all the undergraduate students who participated in the study. And there is no conflict of interest. This is the reference. Thank you.
Very good presentation. So you have done exploring the link between procrastination and academic performance or success. Okay, so very nice presentation. So I have one two query related to this. You have taken sample size 104. So why 104?
That was the sample size because we have 4 years. So first year BSc nursing students we excluded because there could be some other extraneous variables that will be affecting them.
Okay.
And 4th years were having they were not available, like half of them were in the internship. So we excluded both first year and 4th year.
Okay.
So we had only 2nd years and 3rd years. So
only 2nd year and 3rd year.
Yes. So in that 3rd and 5th semester students we took. Okay. They were in 3rd and 5th sem during the time of
3rd and 5th. So have you calculated sample size for this?
Yes, yes.
Sample size
depending
calculation.
Upon the total sample size of the course, BSc nursing course.
Okay, total, you have taken total.
No. Based upon that, when we calculated, we got this percentage.
Okay, and like sampling technique, you have used disproportionate something like that. So how you did this?
Disproportionate means we take the same proportion from all the batch, like whomever is, how many stratas we have. So our two classes, like that is third and fifth sem,
Yes.
equal proportion should be selected for the study.
So it is not disproportionate. It is proportionate.
Sorry, not equal proportion. It is
proportionate.
same number. It is disproportion
Yes,
actually. Sorry,
it's
I
a
made a
proportionate,
mistake.
not disproportionate.
Same number we are selecting, not the proportion. It's not proportionate to the total number. We represented equal number in each, no, from both the batches.
Okay. So in socio-demographic variable, what you have included? Socio-demographic
Include much
variables.
only from where they are staying, which
Okay.
year, and their age and sex. That's all.
Okay, like socio-economic status.
We
And
didn't include, assuming that it may not have an influence on
how can you say that? Other studies are saying that like
could be.
socio-economic
Maybe
status.
we could have added. We could have added that.
Yes. Okay. Thank you.
Please open the discussion section.
Which one?
You have a good presentation, but I have some query in a discussion part.
Discussion.
Yeah. There. These finding is consistent of previous study for BMC Nursing 2024 and MDPI. Why you are using only two publishers? You have using only two publishers.
No, because there is like limited slides, we just put this one, just one.
No. You are mentioning because previous study only for two publishers. You have to use some more good publishers.
No, in the actual study we have more studies. Because for the presentation sake, I just took one or two important ones from there.
Okay, thank you. I have a call.
Basically, it's a nice study, man. What is the next after that study? What is the utilization and implications of this study?
The students don't understand how this procrastination is affecting their learning outcome. So it is very important from the first year onwards, we have to give them this time management sessions or know how this procrastination can hinder their learning outcomes. So as a teacher, we have to make them aware that procrastination is playing a very important role in the learning outcome and how to handle it by giving awareness sessions or training, even monitoring them when and where. Like we have strong mentorship programs, so the mentors also keep a track of their academic performance and know whether if anything is required, we take it seriously. Then and there we manage it. So that is the recommendation of the study, that it has to be trained for the student from the beginning onwards.
And your two objectives were association between the socio-demographic variables and the level of the two variables. But you says that no demographic tables was there, so it is a little bit confusing that which variables are literally you have included in your studies, which may affect the level of academic performance.
Because maybe it was our mistake that we assumed that it may not have a role. If we had included, we could have found out some kind of association. We could have checked for the association with that.
But if, ma'am, there is an objective, you definitely go with it. Because this is part of your study. This is not assumption.
We did try to find association, but we couldn't get association.
Okay, ma'am. Thank you.
There was no association found. Thank you.
Thank you. We'll have our next abstract presentation by Ms. Melita Schelling.
Good evening, all the respected moderators and the judges, and all the dignitaries in the audience, and also the researchers over here. I'll be presenting on the topic Enabling Youth for Prompt Action in Cardiac Emergencies, which I have abbreviated it as PACE, an evaluative approach. To introduce the topic, worldwide out-of-hospital cardiac arrest is a serious public health issue and is a major cause of death. For individuals experiencing cardiac arrest, the timely CPR intervention is crucial to increase their chances of survival both within and outside of the hospital. Teaching CPR to the teenagers enrolled in schools has been a successful strategy to raise OHCA survival rates and enhance CPR rates. Additionally, students who receive CPR training can act as CPR multipliers by teaching their friends and family members the skills and knowledge they have learned. Therefore, introducing these life-saving skills at places of employment and education would be extremely advantageous. With this brief background, the aim of the study was to empower or equip young people with awareness and skills required to respond quickly and effectively during cardiac emergencies. And the objective of the study was to find the effectiveness of the simulated training program on awareness on emergency response to cardiac arrest and skill in performing CPR among the trainers of official youth organizations. The research methodology goes like this. The research approach was quantitative research approach. The research design was quasi-experimental single-group interrupted time series design. The population were the trainers of official youth organizations in selected pre-university colleges of Udupi district. The sample are the trainers of NSS, NCC and the Red Cross units of various pre-university colleges of Udupi district. The sample size, it was 40 for this study considering the enumerative sampling technique, enumerative, and the sampling and the setting was selected pre-university colleges of Udupi district. And the variables were, the dependent variables were awareness on emergency response to cardiac arrest and skill in performing CPR. Independent variable was the simulated training program on emergency response to cardiac arrest. And the socio-demographic variables were the trainer's age, gender, their history of witnessing cardiac arrest, and their experience of giving chest compression previously, and the previous training if they had undergone any on CPR. The data collection tools used were demographic proforma, and tool 2 was structured awareness questionnaire on emergency response to cardiac arrest. Tool 3 was checklist to assess the skill in performing out-of-hospital cardiac arrest. All were prepared by the researchers. Data analysis, it was done using descriptive and inferential statistics. Descriptive statistics used were mean, standard deviation and frequency, and inferential statistics used was single group repeated measures ANOVA because it was a single group interrupted time series design. And the ethical considerations used in the study was the head of the institution. From there, the permission was obtained, and then deputy director of the university education, Udupi district, Karnataka. The permission was obtained to conduct the study in the various colleges of Udupi district, as well as to get the list of colleges wherever they had the NSS, NCC, and the Red Cross units. And the institutional ethical committee approval was obtained. The study was registered in Clinical Trial Registry of India, and also the informed consent was obtained from the participants. And before the data collection, the participant information sheet was given, and about the study, it was briefed to the participants. The schematic representation of the study design was, it was a non-randomized study, and the baseline measurements were taken at 3 intervals, at baseline, and then at 1 month and at 2 months. At second month, when the pre-assessment was done, after the pre-assessment, the training was given, and soon after the training, the first post-assessment was done. And at 3 months and 4 months, again, the 2 other post-assessments were taken. So there were 3 pre-assessments, and in between there was an intervention, and then 3 post-assessments. And the tools were validated by giving it to the 7 experts, and 2 were from the emergency medicine department, 2 were from the critical care medicine department, and 2 from the community health nursing department, and 3 from the medical surgical nursing department. And the scale content validity index obtained for all the 3 scales were 0.97, 0.86, and 0.96 respectively. And the reliability of the tools were established. For the second tool, that was structured awareness questionnaire, the reliability was established using split half method, and it came to 0.80, and it was done among 20 teachers from one of the PU college in Udupi district. And inter-rater reliability was done for assessing the reliability of the skill checklist, and it was done among 20 BSc nursing students from our college, and then it was done using having two raters and inter-rater reliability was carried out, and both the tools were found to be reliable. And the tools were pre-tested, and later the pilot study was done. Then the conceptual framework used in the study was based on the seed and soil model, which was proposed by Stephen Paget in 1889. Here the seed refers to the teachers or the trainers, what I referred in this study as. So they were given their baseline assessment on the knowledge and the skill in performing CPR was assessed, and they were given the simulated training. What we see in the center is a student and a teacher. So here in this study, I'm presenting part of the study. This study is funded by NRSI as part of the FNRS 2024. And this was a second phase. So what I have shown here is a student and a teacher, whereas the phase one also can go with this approach, because a trainer who is taught about this can also train many more, and they can become the catalyst in their particular organization to and empower many more in the institution. And so that was the soil. Soil requires the educational environment and the institutional policy support and the community support. And the growth is like, by having this, continued participatory learning approach, many more can be trained. And so that's how the educational institutions can be, the entire institution can get empowered, so that any emergency in those settings, there will be people who to take care of the needy, and then they will be of help to save someone in need. And the results of the study were projected here, and the sample characteristics, the mean age of the participants was 38.55 with a standard deviation of 7.76, and the majority were females, 75%, and then about 26%, 26, that is 65% of them said that they have heard about cardiac arrest, but none of them had history of witnessing any cardiac arrest previously, and also history of giving chest compressions in the past. And among those trainers, about few of them said that they had previous training on CPR. When I asked, so that data I have not put here, but they said it was conducted as part of the fire rescue program. And to find the effectiveness of the program, the single group repeated measures ANOVA was conducted. So this result showed that the F value was significant at less than 0.01. So the study was, the intervention was found to be effective, and also we can see the increasing trend in the mean scores at the three, after the baseline, the two pre-assessments as well as the three post-assessments. Even the repeated measure ANOVA, which was done to assess the effectiveness of the program on the skill, also showed that the F value was significant at less than 0.01. And this is a profile plot which is showing the increase in the main scores, but whereas in this knowledge score, awareness score, if we see, the pre-test done at second month and also the immediate post-test, which was done soon after the training program, there was not much of difference, but there was increase in the trend in the mean scores of the knowledge at the third month and the fourth month, whereas we can see the continued increase in the mean scores in the skill. And these were the activities which were carried out. And the poster, what we see in the first is the poster which I have prepared and given it to all the colleges where the program was conducted. And it was done in both English and Kannada. And those are the remedial measures, two photos, because those who had not attained the skill 100%, 12 of them were there. They were given remedial measures, because when we say that somebody is taught about CPR, it is not something which is a training like any other training. So ultimately they should be having a 100% skill, so that in emergencies, so they should be of fully helpful to that in that situation, not having 50% or 80% or even 90% of the skill. So that's where remedial measures were given, and that in between what we see is one of the school where I have conducted the program. They have published it in the local newspaper, and later on there were many requests in different schools where I have conducted the program to give a program to the entire batch of students, which I have conducted as part of the study. To discuss, the study significantly improved CPR awareness and the skills among trainers, aligning the findings with the studies conducted by Bond and Grief. And the simulation-based participatory learning enhanced both cognitive and the psychomotor performance, which was supported by the study conducted by Mioto and Normal et al. And sustained improvements reflect reinforcement effects shown by the study conducted by Sterne et al. And the Plant et al. In conclusion, the study supports the WHO and the AHA recommendations for school-based CPR education to strengthen the community emergency response. Also, the integration of CPR training aligns with the National Education Policy of 2020, which emphasizes skill-based learning and health literacy. So these were the references, and I acknowledge the funding provided by NRSI for conducting this project. Thank you.
very well presentation.
Thank you, sir.
So I want to ask about your research design that you have like use this baseline 1 month pre, 2 month pre, I think post.
Yes, sir.
So third time pre, then intervention, then third times post.
Second month, the third pre-assessment,
Yeah.
and soon after that the training was given, and then soon after that the first post-assessment was taken.
Yes.
And then the second two other post-assessments were taken immediately after a month, so that is at the third month, and the last post-assessment was at fourth month.
Yes.
So
what is the need of 3 times pre in this? You can take only baseline, then give intervention, and after this intervention, you can take third, 2 and 3 post.
yes, sir.
So why you took 3 pre?
Yes, sir. Thank you for the question. So there is an added advantage in using this design, because when we do the repeat assessments, because we might take the program at once, because this program held at their respective colleges, because initial plan was to call all of them to our single simulation center at Mahe, but it was not feasible because they are from different places, and all of them to gather at once, all trainers, it was difficult. So I had to reach out to there. And program, once it is given, and when we give it repeatedly, the same question as the retention of knowledge will be better, so that by responding to the, because ultimate purpose of this study was to empower someone to be ready to handle some emergency situation. So with my one training, it may not be making that impact, which may not be that impactful. So by giving them the repeated questionnaires, because the same questionnaires were repeated, so answering to the same questionnaire, so there was a.
So why only 3? You can take 5 times, it will be better.
Yes,
so why
sir.
only 3?
So I have limited it to 3 with the time constraint of, because it was in a 1-year project.
But
So
I think as per standard, we took like baseline, then give intervention, and then we can take post test 1, 2, 3 times. According to this, okay, it's very good. But you have taken sample size of?
It was an enumerative sampling.
Sample size?
40 I have taken.
40,
so
because you have taken grant from NRSI and you have taken just only 40 samples. I think you should take more samples for this. It's a like skills improvement study, operational type of study.
Yes,
so you
sir.
take this. I think the sample size is very low.
Because I went with only those trainers of the NCC, NSS, and the Red Cross units. So later on, I'm definitely wanting to write it for a larger funding, so that though there were challenges, but I took it as, it is close to my heart, because I felt training those people, it really made me feel good that, I could train some community people, so that, because we see these days the cardiac emergencies happen every.
Yes, it's
yeah,
going
so
on.
there should be a trained people. So that made me feel that, I should not stop it here. I should write for further funding, and I'll definitely try to do that.
Okay, you will do after this
Yes, definitely,
study.
sir.
Okay.
Yes.
So you have like given like repeated measures ANOVA.
Yes.
So can you show this that slide? Here. Okay. Yeah. So what is NP square? What is it?
That is eta square, the effect size, because these participants are not from the same place. So they come from different places.
Okay.
So what the samples effect size shows that.
So it is very less effect size, 0.087. It's very less.
Yes,
Your
maybe
results are significant, you can see.
Yes.
Okay, but it's very less effect size.
Maybe
So
because of the lesser sample size. So when I do it as a large scale study, I may definitely find it.
Yeah, because there is like the effect size is, you can see baseline is 9.95 and in format that is 5.77 and the p value is highly significant.
Yes.
So effect size should be like very large, but it's like related to mainly your power of study. It's a power is more than 80, or this is 87% of the power of study.
Yeah.
So it should be, if you are like telling effect size, it should be high. Okay.
Okay.
So this is according to, and main thing is the sample size you told is it is very less, 40. So you have to improve this sample size.
Definitely.
Okay. Thank you.
Thank you, sir.
Nice presentation, ma'am.
Thank you, sir.
Actually, I have some basic questions. You choose this title. This research work already be done and lots of work already be done.
Yes.
So from your study, what new outcome has come?
Yes, sir, definitely. The last study, when I did the review of literature, I found in Bangalore there was a study which was conducted among 4,000 odd students training. But then only difference what makes with this is I have taken this interrupted time series design. So that design wise, I can make a difference. And also, it was published in 2024, that paper. But there are no recent studies where the trainers of the professional organizations, and then through them actually the second phase of the study was teach one, each one teach one technique, because each of these trainers whom I have trained, they are supposed to teach, they did that one students, and that analysis is not being projected here. So it is like the trainers teaching the core group members, so they had the option of selecting anyone who is good at. So those trained core group members will train further more students in their institution, so like that. So it was a participatory approach. So I have done only the part presentation of the project here.
Okay, ma'am. Actually, I have seen your discussion part. You have your references is very around 5 year old. Okay.
Yes.
And I think this is the last year your project has I think finished. I think.
Yes, sir. Last October.
So why did you publish this one?
No, not yet.
Not yet.
Not yet.
Actually,
just submitted the report, final report.
Okay. No problem. Thank you.
It's a nice presentation, ma'am, but I have some queries. The Red Cross people you have selected, because the Red Cross trainers go for the first aid training, and the CPR training is a part of the first aid training. So why the persons who are from the Red Cross Society you have selected?
No, it having trained by the Red Cross. So there are now updates in the CPR as per the 2020 guidelines, HA guidelines, and also those skills may not remain. So like those trainers, they wanted, and none of them have reported that they have got trained, and hardly I have got people who were the trainers of Red Cross. I could get many from the NCC and the NSS, and even the list what I have got from our DDPU office. But actually, when I inquired, there are actually 38 colleges. When I inquired, they said it has been, we don't run anymore these professional organizations. So finally, I landed up inquiring going in person to the colleges where they actually had these associations, and none of them have verbally reported that they have got the training, and even if they had got it, it's long ago, so they wanted to have a fresh training got from.
So you randomly selected the samples?
Pardon, sir?
Randomization was done in the sample selection?
No, sir. It was enumerative sampling wherever there were these units. So those trainers.
But you mentioned in your design that it was a quasi-experimental design.
Yes, sir. Because it was the same group which is followed up.
But ma'am, you are mentioning the quasi, but randomization was not there and only single group was there. So it's just like a pre-experimental design rather than the quasi-experimental?
It was a NR, non-randomized. It was non-randomized, sir.
And we have the three qualities in the true experimental study: randomization, and then the control group, and then the intervention. So you have the intervention, but you have no control group, and you have no randomization. So can you say that it is a quasi-experimental study?
I think the better one would be like.
You mentioned quasi-experimental.
Yeah, I have mentioned it as quasi-experimental. It is like the same group followed up, but it is single group. Maybe I can say it as a better way, the single group interrupted time series design.
Yes, ma'am. And ma'am, another thing is that how you assess the practices of the participants?
Yes, sir. So I have carried the CPR mannequin whenever I went for even the baseline and all other assessments. Whenever I went to those colleges, I've carried the CPR mannequin from our college, and then I made individually each one to perform the skill on that.
It's basically OSCE based assessment was that.
With the checklist, I have assessed how they were performed.
Thank you, ma'am. Thank you.
Thank you.
Thank you. We are moving to our next presentation by Ms. Reshma Kutian.
please. Good evening, all. I'm here to present my scoping review titled Ultra-Processed Food Consumption and its Association with Weight Gain, Obesity and Dyslipidemia Among Adults. So the content is arranged in the order like introduction, objectives, methodology, results, as well as discussion. So the global food consumption pattern has shifted its trend towards ready-to-eat foods. The traditional diets are rapidly being replaced by packaged ultra-processed foods. UPFs are convenient, tasty, and affordable, but high in sugar, unhealthy fat, and salt, and low in vitamin, minerals, and fiber. UPF makes life easier. The increasing consumption has raised serious health concerns. Also, the government of India has planned for Fit India as well as Eat Right India, where they have a slogan called as Thoda Kham Karo, that is related to the consumption of sugar, salt, as well as ultra-processed foods. So based on this, the scoping review objective is to systematically map the existing literature on ultra-processed food consumption and its impact on weight gain, obesity, and dyslipidemia. So the methodology followed for this scoping review include the framework uses ASCII and O'Malley framework, that is for the guidelines of the systematic scoping review, and Prisma SCR is used for reporting the scoping review. The database is searched up PubMed, Sinhal Ultimate, Embase, Elsevier, Web of Science, and Scopus. The keywords used here are ultra-processed food, weight gain, obesity, and dyslipidemia. The inclusion criteria was decided by the study authors. The primary studies conducted among adult human population, which reported consumption of ultra-processed food by NOVA category of classification, that is group 4, which says ultra-processed food, and at least one outcome of the study, it should include weight gain, obesity, or dyslipidemia, and studies published in English language until September 2025 has been included. The exclusion criteria of scoping review, studies published in the terms such as sugar, salt, or rich in fat are not considered. It should be mentioned as ultra-processed food, as well as the reviews and case studies and all are being excluded. The studies conducted among pregnant women, cancer patients are also being excluded. So this is the selection of sources of evidence, that is Prisma flowchart. So we have identified 6,744 articles on the different databases, and further these articles were imported to Ryan software. In the Ryan software, the duplicates were removed. After duplicates removal, we had 3,640 studies, and among which 3,576 articles were excluded after title and abstract screening. Title and abstract screening was done by 2 authors. Conflicts were resolved by the 3rd author. The full text article assessed for eligibility was 64. Data extraction was done for the 64 articles by the 2 authors. The full text article again excluded is 37, where it was a wrong population, the wrong outcome, full text was not available, other language, wrong publication type, and some studies were repeated. Finally, the final scoping review included synthesis of total 27 articles. So the result of the scoping review says that there were total 19 cross-sectional studies, 3 prospective cohort studies, 3 experimental studies, and 1 longitudinal cohort study. The longitudinal cohort study, 1 study was conducted of a child from 7 years of age, and it was continued up till 24 years of age of the child. And only 3 experimental studies were identified through this search. The geographical distribution of the studies, if we see, majority of the studies were conducted in UK, Canada, then Australia. Studies were also conducted in, 1 study is being conducted in India using NOVA classification. The total population included were adults aged more than 18. Total sample included for the study after the final retrieval is 3,05,704 articles. 704 total sample, sorry. So the UPF intake as reported by total energy intake, if we see grams per day, it is more among the studies that has been conducted in UK, USA, Canada, Saudi Arabia. In India, we had only 1 study that was conducted in Bangalore, and it reported minimal consumption of UPF. So the table 2 will tell us the association of UPF consumption on specific outcomes. That is, we had an outcome on weight gain, obesity, and dyslipidemia. 2 studies have identified that the weight gain had a positive association among UPF consumption, and 22 studies reported that UPF consumption has a positive association with obesity, and one study reported that there is negative association. UPF consumption is not associated with obesity. And among the studies conducted, among the 22 studies, two studies reported that among men, there was a positive association between UPF consumption as well as obesity, but women's did not had positive association of UPF consumption and obesity. When considering dyslipidemia, we have identified 4 studies narrating the positive association for UPF consumption on dyslipidemia. So the discussion and conclusion, that scoping review consisted of 27 studies across diverse populations and countries. Higher consumption of ultra-processed food is positively associated with adverse health outcomes. Obesity and adipose indicators like BMI, waist circumference, abdominal obesity, body fat percentage in most of the studies. It also identified that among obesity, abdominal fat was very prominent, abdominal obesity was very prominent among the participants. The cardiometabolic risk factors, particularly the dyslipidemia, that is elevated triglycerides, low HDL, was also identified in the longitudinal cohort studies. Null association was identified in only one study, that was a very small cross-sectional study with very less number of participant size. So the research gap identified in the scoping review is there were limited RCTs conducted to identify the association between UPF as well as the weight gain as well as the dyslipidemia, and there are very few longitudinal studies conducted. The UPF consumption is a significant dietary risk factors for obesity and metabolic syndrome globally. Public health strategies should prioritize reducing UPF intake and promoting minimally processed food. Thank you. These are my references.
Very good presentation. So you have mentioned this, it's a scoping review.
Yes.
I think it's a systematic review. You have used the Prisma.
No, we have not done the risk of bias as well as quality assessment of the studies.
No. It's not like necessary in systematic review. You have to use risk of bias and
but quality assessment of the studies are not being done, sir. I had 2 RCTs also here.
In systematic review, okay, in systematic review, if you are writing systematic review, no need of this risk of bias. Risk of bias and quality of like that is in coming in meta-analysis, not in systematic review. So you can do systematic review right now. Why you are calling it scoping review? It's a systematic review.
Sir, as per the guidelines what we have studied in our institution,
Yeah.
for systematic review, there should be quality appraisal, quality checks to be done. So that is the reason I have taken this as a scoping review. Yes.
No, that is like totally the systematic review. It's not a scoping review. You have like done everything you have done. Prisma you have made.
Yes, sir. This is Prisma SCR.
Yeah.
That is specifically for scoping reviews, sir.
No, it's like a systematic review. What is the difference between both? It's for systematic review. We are using systematic review. Yeah. Well, quality appraisal is for part of meta-analysis.
No, sir. It is not a part of meta-analysis. That is before meta-analysis. That is what I think.
No, quality is for like risk of bias, quality. It's coming after this meta-analysis, not before. So that is. Anybody else want to say? Because we need. No, ma'am.
Sir, all systematic review will not go for meta-analysis.
No, I know that.
Yeah.
All systematic review. So it's a systematic review.
Yeah.
So it's a systematic review. No need of go for meta-analysis. You can do systematic review. There is no problem.
No, I have not done the quality appraisal of the studies. Yeah.
Because quality appraisal we need for that. Quality appraisal we need for mainly meta-analysis, not for systematic review. So it's like you can go for this systematic review. It's very good. You have done all the things. These are the steps you have followed for which we are following for systematic review.
Yes.
Yeah. Okay. Thank you.
Yes.
It's a nice study, ma'am. What will be the significance of this outcome of the scoping review?
The significant outcome says that as we have a slogan, that is what I mentioned in the before, sir. Eat right India. Okay. So the UPF consumption is increasing day by day. So the overall thing I had to assess was what is the association of this UPF consumption towards the dyslipidemia and obesity, because obesity is a major risk factor in the current days, what we have seen. So finally, what I've identified the gap in this scoping review is there are limited RCTs that is being conducted in this area to really tell us whether this UPF consumption is really associated with obesity as well as the dyslipidemia. And we also can see there are very limited studies, only 4 studies I could get suggesting the association between UPF consumption as well as dyslipidemia. The thing is that there are very limited studies pertaining to this topic, sir.
Thank you.
Thank you.
Thank you. We have our next presentation by Janet.
Good evening to all. My title is Effectiveness of a Multifaceted Lifestyle Intervention on Risk Factors for Coronary Artery Disease Among Perimenopausal Women. Women face unique risk related to hormonal changes, particularly reduced estrogen during perimenopause, which significantly elevates CAD risk. The early detection and management of CAD risk factors, particularly during perimenopause, are vital for effective screening and prevention. So, a perceived lack of control and psychological barriers prevent many women from adopting healthier habits even when they are aware of the health risk. So, this study focuses on multifaceted lifestyle intervention, MLI, which includes raising awareness on CAD, raising awareness on dietary recommendations, performing physical exercise, stress relieving measures, and finally providing counseling, which is called as empty chair technique. Novel measure is just a form of counseling for perimenopausal women. The living literature shows population gap, methodological gaps, and because many studies are not consistently done in this group, especially related to cardiovascular knowledge. And most evidence comes from Western countries with fewer studies focusing on South Asian context, despite having higher cardiovascular risk. And research on empty chair counseling technique is done only on adolescents in the area of anxiety, grief, and not in the particular older adults. Objectives of the study. First one, to identify the pre-test risk factors for CAD among perimenopausal women. Second, to evaluate the effectiveness of MLI on prevention of risk factors of CAD. Hypothesis, there is a significant difference in mean scores of risk factors of CAD among perimenopausal women between the intervention and control group. And the sub-hypotheses are, there's a significant difference in biochemical risk factors, H1B is biophysiological risk factors, and HC is lifestyle risk factors. Methodology, research approach is quantitative, setting is a tertiary medical college hospital, and the sample is perimenopausal women who are non-healthcare employees. And the design is quasi-experimental, pre-test, post-test, control group design, and sampling technique is random sampling with random assignment to intervention and control group, and the sample size is 46 in each group. And as I said, MLI includes various components: health knowledge, dietary recommendation, one-time performance of physical exercise during their duty hours, and also providing counseling, because usually we see that the women are aware of the health risk and they are aware of the health promoting behavior, as I saw in the knowledge assessment. But incorporation to daily routine is very low. So I promoted this using novel measures, as the empty chair counseling technique, which is a simple use of two-chair technique, and a chair is kept in front of the participant, and the participant is, and there is a dialogue between the personal self and the healthier self. And the investigator is called facilitator, who allows and the focus area could be stress or the physical activity or the diet. So one is taken as per their interest, and the participant herself brings the novel idea to incorporate this into her daily routines. That is what is the empty chair counseling technique. And the sampling criteria, perimenopausal women in the age group of 45 to 55 years were included, and those who contraindicated to perform physical exercise and suffering from CAD and cardiovascular diseases were excluded. Ethical considerations and administrative permissions were taken. Result shows that most of them belong to 45 to 49 years of age group, completed primary or the high school education in both the group, belong to Hindu religion, and were from urban and the rural area, and all of them had an income less than 25,000, and they taken mixed diet, and very few of them had a family history of diabetes mellitus, hypertension, stroke, and dyslipidemia. And the health history showed some of them had a complicated pregnancy. None of them reported to use oral contraception. And very few had a current history of diabetes mellitus, hypertension, dyslipidemia. Sleep was disturbed in majority. And none of them reported to use, consume alcohol or smoked. And the distribution of study group based on the biochemical risk factors. So showed that majority, some small percentage of women were pre-diabetic, and less than 1/4 of the sample showed borderline high TC, total cholesterol, total triglycerides, and low HDL and high level of LDL in less than 1/4 of the sample. And the physiological risk factors showed few of the small percentage of women were pre-hypertensive, and the diastolic blood pressure was normal. Nearly half of them were overweight, and they were at possible risk with regard to waist circumference and waist hip ratio. And the lifestyle risk factors showed half of them performed low physical activity and or moderate physical activity as determined by the International Physical Activity Questionnaire, IPAC short form. And majority had a moderate stress as determined by the perceived stress scale, and less than half of them consumed unhealthy diet. And the effectiveness, this is a slide about comparison of post-test scores of biochemical risk factors to show the effectiveness by independent t-test. So it showed there was no significant in the biochemical risk factors even after the intervention, but there was a significant difference between the groups in terms of biophysiological risk factors, that is SBP, BMI, waist circumference, and waist hip ratio. Even there was a significant difference for lifestyle risk factors in terms of dietary habits, physical activity, and perceived stress. And the findings do align with the literature and other studies, whereas it shows that studies done by Isaac et al., Wang et al. Shows that the lifestyle intervention had significantly improved the risk factors of coronary artery disease. And of course, biochemical parameters were not significant in these studies too. The conclusion, so multifaceted lifestyle intervention combining education and the empty chair counseling technique improved the knowledge, which I have not shown here, as well as modifiable risk factors among perimenopausal women. There is a lack of supportive research using empty chair technique counseling in this age group and also in Indian context. And the study did not incorporate new biomarkers such as C-reactivity protein, etc. And I have used only the traditional method to assess the risk factors. I've done. These are my references.
Very good presentation. So you have mentioned in your tables that you used Fisher exact test
Yes.
And there are some you are using chi-square test.
Yes.
Can you show me?
Yes. That is to check
Yeah.
the homogeneity between the groups. That
Okay.
both the intervention and control groups were homogeneous, and where the cell value is less, there I use the Fisher exact test. Otherwise, I use the chi-square test.
Okay. So in like in some variables you have used the Fisher exact test. For example, this
Yes.
type of.
Yes, sir. There I have used.
No. Previous slide. Yeah. For this.
Yes.
No. Previous slide.
That's the first slide. Second
Yeah.
slide.
Here. Type of diet taken, mixed and vegetarian.
Yes, sir.
Okay. So here are like observed frequencies 3 and 2, something like that. In this. So instead of using this chi-square test, we have to go for Fisher exact test, because we have to calculate expected frequency, and expected frequency is less than 5.
Yes, sir.
So like majority of the time, if our observed frequency is 3 and 2, less than 5.
Yes, sir.
So expected frequency, okay, most of the time will be less than 5.
Yes,
so we
sir.
have to use for Fisher exact
Yes,
test
sir. Yes, sir.
instead
Yes,
of this.
yes,
Yeah,
sir.
okay.
Yes, sir.
Okay. Thank you.
Nice presenter, ma'am. Ma'am, actually, I have some basic question. Actually, I'm not from the nursing. Actually, so I'm from the drug delivery system. I have some question because whatever you result you have got, have you compared with the some reported studies? Means your result is consistent with the some.
Yes, sir. There are contradictory studies and supportive studies too. Some studies, especially long-term studies, have shown the difference in the biochemical parameters. But most of the studies also like same support my studies. There is no difference is seen in the biochemical parameters, whereas other all parameters there was a difference.
And what are the outcome of the study?
What's the
Outcome of the study?
So outcome of the studies, like especially non-healthcare, my participants are non-healthcare women employees who perform the work in sweeping and other low work, and they assume that lifestyle improvement is not required. They say those activities are enough, and they are not much. They do not give much importance to the health. And so in our university now, after this, we are planning to target these employees, non-healthcare employees, for the during the duty hours for promotion of health activities. Because most of them we can see overweight, obese, and very with the large waist circumference. That is what we see, and maybe could be because of the diet or low physical activity of only one routine activities. So I feel this intervention is very important in my university, and also in public also it is very important to implement.
Nice study, ma'am. Ma'am, in your inclusion exclusion criteria, the women who are receiving the hormonal therapy,
yes, sir.
So have you excluded that woman from your study, or you have included?
Women receiving hormonal therapy are excluded, sir, because they must be already getting the enough guidance, and I don't think my method will help. There will be bias. A homogeneity may not be there if I include them.
And another thing is because overall we consider that the metabolic syndromes are very prominent in the age of plus 40 in the women's.
Yes, sir.
So how you decide that the woman is not having the metabolic syndrome, and you will include the woman in your study?
I understand that perimenopausal age group where the estrogen level declines, and definitely the bodily changes may not allow to they may increase the risk of CAD, development of plaque and all those. That is why the preventive measure should start much early. So I do agree. That is why maybe I have not got the changes in the biochemical parameters. So these other all lifestyle and such which are subjective, I have got the significance.
Okay.
Maybe
Thank
because
you,
of that.
Okay, thank you, ma'am.
Yes.
Thank you. We have our last paper abstract presentation by Ms. Parveen.
Good evening, everyone. This is a meta-analysis. The title of this meta-analysis is Impact of Nurse-Led Palliative Care Intervention on Symptom Burden and Quality of Life in Cancer Patient, a Systematic Review and Meta-Analysis. Cancer is a major global health issue with increasing incidence and mortality. Palliative care with specific aim to palliation of symptom and end-of-life care strive to improve quality of life by addressing physical, emotional, and spiritual needs of the patient. Nurse-led models, which are very popular nowadays, are recognized for improving accessibility, continuity, and holistic patient care support. Uh, so with this, we have two objectives. One, the primary one is to evaluate the impact of nurse-led palliative care intervention on quality of life and symptom burden among cancer patients, and the secondary was to assess the correlation between quality of life and symptom burden among cancer patients. In methodology, this is an systematic review and meta-analysis, and we have taken 3 RCTs and one quasi-experimental study which has been conducted between 2015 and 25. The reason behind to take this specific time period was because at this time only the palliative care was more popular, and even nurse-led interventions are also popular in that period. Only we hardly find any cities before that period. That's why we took that period only. In inclusion criteria, as I told, RCTs or the interventional studies we have taken, and and it was, if it was done on adult patient more than 18 years with advanced disease condition receiving palliative care, primarily led by nurses, and had a comparator group as a standard routine care or the physician-led care group. Databases search for this was PubMed, Sinhal, Embase, Cochrane, Central Psychoinfo, and Gray literature with the keywords like nurse-led palliative care, the quality of life, symptom burden, or the interventional studies. The outcome variables were the quality of life and symptom burden. Both the variables in the RCTs or in the interventional studies, these variables has been assessed with the standardized tool like quality of life EOR, TCQ, LQ30, and FACG tool was used, and for symptom burden SAS tool was used in all the studies. Analysis for analysis HG with random effect model was assessed, and sensitivity analysis for study design, as I have included the quasi experimental study was done. Prisma flow chart I have not included because we have paucity of time, but the main through, like we have gone through almost more than 100 studies, and after selecting or as per our inclusion exclusion criteria and the objective, we have only 4 studies which were 3 RCTs and 1 quasi experimental. And the total sample size in these study was the 930. There are two forest plot here. You can see there is no marker here. Na? In left-sided forest plot, you can see that three RCTs. The lower one are the RCTs, and the upper one is quasi-experimental. Here, the mean difference has been depicted, and here you can see that this is the standard zero line, and in the right side of we have most of the results in the right side, which depict that with the nurse-led intervention, the effect size is better. And if we see the pooled effect of all these RCTs with HG, which is 0.31 with the p-value of 0.09 and heterogeneity of 86%. So we can here we can interpret that there was a moderate effect size of the nurse-led intervention on the quality of life of the patient. And simultaneously, we have right hand side, we have a forest plot for the sensitivity analysis, and here all the 3 RCTs has been taken, and here also we can see that the heterogeneity is fall down 51%, but here G is only 0.11 with the p-value of 0.12. Here also we have mild effect, though that is not that high, but still there is a better there is a mild positive result of nurse-led intervention on the quality of life of the patient. Similarly, effect of nurse-led intervention was seen on symptom burden. Here we have two RCTs and one quasi-experimental. In one RCT, symptom burden was not assessed, that's why that was excluded. And here also we can see that the results like mean difference in two studies is in minus. That is because if symptom burden will be there, then the quality of life patient will not be, quality of life will like symptom burden will be less than the quality of life will be better. Means there is a inverse proportion or inverse relation between that. That's why the mean difference is in negative side. But here the G value is very less. It is almost at the zero line only. Its G is almost minus 0.02, P 0.88 and heterogeneity of 75%. But when it was done on the RCTs, the heterogeneity will come at 0%, but G value is in a positive direction. G is 0.10 with P value of 0.31. That is also a mild effect of nurse-led intervention on the symptom burden of the patient. Similarly, the second aim was to find out correlation between symptom distress and quality of life. It comes with the R value of minus 0.77. Though I told ki there is an inverse relation between these two parameters. That's why it is minus with P value of 0.44. Certainty of evidence is being checked on the grade guidelines with the ROPE2 assessment tool. And in ROPE2 assessment tool, there are 5 domains which is being assessed, like randomization, whether blinding is done, randomization is done or not, deviation of intended intervention is done properly or not, missing data, how they have handled the missing data, measurement and the reporting. And based on these domains, the certainty of evidence will come in the low to moderate. So with this traffic light plot, we can find out this result. This is a funnel plot, which is basically look for the publication bias assessment, though it is not significant, though it should be done more than 10 studies, but we have only 4 studies and we went for this also. And here you can see that mean effect of all the studies is around that dash line only. So we can say that there are very less publication bias in the in the selection of the studies. We can conclude that nurse-led palliative care intervention show moderate to low non-significant intervention in quality of life and symptom burden, though statistically insignificant, but practically these things values very much. Evidence of certainty low to moderate as per grade framework. Nurse-led models are beneficial for holistic patient-centered care, especially in resource-limited settings like India, where we have very limited physician and a large number of nurses. And it is recommended that large multi-center RCTs are required for stronger evidence for such kind of studies. These are the references. Basically, these are the studies which we have included for the review. I acknowledge all the researchers and reviewers whose work contributed to this review. No conflict of interest is there. And this is Prospero certification is being taken for the study. So it is registered in Prospero. Thank you for this.
So nice presentation.
Thank you.
So I have one query. You have used like ROPE2 for scope bias assessment.
Yes, sir.
ROPE2 is only for RCT.
Yes,
so
sir.
you have one
Please,
non-RCT.
Please, sir, I have gone through this also. ROPE2 can be taken for interventional studies also. So mine was though it was quasi-experimental, but interventional study.
Yeah.
So
For quasi-experimental study,
interventional studies can be done.
interventional study, but it's not RCT.
Sir, that was quasi-experimental.
Quasi-experimental. So for quasi-experimental, we should use Robbins.
Sir, should be used, but since I have used...
I know that because you have only 4 studies, so you put
forest
here.
plot also that is depicting that things are...
No, you did sensitivity analysis.
Yes,
you
sir.
remove that and you perform.
Yes, sir,
It's very good.
Yes,
Yeah.
Yes,
But in like risk of bias, you should use only for RCT.
Yes.
Yeah. Okay. And you can mention in your limitation that there is only one non-experimental study or non-RCT study, quasi-experimental. So you cannot perform. Yeah. Robbins you can do Robbins for only one. There is no problem. Okay. Yeah. Thank you.
Thank you, sir.
Nice presented, ma'am.
Thank you, sir.
Actually, whenever we use and select a study, we require a good referencing, ma'am. I have seen you did not add the Web of Science and Scopus from your study. You use a database from the PubMed and all these things. But why you are not using a Scopus and the Web of Science? Because for this type of study, reviewing, we need a good we need a good referencing.
Sir,
Okay.
these are just to mention. I have like went through Google Scholar also, and there are like.
I understand, ma'am. But actually, whenever you plan, but referencing is very important. Whenever you send your paper for a publication, the editor used to see which references you have selected.
Okay, sir.
So
I'll
that
take care of
the
that.
Web of Science is the world most famous indexing, and you
Even
skip
most
there.
of the if they are PubMed they
that
are
is okay, ma'am.
Scopus affiliated also. So
It is advice to you, ma'am. Actually, it's not
Thank you,
just
sir.
okay. Ma'am. Thank you, ma'am.
It's a nice study, ma'am, and you have done a really extensive analysis of all that whole studies. Congratulations. Thank you.
Thank you, sir.
Thank you so much to all the presenters. We request our moderators, 3 moderators, to kindly evaluate the posters also, which are displayed outside the auditorium. I request